Good morning, everyone. I'm Christian John Lillis, the co-founder and chief executive officer of the Peggy Lillis Foundation, and I'm delighted to welcome you to PLF's first ever scientific symposium on C. diff. As you may know, my brother Liam and I, along with countless family members and friends, started the Peggy Lillis Foundation in response to our mother's death from a community-acquired C. diff infection in April of 2010. My mother was a kindergarten teacher and believed deeply that knowledge is power. I apologize. My mother was a kindergarten teacher and believed deeply that knowledge is power. Her belief has been an animating force behind our awareness and education work. Like my mother, I believe that the production and distribution of knowledge empower us all, whether we're C. diff patients, caregivers, scientists, doctors, or drug developers. Expanding and sharing knowledge about C. diff is vital to PLF's mission and a critical way to combat this terrible infection. When my mother became ill, I was utterly ignorant of C. diff. That lack of knowledge prevented us from making different decisions or acting more swiftly when she became sick. That's one of the reasons why I'm so pleased that we're hosting today's symposium. I'm also excited about the treatments and preventatives approved over the past 14 years. When my mother was ill, the only treatments available were vancomycin, IV immunoglobulin, and surgery. She received all of them, to no avail. While a few adventurous physicians were performing stool transplants, we didn't learn of them until after she was gone. Fecal microbiota transplant didn't capture the imagination until about 2 years after her death. Since then, the FDA approved a narrow-spectrum antibiotic for C. diff and 2 live biotherapeutics to repair the gut microbiome for people with recurrent C. diff. We have also progressed in diagnostics with new tests and C. diff added to broad stool panels. Physicians and laboratory technicians have developed algorithms to increase diagnostic accuracy. Pardon me. We also have a rather large pipeline of new treatments and preventatives. Today, you will learn about 8 products currently in development and hear updates on some that are currently in use. I cannot think of a time in the past 15 years when we have had this many C. diff products in development. It's an honor to showcase these brilliant and dedicated professionals working to make C. diff increasingly rare, treatable, and survivable. I want to thank our generous sponsors who have made today's symposium possible. Thanks first to Acurx Pharmaceuticals for being our platinum sponsor. Launching a new event can be nerve-wracking, so having Bob DeLucia and the Acurx team as our anchor sponsor was very reassuring. I want to thank our gold sponsors, Nestle Health Science and Recurrent. Thank you to our silver sponsors, Biotech USA, Tech Lab, and Vedanta Biosciences. Thanks to our bronze sponsors, AstraZeneca, Bactolife, Crestone, and Lumen Bioscience. With the support of our sponsors and all of your participation, we have registered over 400 people for today's symposium. We were hoping for 250, so we've wildly exceeded our own expectations. So with that said, now I'm happy to introduce our board member, Dr. Paul Feuerstadt. Paul approached me and the rest of the board to host this event earlier in the year. Since we already had 2 events planned for November, I was skeptical. However, Paul expressed how important it is to have a space for scientists, physicians, other HCPs, patients, and industry professionals to learn from each other. And apparently Paul was right, because I think we now have 415 people registered. People just keep registering. So thank you, Paul, for your passion and hard work to make our inaugural symposium successful. And I will turn it over to you. And of course, Paul's muted. We've been doing this all morning.
Yeah. Thank you so much, Christian. It's an absolute honor to be here. And I appreciate the reminder of what PLF is and why we're here today. It's an absolute delight to really be looking at the horizon and hearing about where we are from thought leaders and key opinion leaders, and where we're going from those leaders, and also from individual companies. We've made a lot of progress, but we have a lot of work to do. And I think this symposium is a wonderful chance for us to learn from each other, collaborate, make new connections, and move forward to help our patients. So without further ado, I want to introduce Bob DeLucia. Bob was a co-founder of AccuRx Pharmaceuticals and the executive chairman of AccuRx currently, a company that is studying an advanced antimicrobial for C. difficile called Ibezapolstat. Bob has an extensive experience in the pharmaceutical industry, including time at Pfizer, Sanofi, and other companies. We greatly appreciate Bob and AccuRx's generosity in being our platinum and anchor sponsor for today's symposium. Bob, take it away.
Paul, I appreciate it. And it's a real pleasure and an honor to give a few welcoming remarks to the Peggy Lewis Foundation inaugural scientific symposium, which AccuRx is very excited to sponsor, particularly with November being CDC designated as C. diff Awareness Month. You know, I think it's interesting to note that inaugural can also mean foundational, which I believe is a very appropriate alternate title, since today's program goes beyond PLF's early beginnings as a patient advocacy group to raise public awareness of C. diff, which it has done consistently over the years, but now is building a broader foundation by uniting researchers, clinicians, the medical community, along with all advocates, to share groundbreaking research findings, foster collaboration, and ultimately enhance C. diff patient outcomes. Collectively, I think these efforts have already begun to shape better U.S. public policy for the benefit of patients and the C. diff community as a whole, and should continue to do so. And I might add, ultimately, to contribute to better public health while reducing the public cost burden of C. diff infections worldwide. I'm very pleased to welcome today's presenters, many of whom AccuRx has the pleasure of working with, and all share a strong passion to drive forward our collective mission to pave the way for advances in the field. I think today's topics include something for everyone joining: the latest research findings in CDI, innovative treatments, and the importance of the microbiome in the treatment and reduction of CDI recurrence. Additionally, and very importantly, we'll hear from patients who've survived the C. diff infection, which can facilitate communication between researchers and the patient community, ensuring that research priorities align with patients' needs and concerns. So thank you all for participating today. And now, Paul, back to you to introduce our first speaker.
Thank you, Bob. Appreciate that wonderful introduction for the conference. So now I want to shift gears, and we're going to really start the active learning section of the conference. It's always best to define the gravity of the problem, and there's no better speaker to do this than Alice Gu. Alice is a medical epidemiologist working at the Centers for Disease Control and Prevention. She's an infectious disease trained physician doing her fellowship at the Albert Einstein College of Medicine Montefiore Medical Center in the Bronx, the same institution where I did my GI fellowship. Alice was the lead author of the most recent New England Journal of Medicine manuscript considering the epidemiology of C. difficile infection. And she was going to walk us through the gravity of the problem, what we're dealing with on a national scale. Alice, thank you so much for being here today.
Great. Thank you so much for the introduction. So as you've heard, my name is Alice Gu, and I'm from the CDC. And I just want to thank the Peggy Lewis Foundation for the opportunity to be here this morning to help define the problem of C. diff and to present the current epidemiology of C. diff in the United States. So let's see here. Okay, so I have no disclosures. So in the United States, we have two main surveillance systems for C. diff infection, or CDI. The first, I think many of you are familiar with, is the National Healthcare Safety Network, or NHSN. Since 2013, CMS has required all hospitals to report CDI to NHSN if they seek to receive reimbursement. And so from NHSN, we have national data on a risk-adjusted measure of hospital onset CDI, known as the CDI Standardized Infection Ratio, or SIR. However, only a portion of cases are hospitalized. And so to have a better understanding of the epidemiology of CDI in the US, we also utilize another surveillance system at CDC known as the Emerging Infections Program, or EIP, which you may be a little bit less familiar with. EIP conducts active laboratory and population-based surveillance for CDI in 10 states since 2011, specifically 35 counties across these 10 states. And so from EIP, we're able to capture all cases that are healthcare associated, including hospital onset, as well as community associated cases. And from a subset of these cases, we also receive C. diff isolates that we can perform molecular characterization. Because EIP is population-based and includes data from geographically diverse areas in the country, we've used EIP data to estimate the national burden of CDI and to monitor changes in strain prevalence over time. We started the last decade with the burden of CDI near its highest level. Using EIP data, we estimated that there were over 476,000 incident cases of CDI in the US in 2011, the majority of which, 306,500, were estimated to be healthcare associated, and approximately 170,000 were community associated cases. We also estimated that there were close to 85,000 first CDI recurrences in 2011. These were defined as a positive episode occurring within 2 to 8 weeks of the previous positive episode. We estimated 60,500 of these were healthcare-associated first recurrences, and an estimated 24,100 of these were community-associated first recurrences. CDI is also associated with significant morbidity and costs. It's been shown that recurrent CDI is associated with 2.5-fold higher hospital readmission rate, 4-fold longer hospital stay, and 33% higher mortality rate than primary CDI. And the attributable healthcare costs of CDI are also substantial. It's been estimated that for each recurrent CDI case, it can result in $10,850 of healthcare costs. And if you look at it in its totality, all hospital onset CDI cases, it's been estimated that can result in healthcare costs of about $1 billion annually. Since 2011, however, we have seen a decrease in the overall burden of CDI in the United States from 2011 to 2017. After adjusting for test type over time, we found that the national burden of CDI in the US decreased by 24% between 2011 and 2017. Nevertheless, as you can see, despite the decrease, there was still close to 450,000, ranging from that to 500,000 a year of cases a year. And then COVID-19 pandemic happened. And so how did that impact the incidence of CDI in the US? Well, surprisingly, most US studies of multi-center facilities, including many hospitals, reported that there was either no change or decrease in healthcare-associated or hospital onset CDI rates. For example, among a study of 148 HCA healthcare-affiliated hospitals, CDI was not significantly associated with COVID-19. In another large study, this including VA facilities, both acute care and long-term care facilities, it was shown that CDI rates significantly decreased during the pandemic compared to pre-pandemic era. However, for some of the facilities in the study, the diagnostic testing strategy had changed during the pandemic period, which may have contributed to the lower rates as well. In addition, when we look at NHSN data, the national CDI SIR significantly decreased in all quarters of 2020 compared to 2019, with an overall decrease of 11% between 2019 and 2020. And if we look a little bit closer at NHSN data, this figure shows the total number of hospitalized community onset cases, the total number of hospital onset cases reported to NHSN each year from the rebaseline year 2015 through 2022. And you can see that the overall pattern shows a decline each year through the first year of the pandemic, and then has sort of leveled off, resulting in a 57% decline in the number of hospitalized cases reported to NHSM between 2015 and 2022. And then we look at the national CDI SRR over this time period, we found that there was a significant decrease of 52% between 2015 and 2022. And this decreasing pattern is corroborated by data from the Emerging Infections Program. This figure shows the crude incidence rate of CDI stratified by epidemiologic class. The blue line shows the crude rates of healthcare-associated CDI from 2011 through 2022, and the dark red line shows the crude rates of community-associated CDI over the same time period. And you can see that since 2011, we've been seeing a steady decline in healthcare-associated CDI, similar to what we saw in NHSN with hospital onset CDI declining through the first year of the pandemic and the sort of leveling off. And so this decrease suggests that the overall decrease in the burden of CDI that I showed in the previous slide is likely driven by a decline in healthcare-associated or hospital onset CDI. In contrast, when you look at the maroon or dark red line, which again represents community-associated CDI, we've seen either a steady increase or at least staying constant since 2011, although there was a drop in 2020, the first year of the pandemic, which we think was due to a decrease in outpatient healthcare utilization. But since then, the rates have rebounded back to pre-pandemic level. When we look at the molecular epidemiology of CDI, this figure shows the percent of isolates reported through EIP that are ribotype 027 or ST1. This is the epidemic strain of C. diff. And you can see from 2012 through 2020, both among healthcare-associated strains and community-associated strains, the prevalence of ribotype 027 has decreased. And in fact, interestingly, since 2014, ribotype 027 has been replaced by ribotype 106 as the most common community-associated strain reported through EIP. And then in 2019, similarly, ribotype 106 has preceded or superseded ribotype 027 as being the most common healthcare-associated strain, again, among isolates reported through EIP. So why has healthcare-associated CDI in the US decreased? And we think it's due to several factors. First, there has been an improvement in infection prevention practices in healthcare facilities over the last decade. There's also been a significant decline in the epidemic strain ribotype 027, as I had just shown you in the previous slide. However, I don't think this is the driving factor, given that we've also seen a decline in the prevalence of ribotype 027 among community-associated strains, and yet the incidence of community-associated CDI has not decreased. We've also had a reduction in inappropriate antibiotic prescribing in this country, including reduced inpatient fluoroquinolone use due to just greater emphasis on antibiotic stewardship, particularly in inpatient settings. And so this could lead to less selective pressure for ribotype 027. And as we've seen in England, the restriction of fluoroquinolone prescribing can lead to drastic CDI reduction. But I think importantly, a major factor for why we've been seeing a decrease in healthcare-associated CDI is due to changes in C. diff diagnostic testing practices in this country. We've had greater emphasis on diagnostic stewardship and been very successful, I think, with doing that to reduce inappropriate testing, particularly in inpatient settings. And I think continued decreases in healthcare-associated CDI rates may be due to a recent shift back to using toxin-based tests over molecular assay for reporting CDI. And I'm just going to expand on this a little bit further. So in the last decade, early on, because of concern that cases of C. diff may be missed by tests that had lower sensitivity, such as toxin enzyme immunoassays, there was a push to use more sensitive tests early on, specifically nucleic acid amplification tests. And so we saw a rise of NAT usage in the US in the last decade. However, with that came data suggesting that increased NAT use could lead to potential overdiagnosis of C. diff. And so as a result, we're now seeing the pendulum swing back to the other direction with an increasing number of US laboratories switching to toxin-based test for confirmation, specifically this two-step algorithm, which is more popular, more commonly used in Europe, which is you screen initially with NAT, and if positive, it then reflects the toxin EIA for confirmation. And in fact, as of 2022, 30% of all US hospitals are now using this two-step algorithm. At the same time, there have been changes to NHSN's CDI lab ID reporting rule, specifically that if your laboratory uses a multi-step testing algorithm to diagnose C. diff, only the last test of the algorithm is used to determine whether or not this case needs to be reported to NHSN. And so facilities that use this two-step algorithm, if the NAT test is positive but the toxin test is negative, they're not required to report that case to NHSN. And so for some of the facilities using this two-step algorithm, it's led to a decrease in rate in reporting of CDI rates. However, there have also been recent data suggesting that those that are NAT positive, toxin negative, a small subset of those may have disease and are actually receiving treatment by clinicians, but are not being reported to NHSN. And so this two-step algorithm can result in underreporting clinically relevant CDI for some facilities. So what do we know about community-associated CDI? In general, community-associated CDI, there's a higher incidence of it in younger population and in communities with lower socioeconomic status. Although patients with community-associated CDI may have milder infection than those with healthcare-associated CDI, a third can still require hospitalization, and 11 to 14% of patients with community-associated CDI can develop recurrent CDI. There are several risk factors for community-associated CDI that have been investigated. Some are healthcare related, although community-associated cases have not had recent hospitalization. The vast majority, 80% or so, have had recent outpatient healthcare exposures. And recent antibiotic use is still a major risk factor for community-associated CDI. In one study that looked at patients 65 and older, they found that remote hospitalization, so having hospitalization in the preceding 6 months to a year, was a risk factor for developing community-associated CDI, suggesting that perhaps from microbiome disruption occurring from either antibiotic use or some other factor during hospitalization, that their gut microbiome can still remain perturbed and maybe could increase the risk for acquiring and developing C. diff infection. There are also several non-healthcare sources of C. diff. Studies have shown that exposure to infants and household members with CDI can increase one's risk for developing community-associated CDI. Toxigenic strains of C. difficile have also been isolated from various types of food, water, as well as farm and domestic animals. And then interestingly, there was a study done a few years ago in Europe looking at various C. diff isolates, and they found a distinct pattern of C. diff spread, suggesting that transmission can occur via the food chain route or the environment. So in summary, we've seen a decrease in the incidence of CDI in the US over the last decade, driven primarily by a decline in healthcare-associated CDI. There are several contributing factors for the decline in healthcare-associated CDI, including changes in diagnostic testing practices and antibiotic stewardship. Despite the decline in incidence, however, CDI burden is still substantial in this country and is associated with high morbidity and costs. We're also seeing increasing proportion of CDI that are community-associated. A large portion of these cases require hospitalization, and the majority of community-associated cases have had recent antibiotic and outpatient healthcare exposures, highlighting opportunities for prevention. Thank you.
Well, Alice, thank you so much for that wonderful overview of the epidemiology of C. difficile infection. We now understand the burden that we see on our society and the United States in general. We also know that the microbiota is an important piece of the puzzle in the physiology for this infection. More on that later from Bruce Hirsch. Back to Life is a company based in Copenhagen that focuses on binding proteins that fortify your microbiome against harmful microbes. Today, we have Dr. Sandra Wingard-Thrain, who is the co-founder and senior vice president from Back to Life, who's going to provide us an overview. Sandra, the stage is yours.
Thank you so much, and thank you so much to the Peggy Lillis Foundation for this exciting scientific symposium. I've been looking so much forward to it. Today, I'll tell you a little bit about a survey that we've been doing together with the foundation to understand better how C. diff actually impacts the patients that it is affecting. And then, of course, I'll also talk a little bit about what we're working on. But overall, an exciting program that I'm really looking forward to. So just the backdrop on Back to Life, as mentioned, we're a biotech company coming out of Copenhagen, Denmark. We're around 40 people here in our research labs and facilities, and we're backed by cornerstone investors, including Novo Holdings and the Bill and Melinda Gates Foundation. And we're set out, as just mentioned, to use our binding proteins, functional food proteins, to empower worldwide health through a fortified gut microbiome. So really trying to make sure that we have better tools to maintain and sustain a healthy gut, a healthy body, and just go around our life where we can really just have a more worry-free life. And there, I think it's very close to home to then talk about C. diff, since it's something that affects a lot of people, as we just heard, that it's a problem that is really out there and affecting a lot of people. And that's also where we've been working with the Peggy Lillis Foundation on doing a survey to understand better what it is like living with C. diff. These patients that are affected, what do they really experience? And therefore, we have been conducting a survey among Peggy Lillis members list and trying to understand this. So I'll share some of the key insights from this survey with you today. And the answers and experiences represent 197 current or previous C. diff patients that have answered these questions that we had in our survey. And looking a little bit at the people that then participated in the survey and shared their insights with us, what you can see is that a lot of them have had C. diff in recent years, but also some of them it's a bit of a while longer back. But what is very clear is this trend that we all know from C. diff, that it's something that is often recurrent. So we have an average of 4.44 recurrent episodes in the patients that are answering the questions in this survey, and in that way, it's people who have really lived with C. diff. And one of the things we really wanted to understand is that one thing is how it affects you physically, but another thing is also how does it affect you mentally? How do you experience being a patient with C. diff? And therefore, we really asked about how concerned are you about the risk of recurrence when you've experienced C. diff? So what's the level of worry? And what we see is that 97% are very concerned or somewhat concerned about the next episode. So the majority of these patients really live with a large worry after they've experienced C. diff. When we then also asked about what's your overall impression about or opinion about the availability and effectiveness of the treatments to manage C. diff, we also see that 40% are actually saying that they're not happy with the current treatment options, which I think kind of makes sense when you also see that a lot of them have experienced these recurrences and have a lot of this worry that they're carrying around. But we wanted to understand better. One thing is that you have a not so good impression of the available treatment options, but then looking into the different categories of treatments and products that are out there, what's the general opinion on how effective they are, and also of the available treatments? Do they see that they have been effective in the context of the patients that we were talking to? And here we really see that a lot of them, they don't really have a lot of trust, especially in the antibiotics, which again makes sense to the extent that many of them have had these recurrences and have been treated with antibiotics that have then not really fixed their problems, whereas these new FMTs, are relatively new FMTs, are something where there's a higher confidence in their effectiveness. But still, we are in a situation where only 8% of the survey responders actually see that they find the solutions available to them effective. So this is the opinion of the survey responders. But then we also wanted to see which of the treatments have they actually tried on their own body. So here we asked them, which treatments have you received? And of the treatments received, what was most effective when they were going through it? And here we again see that these antibiotics, in particular vancomycin, the majority, almost all of the responders have tried this, but not as many have seen that this is the most effective treatment. So here we have the recurrence. And what's also very clear is that very few of the responders, unfortunately, have been able to have available to them to try some of these newer, exciting LBP-based products and treatments that are more expensive and therefore just less available. So there is still this major gap in effective treatments and also making them available to the C. diff patients. And that's why we also wanted to understand, but one thing is that there's treatments and you go to the doctor and they try to treat you. But since you have this large worry in these patients, what more do they do? So what have they tried to do for self-help and management, since they are very worried? And here we can see that 89%, so almost all of the responders, have taken steps actively to prevent C. diff infection in their household because of this large mental load, the worry of the recurrence. And if you then look at what have they been doing to try to take these steps, there's a lot of supplements, so prebiotics, probiotics, very many probiotics, but also things like sanitization and hygiene, altering your diet, simply avoiding antibiotics because of the fear that it can trigger the next event. And something that I found a little bit heartbreaking is that some of them even go to sleeping or living in separate rooms to try to also protect their family members from C. diff exposure. And of course, the fact that they then take these steps themselves also adds cost. So when we then look at how have they been covered in relation to insurance, but also out-of-pocket costs that then have accumulated to them in relation to their experiences with C. diff, what we see is that not all things have been covered by insurance, and the out-of-pocket costs really accumulate because they then also take all of these extra steps. So the majority of the responders are using thousands of dollars out of pocket to try to manage C. diff or try to take care of their health in this context. So summarizing what we learned from the survey and what we therefore really wanted you to take away from today, and which I also think goes well together with the introduction we just had on the epidemiology, is that life with C. diff, one thing is the symptoms and that you need a treatment, but another thing is that 8 out of 10 patients are very worried about getting the next infection. So you're really going around with a big burden when you've tried to have C. diff. And that means that they take these steps to try to manage their health. Further, they don't have a very good impression of the effectiveness of the treatment options, and there's definitely still need for better treatments across the spectrum, so to speak, so that we can have a better management of C. diff. And then that they are definitely scared of using antibiotics because they really see that as something, of course, triggering in relation to the worry of getting another C. diff episode. So they very much then go to other types of products, including supplements, to try to manage and maintain their health so that they can reduce the risk of the next C. diff episode. So in summary there, you can say that it's really a picture where there's a big need for new treatments, but also other tools to support both these patients and people at risk of C. diff. That's also why I'm so excited about the program today. There's a lot of companies talking about all the products that hopefully will come to help this segment. Because as also just pointed out by Dr. Gu, there is also this rise in the community cases, or at least maybe an increased awareness of how big a proportion the community cases actually are, and that it's not just a hospital-acquired infection, as was maybe the dogma some years back. These are just some data from some of the really nice also epidemiological research coming out of the Compact CDI cohort that's also working here in Europe, where they also look at where can you find these C. diff strains, and they are all over. And many of the community cases are also not necessarily linked to antibiotic use. So based on that, I really like this Tolstoy quote that happy families are all alike, but every unhappy family is unhappy in its own way, in the sense that we don't know what's going to disrupt our gut. Something happens, and for one reason or another, we become vulnerable, and we need this added layer of protection. And that's really where we need better tools to maintain a healthy gut, also in relation to C. diff. So we need to treat it better, but we definitely also need better ways of trying to support our gut health to just, not get the infection in the first place. And this is where we also use the survey to work on the product that we are working on here at BAS. That's a functional food ingredient and product. It can be a supplement or put into food products that can then help support your gut health on an everyday basis as an easily available solution, so that you can hopefully have more peace of mind and less of the worry of getting the next C. diff episode. We could really see that responders really liked the concept, and also really found it interesting to have more tools to also protect their gut health from C. diff. As mentioned, we work on binding proteins here at Back to Life, so we do a lot of really great protein science in our laboratories to characterize our products, so we can make sure that they can add this layer of protection on a daily basis. And CD Balance is based on a really detailed molecular design of these proteins, so that they can efficiently block the toxins of C. diff, so that once you're exposed or vulnerable to infection, you can protect your gut integrity from the toxins, and thereby reduce the risk that you get the infection until your healthy gut microbiota hopefully recovers, or you, for other reasons, are not as susceptible to infection as maybe an antibiotic treatment made you in the first place. And this is something, we work a lot on here at Back to Life, to really make sure the binding proteins can deliver this effect. So we work a lot with cell models, where we emulate the gut cell barrier and layer, so we can show how we can block the toxins, so we can put our binding proteins into these cell models and that are exposed to the toxins, and show how we can both stop them from being intoxicated by the toxins, so both in relation to their survival, but also in relation to reducing the inflammation levels that are being created in the cells when they're activated by the toxins. So what we feel as the discomfort once the gut starts to get exposed to the toxins, we can alleviate this inflammation and normalize inflammation levels by adding in our binding proteins. And then we've also been working on a model where you then look at the actual gut barrier integrity and, you could say, strength. So that's the key aspect of making sure you don't get a full-blown infection, is making sure that your gut barrier is robust. And here we can also take our binding proteins and, together with the toxins, work with these cell barrier layers, and then see how we can protect the barrier integrity, so how strong it is, but also how we can make sure that it doesn't become permeable, so how we don't have this leaky gut that can be a result of exposing our gut or our cell layer to a toxin. So making sure that we really have a robust gut that is maintained even if we're exposed to something like the C. diff toxins in our GI tract. So that was hopefully some exciting insights from this survey. I think for us here at Back to Life, it was really interesting to see not just the physical, but also what the mental burden of this disease is. We're always very keen to talk to healthcare practitioners or others also working in the field. So if you want to learn more or give us feedback on our work, please contact me or our business development SVP, Julie. Then we'll be happy to talk to you. And then thank you again for the opportunity to talk here today. Looking forward to the rest of the program.
Wow, thank you, Dr. Singard-Thrain. Sorry, mispronounced your name. That was really wonderful. I think it's really important that we, again, ground ourselves in the patient experience, which we're going to hear from patients individually later, but looking at the broader picture, the impact on health-related quality of life, I think all that integrates together into us as clinicians, but also companies understanding what we're doing and why we're doing it. And I think your innovative approach to trying to counteract the toxins hopefully will go a long way in the future. As we now shift gears, in order to understand how to optimize treatment of patients with CDI, we have to properly understand how to accurately diagnose the infection. And this isn't an easy task. Eric DeBerke has been at the forefront of diagnosis and management of this infection for a long time. He's a professor of medicine at the Washington University School of Medicine in St. Louis, Missouri. He's a friend and colleague, and we are absolutely delighted to have an uber expert talk to us about diagnostics. Eric?
Oops, I'm muted. Okay, so I've got my screen share. I'm unmuted, so thank you very much for the introduction, and thank you very much for inviting me to come present here today. And actually, this is going to, I think, dovetail nicely with Alice's talk a few sessions ago with the when she was talking about diagnostics and how that impact our observed or perceived C. diff infection rate, and just the diagnostics we use can impact that. So as we start here, one of the first things I want to review is that I'm going to be talking about both colonization and C. diff infection. So I just want to make sure everyone is aware of what I'm referring to when I'm talking about these two distinct entities. Colonization is when C. difficile is detected in stool but is not causing symptoms. C. difficile infection is when C. difficile is causing symptoms. And of course, the most common symptom of C. diff infection being diarrhea. C. diff causes symptoms via the production of toxins. Historically, it's been toxin A and toxin B, but it's really toxin B is the primary driver of C. difficile infection. In order for C. difficile to cause C. difficile, they have to have the genes to produce toxins, and those strains of C. diff are referred to as being toxigenic strains. Of note, about 20 to 30% of strains of C. diff detected from human stool are non-toxigenic, and this means that they cannot cause C. difficile infection. And I'll talk about this a little more when we get into some of our diagnostics. And again, just because toxigenic C. difficile is detected in stool does not mean a person has C. difficile infection, because it could be that they're just colonized. There are several challenges to the diagnosis of C. difficile infection. And first and foremost, it's because the site of colonization is the site of infection. We are probably all periodically colonized with C. diff over the course of our lives, but most of us do not have C. difficile infection during those periods of colonization. Risk factors for colonization are also risk factors for C. difficile infection. So you can't use the presence of a risk factor, such as an antibiotic exposure, to help differentiate who's colonized and who's not colonized. And then there's those people that develop C. difficile infection. They don't always have those classic risk factors as well. So you can't use risk factors to help determine who is colonized versus who has C. diff infection. And also, most people who are colonized with C. difficile do not have C. difficile infection. And this includes people with diarrhea. This includes hospitalized patients, and this includes hospitalized patients with diarrhea. As I mentioned already, probably most of us are colonized with C. diff at some point over the course of our lives, and not just at some point, but probably periodically throughout the course of our lives. So most studies looking at colonization in infants find a colonization prevalence of between 50% to 100%. Fortunately, C. difficile does not appear to be a cause disease in the vast majority of infants, with CDI in infants being very uncommon, despite the frequent detection of C. difficile colonization in the stool of infants. With toddlers, it goes down to about 10 to 25%. And again, C. difficile infection in this population is very uncommon. Vast majority of this, almost 99% probably, if not higher, just represents colonization, not C. diff infection. Otherwise, healthy adults without diarrhea, you're able to detect C. difficile from 3 to 5% of their stools. And among hospitalized patients, it's about 5 to 15%. Colonization tends to be transient. If you were to culture everyone's stool 3 months after that initial colonization was detected, you're not going to be able to detect that colonization in over half those people. And this includes people who are successfully treated for C. difficile infection. So there's several different diagnostics that are available, but there's two main categories when thinking about diagnostics and what they're detecting. So you've got toxin detection and you've got organism identification. So toxin detection in the US, at least by far, the most commonly used assay is our toxin enzyme immunoassays. They're very rapid and simple and inexpensive. And the result of toxin assays have been associated with patient outcomes. So having a positive, stool positive for C. difficile toxins is associated with worse outcomes versus people whose stool test negative for toxins. The main downside of them is that they are our least sensitive method, so you will have false negatives. So you will have people with C. difficile infection, but that toxin is not detected. The tissue culture cytotoxicity cell assay is more sensitive than toxin EIAs. It has also been associated with patient outcomes, but for a variety of reasons, It really is not utilized in the US in clinical microbiology laboratories, in no small part because many labs no longer have the specialized cell culture equipment needed to do this type of testing as we moved over towards PCR-based diagnostics for viruses. For organism identification, we've got glutamate dehydrogenase or GDH enzyme immunoassays. These are rapid and sensitive, but they detect both non-toxigenic and toxigenic strains of C. difficile. So you're not always, not very specific. There are also some other bacteria that produce GDH. So again, just because GDH is positive doesn't even mean toxigenic C. difficile is present in that person's stool. There are nucleic acid amplification tests, are referred to as NAT, and then you will also pretty interchangeable with the term PCR. So these are organism identification tests. They're detecting organisms that have the genes for toxins. It does not tell us if toxins are being produced. These assays are very sensitive, and actually so sensitive that they don't have very good specificity for actual C. difficile infection, because you will detect many people who are colonized with C. diff who don't have C. diff infection. Stool culture, when performed properly, is the most sensitive test for C. difficile detection in stool, but again, it's not really readily utilized in the US by clinical microbiology labs. I think there are some important flaws in the historical diagnostic literature interpretation that still hamper us today. First and foremost, one thing I like to stress, and actually a pet peeve of mine, is when people refer to C. difficile infection testing. So there is no such thing. There is no test that is currently available that tells us who does or does not have C. diff infection. Our currently available diagnostic detect C. difficile toxins, or they detect the organism. So a major flaw in the historical literature is that there was a lack of clinical data from the patients whose stool was selected for these assay comparisons. Again, 5 to 15% of hospitalized patients are colonized with toxigenic C. difficile, but typically less than 1% of hospitalized patients have C. difficile infection. So there are many more people who are colonized with C. diff than those who have C. diff infection. So with the lack of clinical data, there ended up being a misperception that all these culture positive toxin negative stools were false negative for C. difficile infection by the toxin assays, which was not necessarily the case, because many of these people who are culture positive but toxin negative are colonized. They don't have C. diff infection. Another issue that no longer exists, but was an issue in the past with sensitivity of toxin tests, is that the original toxin enzyme immunoassays only detected toxin A. And that was a problem because up to 20% of C. difficile strains that cause C. difficile infection only produce toxin B. So these toxin A only assays would miss these toxin B producing only strains. So definitely an increase in false negatives for C. difficile infection, but fortunately these assays are no longer on the market. But all these issues led to this push for more and more sensitive diagnostic assays. So I've already made the comment of false positives and false negatives. So again, I'm going to help define that here. So when I talk about false positive tests for C. difficile infection, there's two main categories for this. One is toxigenic C. difficile is detected in stool, but the person does not have C. difficile infection. And that's the concern of the more sensitive tests with GDH, NAT, and culture. And you could have an assay a result that's positive, but toxigenic C. difficile is not present in that person's stool. And these are issues with those tests that detect non-toxigenic C. difficile, including GDH and culture. And also, no assay is perfect. Just due to a background error rate, you're going to have false positives where a test might be positive, even though that target is not present in that specimen. That happens with C. difficile diagnostics, both with all available diagnostics with GDH, NAT, and toxin detection. So to help demonstrate how the clinical presentation is important when interpreting diagnostic assays, is a study that we did. So we actually did perform the first diagnostic assay comparison where we actually included patient information, what was happening with the patient when interpreting the C. difficile diagnostic test. We actually prospectively spoke to the patient. So that stool specimen was collected, that stool specimen was selected for our assay comparison. We did not know the result of the diagnostic assay, but we went and spoke to the patient, saw what medications they were receiving, figured out how bad their diarrhea was. So when we included a definition for clinically significant diarrhea in the gold standard comparator for what is truly C. difficile infection, versus if we did not include that, which was what was done historically, we found it had no impact on the sensitivity of the diagnostic assays we included. So we had 3 gnats in our diagnostic assay comparison. They all had a sensitivity of 99%. We had 3 different toxin enzyme immunoassays as well, with a range in sensitivity from 90% to 94%, which is actually, again, much better than what you would have expected from the historical literature, where they ignored clinical symptoms, did not have that information, or with a toxin A only enzyme immunoassay. But when we did include that clinical information in the interpretation of these diagnostic assays, we found that the specificity of these gnats for C. difficile infection, again, people with actual C. diff infection versus those who are colonized without C. difficile infection, dropped from 98% when we ignored symptoms down to 89% when we included symptoms, for a positive predictive value of C. difficile infection of only 60%. So that means that for every 10 people who were positive by gnat, only 6 of them actually had C. diff infection. And since our assay comparison, this has been consistent with what other people have found, where the range and positive predictive value for C. difficile infection with gnats now it's generally in the range between 40% up to 60%. So in general, you could say it's about a 50-50 chance that the person has C. diff infection. And again, there's been numerous assay comparisons now when they look at patients whose stool is positive by gnat but negative for toxins versus patients whose stool are positive for toxins. In general, these gnat positive, toxin negative folks are generally not as sick. They've got lower white blood counts. They're less likely to have pseudomembrane seen and endoscopy, and they have lower concentrations of C. difficile as well as C. difficile toxins in their stool. And also their outcomes are better. They have a shorter duration of diarrhea, even though in many of these studies, the people with gnat positive, toxin negative stool do not receive C. difficile infection treatment. And also they're less likely to be diagnosed with a subsequent recurrence of C. difficile infection. And also they are less likely to die. Again, suggesting that they don't really have C. diff infection versus those people whose stool is positive for toxins. So there's a variety of things we do to try to improve the diagnostic assay interpretation, make it easier to be able to say, okay, well, this person actually does have C. diff infection versus those who don't. One of which is most labs, pretty much all labs, I think, in the US now will only test diarrheal stools. And again, that's because if you're not having diarrhea, you probably don't have C. diff infection. Another recommendation is that you should be selective in who you test if there's other reasons for diarrhea. So example, if that person is on laxatives, you should probably stop that laxative before you start testing for C. difficile. And so say someone has chemotherapy, which is known to cause diarrhea, maybe you should select only those people whose diarrhea is worse than you would otherwise expect due to the chemo they receive before testing for C. difficile. And then there's been a variety of testing algorithms that have been employed. And also another thing that's important that I think does not always happen is to reassess the patient once that test result is back. If it's positive, is that patient still having diarrhea or not? So that should also impact your interpretation. Conversely, if it's negative, you want to be asking that question as well. So because of the complicated nature of trying to diagnose C. difficile infection, based on everything I just described, there's a variety of testing algorithms that are employed. And so I'm a co-author on this paper here where we created this table to help in the interpretation of diagnostic assays. So if a stool is positive by gnat and for toxins, that most likely that person has C. difficile infection. That's the easiest way to go about the diagnosis. If gnat is negative, that has a very high negative. It's very high negative predictive value, meaning it's very unlikely the person has C. diff infection. If a NAT is positive, but toxin testing is not being done, which is actually relatively uncommon nowadays, but still happens. The patient might have C. difficile infection, but again, in this setting, the likelihood of C. diff infection is about a flip of a coin. If that NAT is positive, but then toxin testing is done and it's negative, again, it's possible the person has C. diff infection, but most of them don't. Only about 15% of these people will have C. diff infection. The remaining will be colonized without C. diff infection. And for the few the labs that still do just toxin testing, if that's positive, again, they likely have C. diff infection. I'm running out of time here and I'm a fast talker, so I'll hurry up. So we also have these GDH-based algorithms here where if it's GDH positive, toxin positive, again, likely C. diff infection. But I'm going to focus on down here. So some labs, if that stool is positive by GDH, negative for toxins, they then will do a NAT. And so oftentimes what you find is that stool will be positive for GDH, negative for toxins, but positive by NAT. But again, as with the NAT positive, sorry about that, NAT positive, toxin negative stools here, the interpretation is exactly the same. Only about 15% of those people have C. diff infection. Most do not. And there are risks to both false negatives and false positive for C. diff infection. For false negatives, they might have C. diff infection that's not being treated. And so we have a persistence and or potential for worsening of infections and outcomes. And in the healthcare setting, that person may not be placed in the contact precautions. You may have further onward spread of C. difficile to other patients. But there's also risk to false positive as well, where a patient may unnecessarily receive C. difficile infection treatment. And although oral vancomycin is great at killing C. diff, it's also great at killing all the bacteria that protects us against C. diff. So this may actually paradoxically increase that person's risk for actually getting C. diff infection once that vancomycin is stopped. And also there's the cost and side effects of medications. And I think the biggest risk to false positives, and I see this not infrequently in my practice, is that actual cause of diarrhea remains undiagnosed and they have persistent symptoms for that reason. So in summary here, C. difficile infection, I shouldn't say can be, it is challenging to diagnose. The site of normal colonization is also a site of infection. And again, a test for C. difficile infection does not exist. You're detecting the organisms or the toxins or both, depending on your algorithm. But you still have to interpret that with what's going on with the patient. And then we have a variety of measures to try to improve that. And again, toxin testing is more specific for C. diff infection, and NATs are very sensitive, but they're less specific for C. diff infection. And I apologize for going a little over, and I am finished here. And let's see, again, I'd like to thank the organizers very much for inviting me to come speak here today. Again, thank you.
Eric, thank you so much. You know, I think you're speaking to the fact repeatedly that we need to look at the patient and see how the patient is doing. In a world where we want to control everything from our cell phone or from the convenience of our house, we don't have great diagnostic testing for C. difficile. And as you've alluded to repeatedly, C. difficile infection, we don't have a test for it. It's either looking for the bug or looking for the toxin and then clinically contextualizing those results. And I think in a world where the expectations of productivity for providers, physicians, advanced practice providers goes up, the thought processes that go into these diagnostic tests, the pre-test probability, the post-test likelihood that that's a true positive or a false positive really takes on added importance. And I think over the last 10 years, with you being one of the key pieces to this, a lot of healthcare systems have gotten much more astute with their diagnostic testing. I think in the community, we have a lot of work to do in terms of gaining the insights that you just shared over the last couple of minutes. So thank you for that. As we shift gears, I want to introduce Dr. Andrew Skinner. Andrew is an assistant professor of medicine at the University of Utah and a staff physician and researcher at the George E. Whalen VA Medical Center. Andrew's a colleague and a friend. He's here on behalf of Recurrent Pharmaceuticals, and he is going to be introducing us to a novel treatment, REC 3964, a novel small molecule. Andrew, take us away. Thank you.
Thank you, Paul, and thank you to the organizers for allowing me to come here. Oh, my slides, look there. There we go, a little bit cut off here, but we'll make it work. I'm Dr. Andrew Scan at the University of Utah. I will try to make up a little time that we have here from my conversation, from following up Eric at this point right now. And so we'll be moving into talking about a new small molecule therapy as adjunctive therapy for C. difficile infections. And the one disclosure that I do have in this setting is that I'm a paid advisor for Recurrent and a site PI for the Alder trial, which we will get into a little bit here. And so these are our objectives. We'll give a quick little background on the rationale for small molecule inhibitors and introduction to REC 3964, and then I'll talk a little bit more about the phase 2 trial for REC 3964 as well. So for our background, as we've kind of already gone over, and I think everyone here knows a little bit, is that C. diff is one of the worldwide diseases affecting nearly 500,000 people in the US and is the leading cause of healthcare-associated diarrhea. However, we've noticed that the treatment has evolved significantly over the past 10 years, but it's still very reliant on antibiotic therapy, fidaxomicin, vancomycin as the mainstays here, and as Eric alluded to in his last talk, is that vancomycin still has many deleterious effects on the microbiome as well. And because of this, we're still dealing with significant recurrence rates, where we're seeing about recurrence in 20 to 30% of the patients. And once you have that recurrence, upwards of about 65% of those will end up going on experiencing multiple recurrences as well. And so when we talk about the background rationale for small molecule inhibitors, and that looks like it got cut off a little bit. So small molecule therapies aim to target the virulence factors which contribute to the pathogenesis of C. diff infections. And so that's why they're typically given as adjunctive therapy, because for the majority of them that are being assessed at this time right now, most of them do not actually impact, they're not bactericidal on the bacteria, but they do impact what causes the infection. So toxin A, toxin B, binary toxin to some extent, motility factors, the S-layer protein, which is important for adherence, sporulation factors, and then biofilm formation as well. And so moving forward, I do want to talk a little bit more about toxin A and toxin B, mainly toxin B, very similar to bezotoximab in that matter as well. And so let's talk a little bit more about REC 3964. And so with an introduction to REC 3964, it is a novel chemical entity that inhibits C. difficile toxin effects on the glycosylation of the active form of the intracellular road GTPase. And so we've got a nice little figure over here on the right-hand side. So where you typically see where toxin is entering into the cell membrane, it actually ends up, REC 3964 is what it inhibits further downstream at that point. And so the goal with that would be to disrupt the inflammation caused by toxin B, diarrhea as well. And subsequently, the further downstream effects of that, to where you can see people with colitis and more severe infections as well. That's not working. I apologize. Right, there we go. And so when we take a look at some of the data that we have so far on REC 3964. So over here on the left-hand side, that's where I want to start to begin with. And so one of the things that we do know, how this was kind of found to be the most effective, is so these bottom images down here. So these are C. diff toxin B treated HEVEC cells, and then also the healthy HEVEC cells that we have here on the right-hand side as well. And so one of the things that we had that Recurrent was able to do is that they, to identify the compounds that rescue the effects of the toxins, they use image-based phenotypic screening assay with a machine learning algorithm to analyze the cells. And so with the healthy cells over here to the C. diff toxin B treated cells over here, it doesn't really look that different, but that is one of the advantages that we can start to use with some of these machine-based learning algorithms, especially image-based learning algorithms, which can readily more detect is there any actual difference at that point as well. And so they were able to find that with their compound, they were actually able to show some improvement when they actually introduced, if you go up to the top image up here, with these, with REC 3964, you start to notice that a slight little shift over once you introduce RE 3964 as well. And so that was the predicted change that you're going to have. Over here on the right-hand side was in a hamster model where they compared, where they introduced C. difficile spores into They're hamsters, and then they have the black line up here being vancomycin. The blue line here are the study drug, REC3964. The purple here being bezlotoxumab, and then this kind of darker blue over here, that was the vehicle, which 3964 is carried in at that point as well. And so, as expected, you notice that the black line carries all the way across for vancomycin, protecting at least while they're on the vancomycin. And then during the Kaplan-Meier curve, we noticed that the bezlotoxumab, the purple line dropped down pretty precipitously, and there was a slight bit of improved survival time within the RE3964 group as well, noting that it potentially inhibits toxin B with some residual activity, at least when compared to bezlotoxumab as well. And these changes were significant, and this was done within 10 hamsters within each of these groups as well. And so let's talk a little bit more about the phase 2 trial that is now actively enrolling as well. And so, again, this is a little bit more basic data, I think, to start off with, but kind of as we know is that the prevalence and the standard of care for C. difficile is something that is actively changing at this point as well. We know that there are nearly 750,000 diagnosed patients within the US and in the EU roughly a year. Severity can range from colonization all the way up to severe colitis, which can require colectomy, with nearly 30,000 patients dying in the US alone from C. diff alone, with an annual cost burden of nearly $5 billion. With the standard of care, as we noted earlier, antibiotics are the mainstay at this point, and that's what's used for most first occurrences for your primary infections alone. There's a little bit of a difference when we start talking about the European guidelines, though. Sometimes we'll start seeing bezlotoxumab used a little bit earlier, but that's when bezlotoxumab and then some of our live biotherapeutic products and then fecal transplant starts coming in after recurrence at that point as well. And so the goal of where to position something similar of REC3964 would be something I would say along the lines of being similar to bezlotoxumab as well. And so, kind of as we noted earlier, the proposed pathophysiology for this would be as a selective inhibitor to C. difficile toxins, and namely toxin B, to bind and block the catalytic activity of the toxin, and thus preventing downstream consequences of infection. And so, how is the phase 2 trial going to work? I'm going to start over here kind of in the middle here for the screening and the randomization, just so we can follow along together. And so we start off by screening for people who have a high risk of recurrence. And so these are going to be people who we deem that they're going to be at a much higher risk of developing subsequent infection after they were to be treated with vancomycin. And so patients at high risk, including those who are going to be immunocompromised, older age, more severe infection. And so they would be treated with vancomycin. And then we have got to randomize them, and we'll go into this a little bit more, into 3 different arms where we have an observational, the study drug given at 500 milligrams BID, the study drug given at 250 milligrams BID, and then follow-up during that time period as well. And so next we'll go over the enrollment criteria, the outcome measures, some of our exploratory outcomes, and then the planned updates as well. So with the study design, as I noted, this is a phase 2 open-label multi-center study designed to characterize the safety, tolerability, and certain parameters and the efficacy of REC3964 with observation. And so the primary drug that's being used for treatment is vancomycin in this study. We're not using fidaxomicin for the phase 2 portion of the study. And the study will enroll male and female participants 18 and older at high risk of recurrence. And the aim is to get roughly about 80 participants from approximately 30 study sites in the US alone. And as I noted earlier, that's going to be 3 cohorts. And so it would be 20 in the group with 250 milligrams of REC3964, 40 within the 500 milligram, and then 20 in the control group. And then the treatment duration of this is going to be every 12 hours for both of the study drugs, up for 28 days. And then moving forward to the design, so each one will be a screening visit day 1, followed by day 15, which is roughly the end of the antibiotic therapy, day 29, the end of therapy, and then day 57 follow-up. trying to move a little bit quickly because I know we're a little bit behind here. And so the primary objectives of the study is to evaluate the efficacy of REC-3964 as determined by survival without recurrence or requirement for additional C. diff at least 4 weeks after the end of therapy, and to evaluate the safety and tolerability of REC-3964. And then the secondary objectives are to assess for the efficacy of REC-3964 as measured by other efficacy endpoints, and to characterize the pharmacokinetics of the study drug as well, with the endpoint being survival without recurrence or requirement of additional CDI therapy for at least 4 weeks after the end of therapy. And this will be analyzed using Kaplan-Meier methods, with a median Kaplan-Meier estimate of the endpoint will be reported along with the 95% confidence intervals for the study groups. The secondary endpoints that we're mostly looking at here are the rate of recurrent CDI, defined as the proportion of the participants who had the C. diff recurrence among randomized participants. The rate of recurrence and two-sided 95% confidence intervals will be calculated for each of the treatment groups and the observation group. And we'll also be taking a look at the time to recurrence as well, where time to recurrence is defined as the time from the date of the randomization until recurrent CDI as well. So not the end of the study drug, but more from randomization. And again, Kaplan-Meier methods will be used to analyze the time to recurrence. Additionally, we're looking at the severity of recurrent C. diff, the recurrent C. diff associated hospital admissions, and then the evaluation of diarrheal episodes. And so that's the number of unformed stools the patients will be having per day will be assessed and recorded by the participants in the stool diary. A few exploratory endpoints that the study will be taking a look at is the interaction with the gut. And so by participating in listings of pre and post-treatment REC gut bile acid composition, microbiome, and antibiotic resistance gene profile will be provided. And then we'll also be taking a look at serum biomarkers, namely the serum biomarkers we're taking a look at here are going to be things like IL-6, IL-8, CCL11, and EGF. And then we're taking a look at the safety and endpoint analysis as well, to ensure that the drug is safe for patients to be provided as well. And so after that is done, the goal is to complete the phase 2 trial. So enrollment is starting. It's currently ongoing and started a few months ago. And the goal is to have the phase 2 trial, the initial study done sometime in 2025. And so I think I caught us up a little bit of time here. And so I will transition over here that if there are any questions, feel free to email me, and I would be happy to talk about more of this as well. And again, thank you for the organizers for allowing us to speak about this.
Hello, everyone. So that was a really interesting session by Dr. Skinner. We are thrilled to be working with Recursion. And I am back to introduce our first patient testimony of the day. And I'm excited that we actually have not just a patient, but a caregiver as well. So as many of you know, C. diff is a devastating disease, not just for the patient, but often for their family and even at times their friends. Our next speakers, Minnie and Spencer Hatch, have battled recurrent C. diff for several years, with Minnie as the patient and Spencer as a caregiver. Together they have fought in their own lives and have raised C. diff awareness in the media for patients. And most recently, Minnie was featured in Self magazine, which is really excellent. And Spencer and Minnie have also advocated for patients on Capitol Hill since 2018 through our lobby days. And they've done all of this while raising 2 kids, which I find massively impressive. And I'm very, very proud to call Minnie and Spencer part of the PLF family. So listen up, guys. Thank you guys so much for being here.
Thanks Christian. My name is Minnie. I am 30 years old, and I currently have a day job as a property manager. I enjoy being a leader in my community. When I'm not busy being a parent or working, I enjoy reading and baking, and I also enjoy playing video games with my online community. My husband Spencer and I live in Salt Lake City, Utah with our 2 children who are 7 and 2 years old. We have been together through every C. diff infection I've had over the last 10 years together.
Hi, my name is Spencer. I'm a technical account manager for a large software company, a father, a husband, and an avid advocate for C. diff awareness and antibiotic stewardship. I adore attending live music, reading outlandish fantasy, and the occasional video game when my tiny tyrants allow. Minnie and I have been married coming up on a decade now, and it is just stunning to think of how much of this time has been impacted by this disease. Through the ups and downs of marriage and raising 2 cute kiddos, it's always been there. Whether during a recurrence or just a worry, C. diff has always been an unwelcome member of our little crew since before we were married, all the way to today.
I first became ill in the winter nearly 11 years ago. I was 19 years old, working in market research as a top performer when my symptoms started. I was being treated for frequent infections as well as polycystic ovarian syndrome. I had been given quite a few rounds of broad-spectrum antibiotics, and I spent quite a bit of time in the emergency room. After months of care without really getting better, the doctor I was seeing referred me on to a gastroenterologist, but it was still months from there before I would have a diagnosis of C. diff. My doctor told me he couldn't see the forest through the trees, that he had overlooked C. diff mainly because of my age. Following the diagnosis, we cycled through treatments of antibiotics until I eventually qualified for an FMT after more than 2 years of battling symptoms and trudging through antibiotics for each recurrence. During this time, we had gotten engaged, and I was managing to use my youthful energy to fight through workdays still. However, I did eventually lose my job because I was so weak and unable to make it farther than my bathroom most days. I finally received my first FMT not long after we were married in 2016 when I was 21.
That first FMT was so unique. We needed to locate a donor, work with them through testing, ensure they were providing a suitable sample. Then we needed to actually bring the blender on the day of the procedure. It felt so new and definitely experimental. It was a little off-putting, but at this point, I had watched my wife struggle with this illness for over 2 years. I had watched treatment after treatment fail to resolve her underlying symptoms. During this time, I watched as she increasingly was unable to work, some days barely being able to get out of bed. After she'd lost her job, the reality started to set in that we were in a crisis. With only one income, we started struggling to meet our monthly bills. Often I found myself towards the end of each month looking through various collectibles or other things, trying to identify something that we could sell that wouldn't be too dearly missed so we could make rent. Things were starting to look grim, and we were ready for any option that had a promise for a different path. Thank goodness her GI was one of only 2 doctors performing FMTs in the entire state at the time. To this day, I thank my lucky stars that we landed in his care as our family was about to grow.
We had our first child quickly following my first FMT, as my health seemed to just bounce back. Everything seemed to be going well. But when I went into labor, I was given an antibiotic for group B strep, and I realized the damage that C. diff had done to my psyche. While I did not have another infection following the antibiotic treatment for labor, the fear of another infection mixed with the postpartum hormones took me for a ride. I needed to find people that understood what I had been through, but I could barely even find information on Clostridium difficile in general. And that's how I came upon the Peggy Lillis Foundation. In a furious search for understanding and community, I first spoke with Christian in March of 2017. Within a few weeks of our son being born, I think it was within 6 weeks of that we had been flying out to New York for our first summit before we started doing those in DC. I am really grateful for this experience. It was not, I didn't know then that it was just the beginning of my story. And I didn't know how much we would need this community. I made lasting connections on this trip, and I felt more alive than I had in years. Becoming an advocate gave me hope, and I finally felt like I was part of something.
That first summit was truly magical. Here we finally found folks that not only understood what we were going through, but who were strategizing about how to make changes so that others didn't need to go through the experiences of an unknown illness alone as we had. With the Peggy Lillis Foundation, we found a home. Like many said, at the time, we had no idea just how much we would need them or the amazing work we'd be able to do with them. Not long after that trip, we were staring down another C. diff infection. Like the first, it did not respond to primary or secondary treatments.
My second FMT was really not long after the first. Unfortunately, I don't remember much of this time in my life due to the brain fog around it. I know I had taken a broad spectrum antibiotic following wisdom tooth removal, and I know it hit me really fast and really hard. I knew within days that I had C. diff again. It's a pain I can never really forget. This infection took a heavy toll on everything from my personal life, my friendships, and worse, the relationship with my infant son. He was between 12 and 18 months old at the time, and the level of illness this time around left us struggling to bond, as I didn't have the energy to connect or play, and more often than not felt chained to my bed or toilet. Our support systems were crumbling under the pressure of an illness that people around me didn't see the devastation of. I was not taken seriously by doctors because my weight at the time, as well as my age. And it was easy for my friends and family to sometimes say it wasn't as bad as I was saying it was, because they didn't live with me and didn't have to see the damage C. diff was causing to myself, my family, and my marriage. I will say treatment was smoother on this go around, but I still had a lot of hoops to jump through to get to the second FMT.
That second round was perhaps the most difficult of your recurrences on our family life. We had our little boy home with us, and things were tough. During that first year, he was frequently sick and needed constant care. Coupled with that, Minnie was struggling with the after effects of her infection psychologically. We thought we'd found a good doctor to help with her medications, coupled with her amazing therapist to manage her anxiety and other mental health concerns. Unfortunately, we had misplaced our faith. We soon found that this doctor was not prone to listening when medications had harsh side effects, and instead of moderating doses or looking for alternatives, often she was adding new meds to handle those symptoms. One of those side effects was impacting Minnie's ability to create lasting memories. Once C. diff was back, bringing with it that awful brain fog, I found my wife working so hard just to get through her day, often unable to recall what had happened that morning. As things progressed, we were so lucky to be able to secure that second FMT, as well as get her working with a much more measured mental health professional who was able to assist her in regaining her stability while also slowly weaning her off the medication cocktail that was proving so devastating to her well-being. During this time, I had also found gainful employment, allowing Minnie to stay at home with our son full-time and be that amazing mom he so deserves. Things were finally starting to settle, and we were building our life as a family. We'd really hoped this round would put it all behind us, but we were sadly mistaken.
My last infection was during COVID. I don't remember why I had taken antibiotics, but I suppose at the end of the day, it doesn't really matter anymore. Our healthcare system was overburdened. It took a long time to get an initial appointment. While under normal circumstances, I would have qualified for an FMT after just one run of antibiotics, FMTs were placed on hold. As I was not battling at the time severe fulminant disease, I was not a candidate for an FMT. We still applied for months to get the care I needed and received rejection after rejection. Eventually, I was considered sick enough to qualify for the transplant after more than 9 months straight on antibiotics and more than $15,000 spent out of pocket just to keep me alive. This does not account for the cost of the transplant itself, which insurance didn't cover. Only one facility within 150 miles of us would do the procedure, and they were not in network for our insurance at the time. This was the only go-around of the illness where I was taken very seriously by the doctors around me. I had gained a lot of weight, which had been previously attributed to my prior FMTs, and eventually I ended up around 300 pounds. During the pandemic, I had dropped down to 95 pounds, and I was told to prepare for the end of my life by my physicians. I was told by my family and friends that this was my silver lining, that even though I was dying, I was finally skinny. I had some members of my community accuse me of drug use during this time because in their minds, illness couldn't cause weight loss to that degree. When I look back, I think of all the wild things I've heard as a patient, but some of the comments about weight loss were really eye-opening to how the people around me perceive this disease. It didn't seem to be a real threat to them the way it was to me. I received what I hope to be my last FMT in the spring of 2021, and this is the longest period in my adult life that I've gone without C. diff weighing me down. I cannot overstate the fear I felt during this time. Fear for my life, as well as fear for my family and what would happen to my spouse and child if I were to die. It didn't seem to matter how hard I fought. I just kept getting worse, and I could really feel myself fading. I began exercising through my exhaustion. I started rebuilding my community through the vomiting and the weight loss. I did anything I could think of to give myself something to hold on to and fight for. My son and I began connecting in a way we hadn't through my other infections, and I knew that I could not give up here.
This illness was different. Minnie was more mentally aware of what was happening and also much more prepared to advocate for her needs. At the same time, COVID had fundamentally changed everything. I was working from home, and so was there and able to help with our son, who was now 4 years old. It was especially painful helping him understand what was happening with his mom. I found myself frequently ensuring Minnie had an emesis bag handy when the nausea was too much, and then rushing to our boy to comfort him and reassure him that his mom was okay, just a little sick. As the days stretched into months, he started to pick up that something was really wrong. Minnie was shedding weight so fast despite the antibiotics, and we were getting nowhere with the third FMT. With each month, we found that even with my good job, money was tight. Between specialist appointments, testing, and medications, the bills were really starting to make a dent in our nest egg. Then the day came that her medical team discussed getting her affairs in order and working on her living will. Well, one thing you must all realize by now, I married a fighter. She outright refused to give up and redoubled her efforts in securing the FMT. With the help of our amazing board at the Peggy Lillis Foundation and her truly dedicated GI, we were able to finally secure that procedure and get her the care she so desperately needed. And I can tell you, I have never been happier signing a $2,000 check to a hospital. It marked the end of that recurrence, and I truly hope it was the last time she will need that type of care.
My life has been drastically impacted by C. diff, and I'm grateful that we're here to tell you my story while so many others are unable to because they just haven't lived through it. I would not have made it through these infections without the support of Spencer and my family at the Peggy Foundation. I needed the words of encouragement and love from people who really knew what I was experiencing. I needed a community I could turn to that wouldn't brush off my concerns or fears. I needed to know that I wasn't crazy and that I wasn't being dramatic about my experience and suffering with this illness. At 30 years old now, I've begun to rebuild my life from the ground up. I've started working again. I have the energy to go about my day as usual. We welcomed our second child in the summer of 2022. While things are great in my life, I do still suffer from lasting complications like gastroparesis following my history with C. diff. I know that I, like any of you, can always end back up in the cycle of C. diff and recurrences. I count on scientists, doctors, and other advocates to help get these stories out there and to change the way we're approaching antibiotic use. Patients count on providers to discontinue unnecessary broad-spectrum antibiotic use to reduce instances of C. diff in the first place. And we all count on pharmaceutical companies as well to revolutionize the treatment of C. diff and other illnesses commonly treated with antibiotics. We dream of a world where nobody dies or has to live in fear of a recurrence.
It really is the dream. For us and so many folks like us who are trying desperately to make their way in the world but get hobbled by C. diff, some like Minnie are lucky enough to make it out with their life. Many others are not. I'm truly grateful to still have my wife at my side, raising 2 wild children and working to improve outcomes for anyone impacted by this illness. I am also grateful to the platform the Peggy Lillis Foundation has given us to share this story and create meaning from the adversity we've experienced. I feel empowered like never before working with these wonderful, dedicated people to make a meaningful difference in the world. My gratitude also goes out to each of you watching today for giving us a chance to share with you our experience. I hope that you might now have a greater understanding of the impact that C. diff has on so many lives, and that you'll join us in making these struggles a thing of the past. Thank you.
Wow. I am just so riveted by your story. Minnie, thank you for sharing this. Spencer, thank you for being a part of this. Thank you for being part of the foundation, but also thank you for I'll just say regrounding all of us who do take care of patients, reminding us of, this isn't just necessarily about, as you mentioned, cutting a check that you were happy to cut, but also potentially selling items in your home to pay for some of these treatments. These are things that patients sometimes don't share, but it's important for us to know and understand. I think also your story is so riveting because of who you are and what you're about. And what I mean by that is you're young and you're having children and you are having recurrences of C. difficile between pregnancies. This isn't what the textbook says C. difficile should look like, but I think this is really, unfortunately, what all of us as clinicians need to be thinking about. So thank you so much for sharing with us. I think it was really, really powerful and very helpful. So we're now going to shift gears, and I want to introduce Bruce Hirsch. Bruce is an attending physician and infectious disease specialist at North Shore Hospital on Long Island. He's charged with a challenging topic, the pathophysiology of C. difficile. Bruce, thank you so much for being here.
Thank you so much, and thanks for the 15 minutes that you've given me to be able to have this project to discuss this topic. On the next slide is how we usually see C. diff. This is how scientists, this is how ID docs see C. diff, a gram-positive spore-forming obligate anaerobic bacteria. But we cannot just see C. diff in this image. And I have within me hundreds and hundreds of patients that I've worked with. And I'm reminded specifically today of a case of a healthy 42-year-old man who was jogging, who was active in his garden, who developed a skin infection after an accident and went to a surgeon. He had an abscess that was drained. He was given Cipro and started to have terrible diarrhea, for which he took Lamodal. And we met him when he came into the hospital extremely sick. And I'll say what happened to him in just a couple of slides. So this is the overview: pathogenesis of C. diff-associated disease, disruption of flora, colonization with toxigenic C. diff, toxin production, mucosal inflammation. And on this following slide is an image of what we're about to discuss and how we're going through. The spores come in through the mouth. The spores germinate into the vegetative form. Toxin is generated. Illness occurs. And the pathophysiology of C. diff causes changes in the body. It causes changes in the person. The pathophysiology of C. diff includes the social, the psychological, the spiritual, the economic dimensions of that. And that gets lost on some of these slides, but that's something that is front of mind whenever we care for patients. So it starts with a spore, as illustrated on the next slide. In the bottom right-hand corner, the spore is this amazing, desiccated, stress-resistant vessel of chromosome with layers of protection. And the spore gets into the GI tract. And in the GI tract, in the distal small intestine, it interacts, it's in an environment that's anaerobic, that's favorable to the organism. And it interacts with primary bile salts. Taurocholate is an important one that disrupts the capsule of it and degrades that cortex, rehydrates the spore, and that spore germinates. It goes into the active form. The active form, if it's in a limited nutrient environment, will later sporulate itself if it's exposed to antibiotics. And the sensing and the activation, the generation of transcription factors, this onset of a transcriptional program generates this kind of amazing architecture where there's asymmetric division of the cell. A mother portion of the cell readies the forespore and generates a spore once again. And it's this dimorphic quality that allows spores to be in our environment. And spores persist in the environment sometimes for months and months and months, and renders community-acquired C. diff a real epidemiologic problem. In the following slide, the undisturbed microbiota protects us from C. diff. And the commensal bacteria, they generate short-chain fatty acids. They have a barrier function. They crowd out C. diff. The commensal bacteria metabolize primary bile acids to secondary bile acids, and secondary bile acids are directly toxic to the vegetative bacilli. And on the right side of the slide, antibiotic disrupted microbiota, the commensal bacteria are less in number. Sialic acid is readily available. Succinate is present, and these are food sources for vegetative form of C. diff. And the commensal bacteria are no longer available to be able to generate the secondary bile acids that keeps C. diff in check. And the vegetative form is able to proliferate, and the proliferating C. diff makes toxins. On the next slide. And on the next slide, toxins are generated. They adhere to the surface of the lining of the intestine. They're endocytosed, they're activated, and once they're activated, they attack the cytoskeleton. They inhibit actin proliferation, and they cause necrosis inside of these particular cells, disrupt the tight junction, and the barrier function protecting all of us from the greatest concentration of bacteria in the body in the lower GI tract is disrupted. There are a number of different toxins that are generated. Toxin B, as mentioned, seems to be the most important one. There's also toxin A. These toxins glycosylate and inactivate the Rho and RAC GTPases. The actin cytoskeleton is disrupted. The other proteins that are also generated in this process, TCDR is a promoter. TCDC protein is an inhibitor of some of these toxins. TCDE helps facilitate generation of toxin. There's another toxin called binary toxin, which seems to be associated with increased virulence, and it's a factor that's associated with the hypervirulent strain that was described in 2005, the BI NAP1027 strain. Flagella present on the bacteria, type 4 pili, these are all virulence factors that increase the intensity of the C. diff experience. And on the next slide, it's illustrated how there's necrosis that's generated. There's disruption of that barrier, and there is a host inflammatory response. And there's generation of inflammatory messengers, pro-inflammatory cytokines and chemokines, IL-8, CXLI, L1, CCL2, inducing and generating an inflammasome, generating IL-1 beta, IL-22. Cytokines are recruiting the host response, and fluid is coming into this inflamed area. And the fluid is part of the diarrhea experience. IL-23 is generated and recruits neutrophils, polymorphonucleoleucocytes, and generate antimicrobial peptides, reactive oxygen species. And some of these inflammatory mediators does do damage to the host tissue, but this is part of the host response. And the host response is part of the resilience of the human body. The body is vigorous in its defense of being able to cope with C. diff, and very, very frequently, C. diff is able to resolve. In the worst cases, on the following slide, an example of more severe C. diff is pseudomembranous colitis, and that's present on the next slide. And pseudomembranous colitis is intense inflammation, and you see pus cells, you see purulence, you see these islands of abnormality. This is all an intense inflammatory response. And on the next slide, you can see microscopically that the normal fine architecture of the lining of the intestine is destroyed, it's inflamed, it's disrupted, and that cap on the top consists of polymorphonucleoleucocytes, inflammatory cells, and dead cells. And in the most severe cases, is illustrated on the following slide. And this is what happened to the case that I described before. Next slide, please. This is pseudomembranous colitis. You see, this is toxic megacolon complicating pseudomembranous colitis. And on the CAT scan images on the left and in the middle, the colon is markedly dilated. And the colon, which is a protective reservoir protecting the body, becomes an inflammatory mass, leaking bacteria, threatening the health of the person, inducing clinical sepsis. And in the case that's illustrated in this New England Journal of Medicine image, the colon had to be resected. This person required a colectomy. And that's what happened to my patient. With the combination of an inappropriate antibiotic, ciprofloxacin, in an area where in a time years ago when the hypervirulent strain was more common, characterized by increased virulence and fluoroquinolone resistance, at a time that this patient took Lomotil, paralyzing the intestine's ability to have diarrhea, to liberate the colonic contents from bacteria and toxin, the colon explodes and a colectomy was required. And my patient went from healthy and jogging to requiring a colostomy, but saving his life and being able to preserve his survival. Restoration of the microbiome has been unbelievably effective. And this is that trial of fecal microbiota transplant. And in the following slide is an article put together by myself, and the next slide is an article put together by myself with the help of Gerard Honig, who's the current president of the C. diff Foundation. And we developed a version of oral administered capsules to be able to do FMT, to be able to capture the power of the microbiome. Next slide. These bacteria that live inside of us, that are part of us, that are disrupted by our lifestyles, that are disrupted by our diet, that are disrupted by antibiotics, is something that we're still struggling to understand and to take advantage of. And on the next slide is a study that I was able to perform with some of my colleagues here at Northwell. And we looked at the long-term healthcare consequences of being hospitalized with C. diff. We did a propensity score matching study. We looked at 3.7 million hospitalizations in New York State between 2014 and 2016. We picked out the 29,000 cases of C. diff. We did propensity matching, and we found on the next slide that there was a increased frequency of rehospitalization, increased length of stay, and increased mortality that persisted for 6 months after that period. The pathophysiology of C. diff is a disrupted microbiome. It is exposure. That spore germinates inside the GI tract. The toxigenic C. diff makes toxins. Our body fights against the organism. It neutralizes the toxins. Occasionally, the toxins cause severe complications. C. diff has profound consequences for human beings with C. diff, with suffering, with stigma, with psychological isolation. A metabolic product of C. diff, P-cresol, is responsible for that special stink of C. diff stool that marks the person as C. diff. The pathophysiology of C. diff involves basic issues of health and basic biology. So in the final slide, I wish that that on the upcoming lunch, I'm here on the Eastern Coast, that your diet looks a lot like this picture, and that you and your microbiome be healthy and be well. And it is an honor to be here, and it's a real pleasure to be able to speak today. And thank you so much for your attention.
Bruce, wow, thank you so much. You took a really complicated topic and you passionately weaved it together with a patient experience. So I really appreciate the information that you just conveyed. Next, we're going to be shifting gears and we're going to focus on risk factors for C. difficile. Without understanding risk factors, we don't know who's at initial risk and we don't know who's at risk for recurrences. So it is my distinct pleasure to introduce Dr. Vincent Young. Dr. Young is the William Henry Fitz Butler Professor of Medicine at the University of Michigan School of Medicine and an expert in C. difficile infection. Vince, the podium is yours.
Hi, thanks, Paul. Thanks for the introduction. I am going to be talking about the risk factors for C. difficile infection today. And actually, this does spring directly from the great talk that Bruce just gave us. I have a couple conflicts of interest, but I won't be discussing any off-label use of any FDA-approved therapies. So if you look at any of the papers that list risk factors for C. difficile infection, it's antibiotics first and foremost, and we'll be discussing that quite extensively during the rest of the talk. But there are many other risk factors, clinical risk factors that people have noted, use of other drugs such as proton pump inhibitors, just increasing age in general, healthcare exposure, patients who are in the hospital a lot or have greater risk of C. difficile, comorbid illnesses, in particular inflammatory bowel disease is one that I'm very interested in, and both are thought to be related to the microbiota, so that makes sense. And of course, if you alter the GI tract through abdominal surgery, you're having tube feeds, and on and on. So there are a number of things that are potential risk factors for developing C. difficile in any given patient. But it is antibiotics. And why? Why is that? Bruce talked a lot about the production of toxins and the C. difficile spores that germinate, producing vegetative C. difficile. But one thing that I like to study quite a bit in my lab, and a number of my postdocs over the years and graduate students have studied, how the normal microbiota mediates the so-called colonization resistance against C. difficile. And as Eric pointed out earlier, people can get exposed to C. difficile spores and transiently shed it, but if they have a normal microbiota, they don't go on to disease by the production of toxin and the production of disease, and then potentially recurrence. So it's the disruption of a normal microbiota, and many of the risk factors that I mentioned previously will result in a susceptible, disrupted microbiota. Well, how do antibiotics do this, and why is this actually important? Well, this idea of colonization resistance, it's mediated by the microbiota in a number of possible different ways. Microbes can compete with C. difficile for nutrients. Also, certain members of the microbiota can do things like disturb bile acid metabolism. Bruce mentioned this. A work from my postdoc, Casey Terrio, looked extensively at how bile acids not only affect germination, but can directly inhibit C. difficile. Microbes can produce products that are directly toxic to C. difficile itself. And the microbes can signal through the host, altering the immune response that can further limit C. difficile. So antibiotics, by disrupting the indigenous microbes present in our gut, can actually affect all of these functions that mediate colonization resistance, thus making us susceptible to colonization and ultimately disease from C. difficile itself. So I would like to talk a little bit about how people have looked at the risk of different antibiotics. When people say, oh, antibiotics can cause C. difficile, that's true. But there is a relative risk for any given antibiotic, and also how the antibiotics are given. So this is a study that was just published last year in Open Forum of Infectious Diseases, where they looked at different antibiotics and compared the risk for community-associated C. difficile. Dr. Gu had mentioned that community-associated difficile is on the rise, not just hospital-acquired. And they wanted to look in the community-associated case, what antibiotics can lead to C. difficile. This was a huge study. They took almost 1 million patients here in a 1-to-5 match, and it was a case-controlled study. They took 160,000 cases of community-acquired C. difficile and matched 1-to-5 with healthy controls that did not develop C. difficile. This was a big database. It included Medicaid, Medicare databases, and commercial databases. They did logistic to regression to try to figure out, based on which antibiotics, and if you look at the patients here, about half of the cases of community-acquired C. difficile, half those patients had taken antibiotics, but also some of the patients had taken antibiotics the controls had taken antibiotics and did not develop C. difficile. They did sensitivity analysis also based on the time of exposure, looking at how long it had been since a patient had been given an antibiotic. So this is not going to be a surprise to anyone. The most high-risk antibiotic was clindamycin, okay? And as Christian can tell us, unfortunately, that was the antibiotic that his mother was given prior to her contracting C. difficile infection. They also showed that the later generation cephalosporins, many of which have anti-anaerobic activity. In other words, they affect anaerobic microbes. And you should know that about 99% of the microbes that are present in your normal microbiota are actually anaerobic bacteria. There are other antibiotics that have less risk. Tetracyclines actually have very low risk of triggering, not zero, but lower risk of triggering C. difficile when compared to something like the later generation cephalosporins or clindamycin. They also looked at the time, and what they showed is over time, if it's a longer period of time, like say half a year since you were given the antibiotics, for all antibiotics, the risk decreases. In some cases, it can decrease to the point that it's nearly zero. And that's really thought to be due to the fact that we're allowing the microbiota to recover after you've given the antibiotics. But in some cases, it takes a long time. So this really brings up the idea of antimicrobial stewardship. You know, you should only prescribe antibiotics when they're truly needed. You should actually supply the most narrow spectrum antibiotic. You should actually think about educating the staff that not every sniffle, not every cough requires antibiotics. Because what we're doing, we often hear about antimicrobial resistance, but we're also protecting the microbiota by practicing antibiotic stewardship. So in the last couple slides, I want to just say that this idea of antimicrobial stewardship and protecting these anaerobic microbes is actually important in many different forms. Of course, we've heard about it for C. difficile, but there was a recent study published by some of my colleagues here at the University of Michigan that looked at what happens if you have patients with suspected sepsis and you gave them two different antibiotics, piperacillin tazobactam, which does have activity against anaerobes, or cefepime, which is relatively broad spectrum but does not affect anaerobes to the same degree as piperacillin tazobactam. And this was basically sort of a natural experiment. There was a shortage of piperacillin tazobactam for a period of time in the year 2016. And during that time, if you looked, the use of piperacillin tazobactam plummeted during the period of shortage, and cefepime was sort of replacing most of that. And then when the shortage went away, people went back, physicians are creatures of habit, went back to the habit of using piperacillin tazobactam as opposed to cefepime. And the primary outcome that Dr. Chandraraj and his colleagues looked at was 90-day all-cause mortality, not specifically due to sepsis. They didn't look at C. difficile on top of that. And they looked at about 8,000 patients and compared those. They made the assumption that cefepime and piperacillin tazobactam were equally effective in patients with suspected sepsis and equally had equal amounts of risk. And what they found that wasn't true. When they looked at mortality, there was an increase in mortality, overall mortality in patients who received an antibiotic that had anti-anaerobic activity compared to one that didn't. And when they did their sensitivity analysis, they found out that there was about a 5% increase in mortality if a patient was given an antibiotic that had anti-anaerobic activity on an empiric basis compared to one that wasn't. So this is really something that we have to think about. Antibiotics are great. Antibiotics have really improved healthcare, but they are not without risk. And so really the idea of protecting the microbiota is very important, not just to prevent antibiotic resistance, but to protect against all-term mortality and of course against C. difficile. So I'd be happy to take any questions. I know that the questions will be emailed, or you can email me a question directly at my university email address. And I thank you for your attention, and I thank the organizers for the chance to speak.
Vince, thank you so much. That was really wonderful, and I appreciate the Dolly references in the end. I am not sure if our next presenter is present. So I would just appreciate an update on that. They just got here. Excellent. So, what Vince really covered is what a clinician needs to be thinking about when they approach a patient. Which antimicrobials were they exposed to? If they were exposed to antimicrobials, what environment do they live in? What are their demographics? What are really their risk factors, so that we can contextualize that information with what Eric spoke about earlier with regards to diagnosis and using the tools most efficiently with regards to detection of toxin versus detection of the organism and what's available to the clinician themselves. Now, I want to shift gears because our next speaker is an individual, Dr. Mary Beth Nicholson. So she is an assistant professor of pediatrics in the Division of Gastroenterology at Monroe Carroll Jr. Children's Hospital at Vanderbilt. She's going to be discussing pediatric C. difficile infection. Now, one of the things that I was always taught as a medical student is, look, kids are not smaller forms of adults. Kids are different. And in disease state after disease state or infection after infection, kids present differently. The way that we diagnose them might be a bit different. The way that we manage them is different. So I am absolutely delighted to introduce Dr. Nicholson. The stage is yours.
Hi, thank you all for the opportunity to speak to you today. And I really want to thank the Peggy Lillis Foundation for really remembering this pediatric perspective, because we know that we see C. diff in kids now, and we know that we can see it at high rates, and we can see a lot of outcomes associated. So I'm really happy to be here today and grateful for the Peggy Lillis Foundation for advocating for our pediatric patients. So I've been working now on C. diff for 10 years, and I'm not going to dig too deeply into the epidemiology because Dr. Gu did such a great job today. But I do want to speak a little bit about kind of how I got in this landscape and what we've seen in our pediatric patients. So I've been studying C. diff in kids for 10 years now, and kind of this is the landscape when I was first studying this, with which most of you are really aware of. We saw a dramatic increase in hospitalizations from 2000 to 2011, leading to 500,000 infections and 29,000 deaths in 2011. And that same time, we were seeing a dramatic increase in the incidence in our pediatric population. So I think we classically thought this was a disease of the elderly and infirm, as Dr. Fertstead had mentioned, but we were also seeing the same increases in our pediatric population. So this was overall crude increase of 9% per year over this study period in hospitalized children, with happening across all age groups except those less than 1. And it's previously been mentioned, we see more colonization in that group. And though we were seeing this in hospitalized children, we are also seeing a really dramatic increase in the rate in our pediatric outpatients. So this is from non-hospitalized children, demonstrated a 12.4-fold increase incidence over this period, with the most dramatic increase between 2004 and 2009. And this is also around the time that I met one of my first patients with C. diff infection. So I'm going to walk you through kind of Caleb's story a little bit here today as well. So Caleb was 4 when I first met him. He was really otherwise healthy. He had a history of a cow's milk protein allergy in early life, but otherwise was a healthy child. And he presented with acute onset of watery diarrhea and abdominal pain. He had received antibiotics prior to this initial presentation for an ear infection, and he tested positive for C. difficile infection at that time. And so I want to come back to Caleb because that's not the end of the story for him, just as that's not the end of the story for so many of our pediatric patients. And Dr. Gu presented this data that they had previously published. So I'm not going to spend a lot of time, but I do think for the first time, it's very exciting that we've seen overall kind of leveling in the incidence and perhaps even that decline that was mentioned in those hospitalized patients. We decided to look at this at a more pediatric glance, and we published this in the Journal of Pediatrics in 2022. And showed really similar findings to what Dr. Gu had seen in this kind of United States-wide landscape, is that for the first time, we were seeing an overall kind of leveling of that incidence in our pediatric population. So this was from 2013 to 2019. We showed a decrease of CDI in our hospitalized pediatric patients of 7.1 cases per 10,000 patient days to 4.9 cases per 10,000 days. And this was across all age groups that we saw this. So this was really encouraging data as well. We looked a little bit more in terms of who these kids were. And so the median age was 7, and about half of them were female. One of the things I always tell my patients when we think about C. diff in kids, and one of the reasons I do think C. diff in kids is not as recognized or maybe doesn't receive as much attention, is that overall the mortality that we see in our pediatric patients is dramatically lower than those numbers we saw earlier that are reported in adults. So the all-cause 30-day mortality after C. difficile infection in children was 1.9%, which again was much lower than what's been reported in adults, and is really a wonderful thing. The rates of gastrointestinal perforation were also low, and rates of colectomy were also very low. And when they did occur, it was usually in kids that have an additional diagnosis of inflammatory bowel disease, which we know is an independent risk factor for a colectomy. In terms of who these children are, I think those of us that care for children are not particularly surprised by this slide. So the bulk of these children have an additional chronic condition. So 75% of them will have an additional diagnosis. Most commonly, these are children that have a gastrointestinal condition or inflammatory bowel disease. They have a hematologic condition or immunodeficiency, and a third of these patients had a diagnosis of malignancy. I want to be clear, though, just like I demonstrated with Caleb, the patient that I mentioned, is that means that 25% of these children don't have a chronic condition. And so I think just because we have children that are otherwise healthy does not mean that we cannot think about C. diff when they present with concerning signs and symptoms. So let's go back to Caleb, because I mentioned the story wasn't kind of over for him. So Caleb ultimately developed pretty severe symptoms. He had bloody diarrhea and fevers. He had an elevated white count greater than 20,000. And he actually developed rectal prolapse, which is an issue where the rectum kind of prolapses through the anus and can require manual reduction. And he was hospitalized due to the severity of his symptoms. He was treated with IV metronidazole. He was placed on bowel rest, so he was not allowed to eat during that time due to the severity of his disease, and he received parenteral nutrition. Ultimately, Caleb discharged home, and he had a lot of new toys, as he should after a 14-day hospital stay here at Vanderbilt. Unfortunately, that wasn't the end of the story for Caleb, and I think that's not the end of the story for so many of our pediatric patients, and why I really think it's important that we consider them while we're designing clinical trials to study new agents. 4 weeks after he went home from the hospital, he again had a return of diarrhea, again with rectal prolapse, again tested positive for C. diff. He was treated with oral vancomycin, but again, due to the severity of his symptoms, he was rehospitalized. And so I mentioned how the severity in our pediatric patients is much less than has generally been reported in adults, and for that, we're incredibly fortunate. However, the rates of recurrent disease in children is just as high as what we see in the adult population. So 20 to 30%, so a third of our patients are going to have an episode of recurrence. And we know those can be associated with increased morbidity and mortality. And once you've had a single recurrence, the rates of having additional recurrences just dramatically increases to 40 to 60%. There's a lot of theories why this occurs, and I know some of that's already been covered and some will be covered later. But this is certainly a major problem that we see in our pediatric population. We've previously looked at some risk factors for recurrent C. difficile infection. Kids with a diagnosis of malignancy, which are already a really highly affected population, have significantly higher rates of recurrent disease, as well as those who have recent surgery and those that have had a higher number of antibiotic classes. I think we've talked before, and I think a lot of the epidemiology that we're seeing with C. diff now is related to the fact that we are having really impactful antibiotic stewardship measures, and I think we really need to continue those. This was a study of 170 pediatric patients, and one of those children had received 8 separate classes of antibiotics in the 30 days prior to their initial infection. So we can only imagine the degree of dysbiosis that patient would have. Additional risk factors published by Larry Kosciuszko's group out of the University of Chicago in kids are malignancy and the presence of a tracheostomy tube. And so I want to just switch gears kind of to round things out and talk a little bit about treatment, because this also is an area that differs for adults, and where I think we also need to be really mindful about considering these pediatric patients. So what currently is recommended for adults for the initial episode is vancomycin or fidaxomicin. Pediatric guidance still includes metronidazole, mainly because we don't have great evidence demonstrating differences in outcomes associated with vancomycin and metronidazole in the pediatric population. For an initial episode of severe or fulminant disease, you can use vancomycin with or without IV metronidazole. That's similar to the adult guidelines. For first recurrence, you can repeat the regimen, and then subsequent recurrences, we think about vancomycin tapers, pulse, or the use of fidaxomicin, which is FDA approved, fortunately, in kids. Subsequent recurrences can be treated with FMT. So there's just some differences in terms of what we think about for adults versus children. I will say clinically, I use vancomycin first line for my pediatric patients. I think overall, there is some evidence of a quicker resolution of symptoms in the setting of vancomycin treatment. Also, it tastes better, which I actually have to consider heavily in terms of our compounded medications, is associated with less GI upset, less vomiting. For first recurrence, I use fidaxomicin. I mentioned that's FDA approved down to 6 months of age, and that comes in an oral suspension or a capsule that's twice a day dosing and is really a great option to have for our kids. I do want to just briefly talk about FMT. This is going to be covered in a variety of forums later, but I wanted to talk a little bit about our pediatric experience and where we probably need some of your all's help and support. So FMT, we know, is loosely defined as taking stool from a healthy individual and instilling it into a sick person to cure a specific disease. We were fortunate, and I was very fortunate to partner with our Pediatric GI Society. NASC began under leadership of Richard Kellermeyer and Stacy Kahn, and really collect a multi-center experience of pediatric FMT. So this included 18 centers and over 335 pediatric patients who underwent FMT at these pediatric centers and had associated follow-up. Those that had an FMT, the cure rate was 81% for a single FMT, and cure was defined as they didn't have an episode of recurrence in the months to follow that initial FMT. In those that did have a recurrence and had repeat FMT, we were able to take the cure to 86.6%, which is really pretty astounding when we know that continued antibiotics do not have nearly the same effectiveness at decreasing risk of recurrence. And also, I think really reassuring news is that only 2 of these pediatric patients had any type of FMT-related SAE. Both of these were hospital stays. One was due to an aspiration pneumonia with FMT delivered via an upper route, and another one was a hospitalization for abdominal pain and diarrhea after delivery via colonoscopy. Both patients fully recovered and did well. So let's go back to Caleb, and he actually did have an FMT due to the severity of his disease, and has done really well in terms of C. diff since that time. But I think what Minnie and Spencer were talking about earlier, and some of the other concerns about anxiety around C. diff infection, is that this is certainly an acute infection, but it also has really chronic consequences. And so I actually took care of Caleb first 10 years ago. He's now 14. And I continue to care for him because he has significant abdominal pain. He's been diagnosed with post-infectious irritable bowel syndrome. And I do think as we consider C. diff, we need to consider these downstream consequences as well. I think that's very important in our efforts moving forward. So this is going to be covered in more detail later too. And so I'm just going to briefly touch on this. But we know that microbial therapeutics are really on the landscape. We now have 2 FDA-approved medications for this, which is very exciting. And this is defined kind of as, I always think of it as bugs as drugs. So human-derived bacterial consortia that can be used for the treatment of human disease. And I think some of the benefits we think about when we think about these biotherapeutics versus FMT are things like standardization, safety, and as well as practicality. But I really need to mention that we have to consider our pediatric patients as we consider these microbial therapeutics. Certainly, I mentioned we don't see the same numbers of C. diff in peds that we do in adults, nor do we see the same degree of severity. But we do see a lot of children that have C. difficile-related disease, and it does significantly impact their lives. So we are interested in developing better care of these pediatric patients. We know that a lot of the formulations that are currently being studied and approved are either capsule or enema preparations, or they require a clean out prior to dosing. And I think all of these are really not particularly pediatric friendly approaches. The 2 currently FDA approved medications have not, I'm not aware of an ongoing clinical trial to look at those in kids. There is, Vedanta has a clinical trial that involves 12 and above, but I think we really need to be thoughtful about considering pediatric patients in this landscape. So I think we're at like this hedge where we really need clinical trials. We need the FDA approval of some of these measures, or we're really going to lack access to effective treatments for recurrent C. diff in children. And since I presented some of our data, I just want to thank some of my collaborators and the work with the FMT Special Interest Group. And I thank you for your time.
Hey everyone, so thank you so much to our amazing speakers from this morning. I mean, I certainly learned a lot. And we will be back at 12:30 to continue the symposium. So please take the next 30 minutes to have a bite, rehydrate. We have a really exciting afternoon planned for you. So we will see you back here at 12:30. Have a good day, good afternoon, good break, whatever.
Welcome back, everybody. Hopefully you had a couple of minutes to refresh and get some nutrification. What a great morning we've had so far. We've covered a lot of important topics. We've had dynamic speakers. We've had great patient interactions. So we have so much to learn this afternoon as well. One of the best ways to minimize and prevent C. difficile infection is infection control. Dr. Hu is an expert in infection control, as she is an infectious disease specialist with the Jefferson Medical Group in New Jersey. There, she is the chair of Infection Control Committee, Antimicrobial Stewardship Committee, Sepsis on the Floors Task Force, and the C. diff Task Force. I'm not sure how she has time for her personal life. With that being said, Cindy, thank you so much for being here. The stage is yours.
Hi, good afternoon, everybody. Thanks for joining us today. My name is Cindy Ho. I am infectious disease, and I'm part of the Jefferson Health System. It is growing. The mothership hospital is in Philadelphia, but it's expanded to include the Lehigh Valley hospitals in Pennsylvania. And so even though I'm on the Jefferson Health New Jersey side of things, I'm actually reporting to you live from one of the Lehigh Valley hospitals in Pennsylvania. So let's talk about infection control. And I thought instead of talking about guidelines, I thought I'd pick something that perhaps maybe not everyone is aware of. And that is that the CDC has something called TAP, and that stands for Targeted Assessment for Prevention Strategy. It's actually a quality improvement framework, and you want to target for action and identify facilities and units with the greatest burdens of HAIs. It's actually been used for catheter-associated urinary tract infections, or CAUTI, CDI, which is Clostridium difficile infection, and CLABSI, which is central line-associated bloodstream infection. So the A stands for assessments to identify areas of prevention and opportunities for improvement. And then the P is for prevent. So I apologize for the rather dry nature of the slides, but there's a large section that is related to the CDC of what it appears when you use this assessment. And then there's portions of other survey assessments that I'll show you. So the first is just from the website, which was last updated by the CDC on March 28th. And it just talks about TAP, that it's free and available for download. In addition to that, the CDC gives free support to healthcare facilities, health departments, health associations, and other partners that want to make an assessment. And importantly, I'll highlight that email address, HAIprevention@cdc.gov, whom I just emailed yesterday. I would say their turnaround time is fairly quick, probably within 24 hours, as long as it's not a weekend, of course. And when you sort of go to that website and you might click on this PDF, it's called CDI TAP Facility Assessment Tool. And you basically go through the motions. The actual PDF is maybe around 10 pages, but I've separated them out and I'm going to talk about different sections. And it's basically to capture awareness and perceptions of policies and practices related to CDI prevention. And many of them are evidence-based. So this is just another way of going through the tools for infection prevention against C. diff. And I suppose it is very geared toward acute care hospital settings because it says your facility name, your unit name, to identify if this is where you work, might be in the ICU, the med surge, the ER, other, or you work across a facility, and kind of the date of your assessment. If you see here, the way that this is designed is to have the, it's de-identified, right? So you don't have your name or anything here, but you identify your role because you know, the experts, the infectious disease doctors or the infection control officers may very well know what to do to prevent, but it would be interesting to see if things are different or perceptions are different from other roles within the hospital. It could be ancillary staff, EVS, because what if you have a C. diff patient, but they don't know that there could be other things they could be doing? The resident, which is a a junior doctor, maybe it could be administrative leadership, it could be nurse or unit manager, a certified nurse assistant, nurse practitioner, nurse educator, of course, infection prevention, quality, and more. and then your years of experience, and then kind of what shift. And we know that these days there are people like hospice and so forth. And it goes through different sections. It's yes, no, unknown. And the thing of it is that you can print this out as a PDF, or you can actually request from the CDC a website link from either, I believe it was SurveyMonkey, or if you have REDCap, they can give you kind of the build, which I didn't really understand. So I asked for them to build a REDCap survey, because then you can dispense it electronically to different people. But you can see it goes through different sections, such as the general infrastructure, capacity, and processes. And it says, does your facility have a team or workup focusing on CDI prevention? Is there a physician champion, unit level leadership? Is there a unit level based nurse champion? Remember, nurses are secret weapons. For training, do you have training on hand hygiene? We know that hand hygiene is critical for prevention of healthcare associated infections, let alone C. diff. How about a knowledge assessment on hand hygiene, a skills assessment of personnel demonstrating the tasks of hand hygiene, PPE, which is personal protective equipment? Is there training? Is there a knowledge assessment on PPE? And more, such as training on contact precautions. Training continues to say, is there training on environmental cleaning and disinfection? Because what if that room has C. diff spores? And what is the knowledge assessment and skills assessment given to nursing personnel? Who does the cleaning of the equipment? Because what if the equipment has C. diff spores, for instance? So whoever you give it to, they just answer yes, no, unknown for all of these questions. I know some of these are tiny. That's because I'm going to quiz you. No, that's because it just fit on the screen. This is audit and feedback. And this is a critical juncture, because you can say you've done hand hygiene and have assessments like this, but did you audit? So have you audited or monitored for hand hygiene, feedback on performance of hand hygiene, audit and use of PPE, contact precautions, audit and provide feedback on environmental cleaning? You know, because if you're an EVS and you miss a spot, but it's a C. diff room, this might be important feedback from the manager to them, for instance. Antibiotic stewardship. We know that antibiotics are a primary driver for risk for C. diff, and there are different antibiotics that have relative risk for C. diff. So it just asks, does your facility monitor certain antibiotics at high risk for CDI, such as fluoroquinolones, third and fourth generation cephalosporins, clindamycin? And do you also reduce the unnecessary use of antibiotics? Do we educate personnel about the risks of CDI with antibiotics? And do nurses educate patients or family members, for instance? Antibiotic stewardship is very important. It continues to say that, do your nurses play a role in evaluating patients with antibiotic allergies? Often I am told by nurses that a patient has an allergy. And for patients that have new or recent C. diff, do you routinely review appropriateness of antibiotics? Are antibiotics reviewed after a few days, for instance? Do nurses participate? Do nurses initiate discussions with the treatment team? And the answer is yes, many times, but it would be interesting to see, depending on the role, if people actually know that, for instance. Early detection and isolation. Is there an indication for C. diff testing? Do people order C. diff for patients with diarrhea, which is 3 or more unformed stools, and there's no other cause? For instance, they're not on laxatives. Do providers avoid ordering C. diff when the patient has a known cause? Why would you do that? Because if it's clearly due to laxatives, then you're not doing a service. And you also, it's not indicated to check for C. diff again after somebody has finished a course. It goes on to talk about contact precautions promptly at the onset of acute diarrhea, or as soon as the C. diff test is ordered, because what if somebody has diarrhea, they're not in contact precautions, and somebody innocently goes in, doesn't know, and they could potentially pass on C. diff. It talks about different other modes of contact precautions, and if stool is collected promptly, because you want to reduce the time of from ordering to isolation and so forth. It goes on to talk about if you talk about case review or potential gaps when a patient is diagnosed with C. diff, what if they're transferred within or outside the facility? There are many questions for contact precautions, such as if you isolate for the duration of diarrhea, or at least 48 hours after the diarrhea ends, or the entire duration of the hospitalization, and more. There are also questions about the cleaning of disposable items, whether their blood pressure cuffs, and when the contact isolation sign is placed, for instance, and if it's confirmed or suspected. The contact precautions, hand hygiene questions go on to talk about gown and gloves and utilization of PPE, as well as the cleaning. So also the hand hygiene after using things like the bathroom, maybe before eating. They sound very simple, but you'd be surprised. For EVS, are high touch surfaces cleaned upon daily or upon discharge? And do nursing staff and EVS staff know which equipment they're responsible for cleaning? It goes on to ask other questions about the type of the product that environmental services or EVS uses to clean. And then this is just a different example that same CDC CDI TAP form is also available for Spanish. Why would you do that? What if you have personnel that speak Spanish and we want to see what their baseline assessment is? So I just have a photo of the first page of that assessment. There's also a separate extensive questionnaire for just environmental services, which I won't go over all of it. Suffice to say that this would be also pretty interesting because they may pay attention to other things that, are not germane, as far as they're not paying attention to antibiotics because that may not be their role. And so the initial survey I talked about might not resonate with them, basically. And one thing that's interesting here is that it says for non-English speaking EVS staff, our training's given in the staff's primary language, right? Because if you don't understand what you're supposed to clean, then, we need to speak in the language and provide guidance for them. This is another item also from the CDC TAP program, which is called a deep dive. And essentially it asks questions in free form, and then it provides responses and kind of hyperlinks if you want the evidence-based medicine, because you will have skeptical people sometimes about the evidence-based measures for infection prevention for C. diff. Last but not least, this is also from the TAP program, which is designed for the lab to assess things like the quality of the specimens sent, does it meet criteria, and so forth. And it's really only 7 questions. The other day I sent this to our lab supervisor and they completed it right away. So it was quite easy. And then I'll end there. And if there are any questions or comments, I'd be happy to answer.
So Cindy, thank you so much. This is obviously such a relevant and important topic for us, and an area where we need to improve as clinicians and as providers. The best way to prevent C. difficile is obviously starting in the process of thinking about infection control. So thank you for that. We're now going to shift gears, and we're going to talk about the treatment of C. difficile. And it's pretty complicated, and recurrence is a major problem. Given this, it is my tremendous honor to host a panel discussion with the lead authors from the IDSA SHE guideline and the American College of Gastroenterology guidelines, Dr. Stuart Johnson and Dr. Colleen Kelly. Dr. Johnson is an emeritus professor at Loyola University in Chicago. As part of the Strict School of Medicine, Dr. Colleen Kelly is an associate professor of medicine at the Brigham and Women's Hospital in Boston. Thank you both for being here. So we're going to start off with 2 short presentations and then discuss the guidelines further together. Stu, can you start us off with the Infectious Disease Society of America, Society of Healthcare Epidemiologists of America guidelines?
My slides should be shown here soon. Okay, sorry, this worked in the back room here first, but I thank you, Paul, for inviting me to speak, and Christian and the Lillis Foundation. So as Paul suggested, I'm going to talk about the IDSA, or Infectious Disease Society of America, and Society for Healthcare Epidemiology guidelines for antimicrobial management of C. diff. So in 2021, we did an update, a focused update, and I won't go through exactly how we developed the recommendations, but it was a very rigorous process, so using the grade criteria, if you will. And I just want to mention the wording here, because this is somewhat important. It's more than semantics, but there are only 2 recommendations, and strong recommendation means that we recommend, and a conditional recommend that used to be weak recommendation means we suggest. And the implication for a strong recommendation that most individuals would want the recommended course of action and only a small proportion would not. And suggest means that, again, the majority of individuals would want this course of action, but many would not. So it gives some leeway for following these guidelines. So the first recommendation was based on a question: in patients with an initial CDI episode, should fidaxomicin be used rather than vancomycin? And the recommendation is that we suggest using fidaxomicin rather than a standard course of vancomycin. This was a conditional recommendation with moderate certainty of evidence. This recommendation places a high value on the beneficial effects and safety of fidaxomicin, but its implementation depends on available resources. And importantly, vancomycin remains an acceptable alternative if fidaxomicin is not available. And although we didn't mention in the update, and the 2017 update, we suggested that in settings where vancomycin or fidaxomicin is limited, that metronidazole was an option for initial episode of non-severe CDI only. The next question was, in patients with recurrent CDI, should fidaxomicin be used rather than vancomycin? And again, here we suggested that fidaxomicin would be used either as a standard course or what's referred to as an extended pulse regimen, rather than a standard course of vancomycin. Here, in addition to being a conditional recommendation, there was lower certainty of evidence. And the comment is important here: the vancomycin in a tapered pulse regimen or vancomycin as a standard course are acceptable alternatives for first recurrence. And this is a bigger conversation, but for patients with multiple recurrences, vancomycin in a tapered pulse regimen, vancomycin followed by rifaximin and FMT are options in addition to fidaxomicin. Now, this rifaximin recommendation was a carryover from the previous set of recommendations and is not terribly practical. This was used when fidaxomicin had not yet become available and was an option in a certain setting. The next question was, in patients with a CDI episode, should bezilotoximab be used as a co-intervention along with the standard care of antibiotics rather than standard of care antibiotics alone? Now, just to remind you, that bezilotoximab is an intravenous infusion of an antitoxin monoclonal antibody. And the recommendation was for patients with recurrent CDI episode within the last 6 months. Again, we suggest using this bezilotoximab infusion as a co-intervention along with standard of care antibiotics rather than the standard of care alone. Now, this is a co-intervention, so this is not a treatment per se, but an adjunctive treatment. And this is to prevent recurrences. Now, the comment section is longer than the recommendation, which tells you something. But it places a high value on the potential clinical benefits, but implementation is often limited not just by cost here, but feasibility considerations. And that means that in many places, the infusion center is where this is given, not in the hospital. It's usually not on the hospital formulary. So a patient has to be referred to an infusion center. And in settings where logistics is not an issue, a primary episode of C. difficile, this might be considered as well. with other risk factors for recurrence, such as age greater than 65, immunocompromised, severe CDI presentation. In patients that didn't have these risk factors, there was actually no benefit. And in patients, the last thing I want to mention is that in patients with a history of congestive heart failure, it should be reserved based on a benefit risk association. So the study found an increased evidence of CHF exacerbations and death actually in patients that had this underlying condition. It's not clear that this was associated with the infusion. It may have been true and unrelated, but that caution remains. And then the last recommendation really was not from 2021, but this was back in 2017. And patients with a fulminant CDI, this is what we recommended, was oral vancomycin orally, and if ileus present, then give it per rectum, and intravenous administered metronidazole in addition, particularly if ileus is present. And then if surgical management is necessary, perform a subtotal colectomy with preservation of the rectum, or this diverting loop ileostomy that has been shown here, where basically vancomycin is instilled in the cecum, and then it's after a lavage with saline, and then it is delivered directly to the vancomycin is delivered directly to the colon. Again, these are very empiric recommendations. There's certainly no randomized controlled data for this, and I'll just leave it at that. Those are the main recommendations that we have for managing CDI.
Stu, thank you so much. We appreciate it. We have the ID side of things, and now we're going to get the GI side of things from Dr. Colleen Kelly. So Colleen, take it away for us.
Hi there. They've got the slides up for me. I'm Colleen Kelly. For those who don't know me, I'm at Brigham and Women's Hospital in Boston. My areas of interest are C. diff, obviously, FMT and inflammatory bowel disease. Next slide. I was fortunate enough to be lead author of the most recent American College of Gastroenterology treatment guidelines for C. diff. Had a great team. And next slide. I was also a co-author on the most recent American Gastroenterological Association guidelines on fecal microbiota-based therapies. Next slide. And I'm going to draw from both of those in this talk today, those guidelines for treatment and prevention of recurrence of C. diff. So before we dive in too much, I just want to kind of compare the available options, which we all know, but just to kind of lay it out a little bit. We have metronidazole. It's been around forever. It's practically free. The rates of recurrence after treatment with metronidazole are similar to vancomycin. However, there's increased resistance to that antibiotic, which has become, like all drug-resistant infections, more and more over the years, and therefore we're seeing more treatment failures after metronidazole. Then in the middle there, we have vancomycin. It does have some resistance that's been reported, but none of it which is clinically significant. It's effective for most infections. It costs about $155 for a 10-day course. And then finally, fidaxomicin. It's being that it's more narrow spectrum. It was more recently developed. It is more expensive. It's over $4,000 for a 10-day course. But because of its more narrow spectrum activity, it has been associated with decreased recurrence rates after treatment of the infection. It's about 16% versus 25% after treatment with vancomycin, and reduced susceptibility to this is rare. Next slide. So for putting this all together and the available options, American College of Gastroenterology decided to, for an initial episode of a non-severe infection, to give clinicians a choice. And you could either give a patient vancomycin, 125 milligrams 4 times a day for 10 days, or choose fidaxomicin, the standard dose 200 milligrams twice a day for 10 days. And the reason we decided to make it a choice rather than elevate fidaxomicin was in part that expense for patients. If you're looking at reducing costs overall, you got to treat about 11 patients to prevent one recurrence with fidaxomicin, which to treat those 11 patients takes it up to about $48,000 for all those antibiotics, as opposed to about $1,700 if you were to treat them all with vanco. But for an individual patient, I've seen people paying as much as $1,500 for a treatment course. There can be delays at the pharmacy, waiting for prior authorizations, and other issues. So we felt that since both are effective, that either could be utilized. We also, differing from the ID guidelines, still allow metronidazole to be used, but under very limited circumstances. This is very young patients with mild infections, outpatients, no comorbidities, but that metronidazole could be considered. However, you want to switch to one of the other antibiotic choices if there's not improving within a few days. Next slide. Then for severe infections, you'll notice we took metronidazole out of there, cannot be used for a severe initial episode. Severe infections, elevated white count, renal insufficiency, you can choose between vancomycin and fidaxomicin also, though we did say there was more limited data to support fidaxomicin in patients with more fulminant or life-threatening illnesses. Next slide. For fulminant infection, these are the very sick patients, often in the ICU. We did have a surgeon on the guidelines with us who talked about adequate volume resuscitation, getting your surgical colleagues involved early, doing some imaging to make sure there hasn't been a toxic megacolon or perforation. And these are the ones you kind of throw the book at it. High dose vancomycin, 500 every 6 hours. We made a strong recommendation for that, though based on very low evidence. And adding metronidazole, especially in patients with an ileus, to get antibiotic to that colon, and rectal vancomycin enemas can also be used and may be beneficial. Next slide. The ACG also talked about using FMT in this scenario with acute, severe, and fulminant infections. That this should be considered, particularly in patients who are poor surgical candidates. Made a strong recommendation for that. Many are familiar with this Fisher protocol, essentially giving sequential FMTs colonoscopically with ongoing vancomycin treatment. Monica Fisher published a very successful single center series where 91% of those patients maintained cure at 1 month. And these were very sick people. 7 of them, in fact, had toxic megacolon. This has been repeated at other centers. There's another Italian center who also showed repeat FMTs in these scenarios are more effective than a single dose. And I will talk a little bit more about the FMT later. Next slide. So then recurrent C. diff. What is recurrent C. diff? Defined as symptoms of diarrhea, which return following successful antibiotic therapy. And that's usually 99% of those recurrences will happen within 8 weeks. ACG guideline did go into a little bit of like what is not recurrent C. diff. Patients after a course of C. diff therapy may have ongoing IBS or other etiologies of their diarrhea. So if symptoms are atypical, if they're not getting better with vancomycin, you always want to consider alternative etiologies for those diarrheal symptoms rather than just treating C. diff over and over, which may not be effective. We don't recommend testing for cure. In an asymptomatic patient after a course of treatment. I've seen patients who come in feeling fine, but someone keeps testing stool, finding C. diff, and treating them over and over. And again, just remembering that post-infection IBS is common. So if they have any constipation with this or any very anything short of 3 or more watery stools a day consistently, you want to think outside the box that this might be something else. Next slide. So for recurrent infection, it's pretty easy. Basically, we say treat that first recurrence with something different than you used the first time. So if you used vancomycin or metronidazole for that first infection, you're going to want to treat the second infection or first recurrence with fidaxomicin. If you already used fidaxomicin the first time, then switch to maybe a tapered pulse dose, longer course of vancomycin. We made strong recommendations for both of those. Next slide. And then what are you going to do to prevent further recurrence? This is when you think, once the patient's had that first recurrence, what are you going to do to, try to keep this from happening again? Immunotherapy, as Stuart talked about, we have bezlotoxumab. This was based on the idea that some patients don't mount an antibody response and are at higher risk for recurrence. This is a monoclonal antibody specifically directed against toxin B that blocks effects of those toxins. It's also very expensive. A single, just the drug cost is $4,000. It did show decreased recurrence rates Kind of similar, 16 to 17% after Beslo versus 26 to 28% after antibiotics, giving a number needed to treat of about 10 patients to prevent one recurrence. Our guidelines also suggested for considering it in patients who were at high risk of recurrence only. And that population, very specifically patients over 65 years old, benefited the most. And especially if they had an additional risk factor, such as this being their second episode in the last 6 months, or if they were immunocompromised, or if they were hospitalized with a severe infection. Next slide. ACG also, as most of the authors were very familiar with FMT, made recommendations to consider FMT sooner in recurrent C. diff. So after a second or further recurrence, that's a third episode of C. diff, that it would be appropriate to offer a patient FMT. We did say that it could be offered sooner in patients who had had particularly morbid infections, very severe. You didn't necessarily need to wait for them to get sick a third time. We recommended dosage of delivery via colonoscopy or capsule and enema if those were not available. And that if patients suffered a recurrence after that FMT, that it was okay to go ahead and do a second FMT. Next slide. We also didn't make a lot of friends in the probiotic industry by taking probiotics out of the equation for C. diff infection. Neither the PLACID trial, which looked at probiotics as a primary prevention strategy, that's someone who hasn't yet gotten C. diff but is at high risk and getting antibiotics, nor patients who've already had C. diff where you're trying to prevent additional recurrences. Neither group benefits from treatment with probiotics. They can be expensive. They can actually disrupt the normal microbiome kind of coming back after an infection. So we recommend against probiotics. Next slide. And then our next sort of controversial and somewhat differing than the ID guidelines was the use of suppressive prophylactic vancomycin. You do have patients who either fail multiple FMTs or are not a candidate. This might be your patient in a nursing home who's very frail and maybe with a limited life expectancy, who's getting repeated courses of antibiotics for something like frequent UTIs. Every time you do an FMT, that gets kind of undone by antibiotics. That it is okay to keep some of those patients on just a low dose, 125 milligrams once or twice a day of vancomycin to prevent C. diff from coming back. Oral vancoprophylaxis could also be considered in someone who'd had a recent episode and are at high risk for recurrence. This is someone who might have just gotten over C. diff but now needs antibiotics for pneumonia or something. Particularly, we recommended this in patients who are recent organ transplant recipients. But again, these recommendations were conditional, low quality of evidence. Next slide. Then to get onto our second guidelines, fecal microbiota-based therapies, AGA looked at this. We looked at conventional FMT. This is the traditional stuff you get from a stool bank, delivered either capsules or colonoscopically. And then the two approved products, fecal microbiota Spores, Live-brpk, and fecal microbiota Live-jslm, as well as an investigational product that's no longer under development. We looked at its use in C. diff infection in immunocompetent, immunocompromised, and severe fulminant infections. This was about a year of work where extensive literature search, systematic full text reviews, data analyses. We drafted those recommendations and left them open for public comment for a period of time, and then we were able to revise based on those comments. Next slide. The first group we looked at were immunocompetent adults with recurrent C. diff infection. We had a lot to draw from. We were able to do a meta-analysis of 11 randomized controlled trials of over 1,000 patients. And patients randomized to receive these fecal microbiota-based therapies were more likely to have their C. diff prevented, recurrent C. diff prevented than controls. For conventional FMT, about a number needed to treat about 3 to prevent 1 recurrence. For the VOWST therapy, I'll call it, because it's sort of, sorry, I hate trade names, but that's sort of long to keep saying. Also highly effective, number needed to treat of 3. And for the RePreve formulation, effective, but not quite as effective, we know from the clinical trials, with a number needed to treat of 11. There were no differences between groups of those who got FMT or didn't in terms of serious adverse events. Next slide. We also recommended FMT for people who were mild to moderately immunocompromised and had recurrent C. diff infection. We based that on 13 observational studies. These patients were largely excluded from the RCTs and all had received conventional FMT. There was no analyses of either of the products in this group. There was no difference in rates of prevention in C. diff in immunocompromised patients compared to the immunocompetent ones. Overall rates of cure were high and about 79% overall, as well as in different subgroups. And rates of severe adverse events also did not seem to be higher in this group. Next slide. So why not use the FDA-approved fecal products? We found that there was insufficient evidence to recommend them. And an FDA clinical review memorandum specifically said that there was insufficient evidence for differences in safety and efficacy in this population. We made recommendations against using FMT or other therapies in those who were severely immunocompromised. These are people who are going through chemotherapy, might have just had a stem cell transplant, have severe primary immunodeficiency, that these people were at higher risks of a life-threatening infection that could be acquired through FMT, and that it was more appropriate to extend suppressive antibiotic therapy until the immune system recovered, as most of these situations are transient, and that was likely a safer option. Next slide. And then finally, AGA recommendations on use of FMT in severe fulminant infections. I recommended, again, conventional FMT, because this is where all the data is. There have been 5 observational studies of almost 300 patients, but the results are pretty astounding. The reduced risk of mortality compared with standard of care is very high, with a number needed to treat of 4 to prevent 1 death. By subgroup analysis, if you're talking about patients with just severe infection and early use of FMT, we're talking 30 fewer deaths per 1,000 patients. Patients with that fulminant infection, 175 fewer deaths per 1,000, as well as fewer colectomies with no increased serious adverse events. Unfortunately, we do need more data in this area, and this is in danger due to the FDA policies around FMT. Christian Lillis and has been wonderful, and I definitely get your thoughts on this to the FDA. Just a little plug that we really need stool banks and stool bank material in order to keep offering treatment to these groups, because neither product that is approved is appropriate in this population. And that's it. Thank you very much. I'll take any questions.
Okay. All right. So Colleen, thank you for that wonderful overview. Now we're going to sort of kick it back to everybody, which is we have kind of updated guidelines from 2024 from the AGA with regards to microbiota restoration. But I think that the guidelines from 2021, which were both kind of highlighted, we probably need to update sort of what your thoughts are, both of your thoughts are for, let's start with bezlotoxumab. Stu, what are your thoughts in 2024 for where bezlotoxumab sits in the treatment algorithm, if it's changed at all?
Yeah, so again, we recommended it for patients with who've already had an episode, so for recurrent C. diff. I mean, the data showed that patients with an initial episode and high risk for recurrence, it was also helpful, but practically it was not, we didn't think it was a practical recommendation. It's very hard to identify primary patients may show up in the hospital or where else and get them to an infusion center in a timely manner to give the end of therapy. So I think it works. I have a lot of personal experience with it. I think it's a very helpful thing. It lasts maybe 6 months. So I mean, it's not a lifetime cure, and neither is FMT for that matter. But I just emphasize that it's an adjunctive therapy. It's not treatment per se. And then, you know, the logistics of getting it and the costs are issues, of course. But I think it's effective. And this, where to put it in an algorithm of patients that have primary episode, have a recurrence, maybe have a second recurrence. And that's where we really don't know exactly where it goes. And I was told, I was not at ID week this year, but there was a point counterpoint between Eric DeBerke and I'm trying to remember who took the other point, comparing fidaxomicin versus bezlotoxumab, where to put those in the regimen. So there's a lot of work to be figured out exactly where that fits in the regimen on managing patients with recurrent C. diff.
Excellent. Thank you. Colleen, your thoughts on bezlotoxumab 2024?
So I agree with what he said, and I generally offer to the patients who have referred to me for recurrent C. diff, and if it's not going to be a high cost to them and it's fairly easy to get, we go ahead and do it. I also found a really nice little niche use for it. Myself, Alex Koritz, we have these patients who fail an initial FMT, and we've had really great success using bezlotoxumab prior to that second FMT to up the odds of the FMT working. And that was something we just had accepted for publication. Appears to increase your yield with that second FMT of about 15%. So we can get that, it kind of gives that FMT a chance to work by blocking the toxin as that reconstitution of the gut microbiota is happening through the FMT.
Sounds excellent. I think you presented that data at DDW this past year, correct? So I think that's exciting. I think certainly something we need to noodle on a little bit with that. It would be sort of the cost effectiveness of that. Getting back to some of your really important points as it relates to some of the cost of the other products, but it's the more options we have for providers that the providers are comfortable using, I think is better for all of us. Colleen, fidaxomicin heading towards, let's just say, generic form. Obviously, cost has been a major factor. Let's fast forward. It's going to be 2025 soon. Let's fast forward to January 30th, 2028 was on your slide. So let's go to February 1st, 2028. Where does fidaxomicin fit? Assuming there's no other, obviously, FDA-approved antimicrobials, where does it fit compared to vancomycin?
I would think if cost is no longer the main issue and access is no longer the main issue, and we can very easily on that date write for fidaxomicin and have it because, I would certainly choose it. Yes. Okay. Also, not just another thing, it's twice a day instead of 4 times a day. And you got to say, when you have a patient getting up in the middle of the night, setting an alarm to take a dose of medication, I think even for that reason, it's an easier drug to take.
Okay, so removing that cost factor makes a difference for you. Stu, obviously your guidelines were sort of purely data driven. Where would you see it fitting at that point compared to vancomycin?
Well, if you look at the guidelines, we already recommended fidaxomicin over vancomycin.
Yep.
It was a conditional recommendation, and certainly if cost was an issue, vancomycin was acceptable. But it's a better drug. It's narrow therapeutic. It doesn't have the unintended side effects of activity against some of the protective flora in the gut. So I think that's the direction we should be going in. And whether we see resistance develop on a bigger scale, it's yet to be determined. But I think it's a better drug, and I'd use it preferentially.
Excellent. Yes, and I think we're all in agreement on that. So so we have 3 minutes left, but I'm gonna ask a question that might require a bit more. So here we go. Open biome is sunsetting, or at least it seems that way in terms of the non-fulminant patient. So Colleen's guideline from the AGA essentially says in those who are severely immune compromised, we should not be considering microbiota restoration therapy. So what would we say to practitioners there? Is bezlotoxumab where we would go? So Stu, why don't you give us a minute on that?
You're talking about severely immune compromised.
The patients who are actively on chemotherapy with multiply recurrent C. difficile. They're not fulminant, so they're not in the ICU.
Yeah.
And I like to say they're looking at me in the face and they're saying, Paul, what are you going to do for me?
Yeah.
Well, it's a hard question.
I think IV bezlotoxumab is an option. For a long time, I've considered myself a drug pusher rather than a microbiome restorationer, if you will. But I believe that's the underlying issue for recurrent C. diff primarily, is this restoring colonization resistance. And exactly how you do that is an issue. But people with severely immunocompromised, obviously I think you have to be cautious with FMT, and I would agree with the AGA recommendations against it.
Excellent. And Colleen?
So I had a patient like this very recently. She was undergoing breast cancer chemotherapy. She kept getting recurrent C. diff, but it was actually causing issues with her therapy. They weren't sure if it was C. diff or if she was getting diarrhea from the chemo. And so to just take that out of the equation completely, we treated her for a course of C. diff with vancomycin, and then kept her on twice-a-day vanco until she was well past her planned duration of therapy, and then did an outpatient sort of stopped the vanco and gave an FMT. If we don't have open biome available, I would do the same thing, only it would be stopping the vancomycin and giving her a dose of most likely Faust.
Excellent. Yeah, so I do similar things. I certainly consider bezlotoxumab. Access to bezlotoxumab is challenging. So I typically do actually what Colleen does, which is I say we tread water for a while. And then once we can get them through that sort of bumpy period and they're immune reconstituted, I would consider moving towards microbiota restoration therapy. Well, this was fabulous. We're right at 1:15 right now, so I'm going to try to keep us on time. Thank you both for being here and adding these wonderful insights. Oh, Stu has one thing he wants to say?
Yeah, just a couple questions. And you avoided some of the controversy, I think, between our guidelines.
Yeah.
I would say I would agree that it was a cautious interpretation of the data to not recommend the new biotherapeutics for people that are moderately immunocompromised or in other situations. But, frankly, even though you don't have data to recommend it, I don't know why you wouldn't use that, one of the new products, rather than relying on.
I'm going to frame your question a little bit for Colleen, which is essentially saying that the AGA recommendation was that for patients that had a mild immune compromised state, not moderate or severe, that they would receive what was considered conventional FMT, which would have emanated from a stool bank, and not the new FDA approved treatments. Now, I think that I'm just going to sort of inject one thing here, which is that predated the open label study from Fecal Microbiota Live-jslm, trade name RePreve, which included 697 patients, and a significant number of those patients did have some form of immune compromise. And I think that possibly might have changed what the AGA recommendations might have been. That was published in September of 2024, and the AGA guidelines were published in February of 2024. So with that foundation in mind, Colleen, what are your thoughts?
So yes, when we were writing these guidelines, we were going on that literature review, which we had done, and everything that we had up to that point. And we based those on what we had the best available data for, which was conventional FMT. And also, we did not know at the time that open biome was going to cease to be an option. And if open biome were to continue to be an option, I would still, based on the available data, recommend conventional FMT, or if there are local institutional stool banks, which I know they have at Mayo, they have at MGH, to use conventional FMT in those patients.
So I'm going to ask a quick bullet question here, loaded, but a nice way to finish, I think. Colleen, assuming there's complete removal of open biome, which is unfortunately the track that I think we're headed on right now, except for fulminant disease, would you use one of the FDA-approved treatments in somebody with a mildly immune-compromised state, knowing the newer knowledge that we have over the last time since your guideline, really the data cutoff was for your guideline, which is well over a year ago now?
So that's a tricky question, because you're asking me to choose between RePreve, where there's a little bit of data, but I do think VOWST also has some limited data on immunocompromised patients based on.
I'm not asking you to choose. I'm just asking either one.
Okay, because I'll choose VOWST.
No. I wouldn't put it.
You don't put me on the spot.
No. And I don't think there's. I
would not let. If I had, honestly, if I had no alternatives for my patients, I'm not going to let them continue to suffer with recurrent C. diff over a kind of academic sticking point like that. And I would obviously have a conversation with the patient, explaining to them, like, you should do informed consent with these drugs as you do with conventional FMT, talking about risks of infection and the limits of the data, but I would offer it.
Okay, and Stu, what are your thoughts?
I see no reason to use stool bank. I really don't. I mean, what is magical about a stool bank provided specimen that's not in one of the new, use the term there, but the approved microbiome restoration products?
Yeah, I think one thing that's very, very important to keep in mind as we talk about the fulminant, we talk about no need for stool banks. There is zero data on either of these in fulminant infections. You cannot give microbiota restoration orally, and the VOWST product is probably much too dilute, and delivered by enema, just not appropriate for those patients.
No. I wouldn't even raise that as a question, and I don't think that my hope is that no clinician in practice would consider that. I think that the sticking point now is that we have a potential gap, and I appreciate, I'll just say, the coherence that we have here, which is essentially that I think, myself included, I would use in somebody who's mildly immune compromised one of the FDA approved products. Just because of what I believe to be the generic efficacy, although I agree completely, we don't have we don't have sufficient data to say, very definitively. I think it's probably the right thing to do, and I think we have agreement on that. Awesome. Okay. Well, thank you guys. This was great. All right. Okay. So we're going to move on now. We're going to shift over to my dear friend and colleague, Dr. Glenn Tilliston. Really one of the pieces of dialogue that we went back and forth on was microbiota restoration, and that's kind of where we just ended. So now I'm going to introduce Dr. Tillotson. He is a senior consultant as part of the GST Micro and has a wealth of experience with C. difficile. He's going to provide an introduction to the microbiota and an overview of FMT and LBPs. We were getting into a little bit of the weeds on that, but I think it's time for us to pull back, get a beautiful overview of it, and then we're actually going to talk about the individual products with individual lectures. Glenn, take it away.
Thank you. I'm very appreciative to the Peggy Lillis Foundation for this opportunity. It's nice to be considered part of this august body. So thanks again, and hopefully in the next 15 minutes or so, I will give you the journey through the ages. I was thinking very much of sort of Chaucer's Canterbury Tales, but I couldn't stretch that far. But let's start back in the midst of time, shall we? So in the 4th century, long before I was practicing or in microbiology, Ji Hong created a mixture created from healthy human feces that he called the yellow soup, like this. And this approach was adopted for a variety of conditions: GI, skin, nervous, and gynecological conditions. And, it seemed to be working quite well. And in fact, even out as far as the 16th century, another Chinese physician, Li Zheng, described the use of an oral, fresh, or fermented fecal preparation for treating a range of GI conditions. Get a bit more specific now. The FDA would like that. So diarrhea, vomiting, and constipation. Then not long after that, the vets got in on the act, and I have incredible respect for the vets in terms of microbiology. They frequently discovered organisms and infections long before us human microbiologists did. And Hieronymus Fabricius used a fecal transplant to actually modify poor animals that were unable to ruminate. I can think of a few people that could have done with that treatment, with their ruminations, but anyway. And then more recently, the Bedouins. They're a nomadic Arab tribe that are in North Africa, and they recommended eating fresh, warm camel feces to treat bacterial dysentery. They would sometimes augment it with the feces with milk and urine. Delightful mix, isn't it? Anyway, and this is what I'm about to describe is unverified, but in the Second World War, allegedly, German soldiers in Africa who had intense diarrhea were also given this concoction of camel feces. Whether it worked or not, we don't know, but nevertheless, it's one of those yet to be verified. So let's move on to a little bit more verifiable and recent history in the time of fecal transplant. Eisman in 1958 reported the first human use of fecal microbiota transplant for the treatment of pseudomembranous colitis caused by what he described as Micrococcus pyogenes. I would think that was probably Staphylococcus aureus or a relative that, and as we all know, that particular organism can cause horrific toxic conditions in the bowel, PMC. To the best of my research, the most recent case of FMT being used for the treatment of C. diff was 1983 by Schwann et al. And they used fecal enemas. And in fact, the enema route was used for quite a period of time, basically because there weren't many alternatives. However, we also know that in the kind of the early 2000s to around 2010, as Dr. Hu mentioned earlier on, there were significant changes in the epidemiology of C. diff, and the severity of these infections, and clearly the number of them, increased markedly. And we were looking for alternative routes to manage these particular problem infections. And Van Nood and colleagues in the Netherlands conducted the first randomized clinical trial of FMT, and they produced a single infusion of the fecal material by the nasoduodenal route and showed that this was actually superior to the standard of therapy that was vancomycin. This study was actually published in the New England Journal of Medicine, as I'm sure all of you know, and it was actually stopped early due to the superiority that was demonstrated with the fecal transplant. In addition to the nasoduodenal route, the different routes of administration that were tested were quite diverse. Besides, the ND route, as we call it, the lower route of colonoscopy or enema, retention enema, or via upper GI tract through capsules and various other approaches. But there was a certain element of uncertainty and a bit of safety to this, that a new approach was adopted, not necessarily a safer approach, but a new approach was adopted. And my friend Tom Louis from Calgary, who is on the left there, he developed this really quite cool process. And if you are interested in doing this, there's the YouTube link. I would recommend you go to your local Amazon store and get yourself a blender, because you'll see why in a moment. But Tom pioneered the poop pill, as he called it. And, you know, he had a team of volunteers who donated their stools, and those stools were basically used in this approach, which he called the poop pill. And eating a poop pill can be good for your health. And these are quotes from Tom. I'm not making this up. So how do you make a poop pill? Well, I thought the best thing was to look at the pictures. And there you see on the top left, a stool sample in a plastic bag. You've got there the blender, a sieve to collect, to eliminate the more particulate matters. You then blend it with usually a suspension of, if you can get saline suspension, that's best. And then you filter out the remaining debris, and you can put it in bottles ready for preparation. These can be given by colonoscopy. The other way I think Tom has advocated is to try to put them into some form of capsule. But I think the colonoscopy is by far and away the most pleasant route to do this. However, with all things in medicine, I'm sure we're all aware that there can be possible adverse events. And with any process of adding FMT, you can get GI effects such as bloating, flatulence, nausea, abdominal pain with cramps, and diarrhea, ironically. But these tend to be mild and self-limiting. There are other approaches that can be a problem with FMT. Is during duodenal installation, there can be aspiration. From my understanding, and not being an expert in this is pretty unusual. Fortunately, that's good. And clearly you can have issues when you're giving the FMT via colonoscopy. You know, sedation is required, and we all know that occasional hiccups will occur during that period. And if you happen to give this to patients who have an underlying IBD, you can actually initiate possible flare-ups or even transient fevers in these particular patients. So there are things to be aware of. And I'm not saying this is just exclusively to FMT. I think these are just, if you're introducing bugs into a different domain, things can happen. Now, what I want to do here briefly, and I'm not going to go into massive detail, is that not all FMTs are the same. And that's fairly obvious, I think. What I've tried to do is to divide it into two columns here, looking at the donor recruitment, and that's clearly, you know, very important in terms of what you're going to put into the patient, but also what do you do when they've donated their sample. And I think a really cool look at the literature in this case, and you can see on the x-axis there the percents of how often these items were reported. So that shows you the inconsistency. So in terms of donor recruitment, how many times did a donor donate? Was it every week, every month? Not noted in some of those. How many donors were included in the overall pot? And you can see going down that list in terms of donor recruitment, there were quite a few. Pathogens screened in the blood or stool, that was mentioned in about half of them. Diseases are the risk factors at screen. So you can see here, there's actually a difference, quite a marked difference in the standardization approach for the donors. Then in terms of when you get the item, the stool, what do you do? What did they do? Well, the type of diluents used was most frequently reported. The methods and the volume, that was quite regularly reported. But then when you look at things like conditions of stool prep, stool conservation, homogenization duration, all of those were not very consistently reported. So you've got this whole standardization question mark. I'm going to skip this one because I think the next slide actually tells it a little bit better. So microbiome, I call it microbiome-based therapeutics. They've evolved obviously from the 4th century with the yellow soup. But what we've gone on to now, I think, is where do we stand with the FMTs? Now, on the right side of there, I put together a timeline. I was thinking of trying to do it like a geological, going through the Earth timeline. Didn't quite work out that way, but some graphics people put it together quite nicely. But nevertheless, let's have a look at the pros and the cons of FMT. The pros. Well, you deliver a diverse microbial consortium to patients who are dysbiotic, and I'm hoping those on the line understand what dysbiotic means. And there is evidence in that you prevent future recurrences of CDI. That's shown quite well, and therefore that's what it was intended to do. And it's generally safe, but there are certain limitations on the data. But it is generally safe. Now, on the other side, yep, thank you. On the other side, there's no FDA-approved products, or clearly. There's a risk of transmission of pathogens. You're really dependent upon the donor stool. You need to know what the donor has been doing, what's their health been like. And that takes me to the next point, the lack of standardization for donors. And clinical lab testing is not often, conducted or validated. There are safety risks associated with colonoscopy or nasogastric delivery, and it's really not being used in very many cases of recurrent C. diff, less than 10% overall. So it's not the first go-to approach, is it? And I wanted to talk about the clinical trials because we talk about how reliable is the clinical data that we examine. So what I've tried to do here is to pull out some of the salient points. There is variability across the clinical trials, without a doubt. And the cure rates were actually, strangely, I guess, lower in the randomized controlled trials than those in open label. 67% or so versus 82%. But this inconsistency is probably due to the heterogeneity amongst the randomized controlled trials, which will, is illustrated in the structure and the control groups and so forth. And I think, this variability makes it difficult to compare apples and pears. The patients enrolled in clinical trials in the FMT ones are not necessarily a true reflection of all the patients seen in the real world. In standardized RCTs, as we call them, the inclusion-exclusion criteria are extremely strict. And I have been known to quote the iceberg phenomenon. The number of patients that get into a clinical trial is the tip of the iceberg. The vast majority are underneath, and they're the real-world patients who really don't see what's going on there. And was discussed earlier on today by Eric, was the CDI testing is inconsistent, and I think we all understand that. So there are some anomalies that need to be taken into account when you look at the data of FMT, and I think it's something that we need to be aware of. My apologies, jumped. Now, what was just mentioned, I think, by Paul and Colleen was open biome. Now, open biome is originated in, just over 10 years ago at an initiative run out of an MIT-based laboratory over in Cambridge. And it was really started as an independent, not-for-profit devoted group that wanted to expand access to investigational FMT and to actually drive the research into the microbiome. Now, Open Biome distributes investigational FMT preparation. And these are manufactured at the University of Minnesota under what's called an investigational new drug application. And that really provides a certain amount of how can I put it, FDA awareness of what's going on. And now for those of you who are interested in these things, I put a link on there which describes the manufacturing process that Open Biome can conduct. For physicians that want to use this product, they have to be registered and they can purchase the investigational FMT. It's all within an IND process. And the these physicians have to complete a very rigorous questionnaire in order that the product will be shipped. The cost is about $1,700 plus shipping. I may or may not be spot on with that, but I think I'm fairly close. And as of June of this year, I understand 70,000 shipments have been made to around 1,300 sites across the US. But as Paul just alluded to, there is I called it an FDA moratorium. I don't quite know what the future is, but clearly that is up for discussion at the moment. So we've gone from the yellow soup and we've come through to something that's a lot cleaner than a yellow soup and is distributed under an IND. But is this the dawn for something new? Well, I think it is. And I think really in the last 12, 14 years, we've actually come to appreciate that the whole thrust of recurrent CDI is the background, is the disturbed microbiota, and that imperative is to replace that in as a safe and as effective way as we can. So we now have I called it a new era, the Live Biotherapeutic products, or LBP. And there are some key attributes to these, and I'm not going to dig into these because I know there are at least two discussions coming up in this in a few minutes by product. What I'd like to say is that the manufacturing process complies with good manufacturing standards as per the FDA. The donors provide a complete physical history on an ongoing basis. I mean, it's not just how were you last week. These donors really provide a very detailed history of what's going on and what they do. There's a very detailed lab evaluation of biochemistry and hematology. And particular attention is paid to microbiological screening. Well, have you had a cold recently? Have you had diarrhea recently? All of those. And I'll touch on them in a minute on what are the bugs that are screened. And these have all been assessed through thorough prospective randomized clinical trials to what we call good clinical practice standard. So what are the pathogens? I'm not sure if you can see that very well, but there are 29 pathogens on here. And every time something new pops up, it gets added. I think it gets added to the list. I don't think Mpox is on there right now, but I'm sure it will get on there at some stage. And as you can see, there's an array of bacterial and viral pathogens on there. There's even a good old Giardia in there. And you've got what I think is the crux of the safety of these products is multi-drug resistant organisms. Now, previously it was, you can only search for what you know is in there. You don't know what you don't know, I think is the famous phrase. But now we're aware of multi-drug resistant organisms. These are thoroughly searched for as well. We don't want those going into patients who are in any way, shape or form slightly immunocompromised. So what are the criteria to become a donor? Well, these criteria apply in the exclusion criteria in the prior 30 days. The list is really extensive. Have you had a fever of unknown origin? Is your BMI shifting upwards? Do you have metabolic syndrome? Atopic disease. We don't really understand if that has a role here, but nevertheless, you've got to be aware of it. And obviously, do you have a history of IBD, C. diff, autoimmune disease, and various other things that are potentially important in providing stool samples for then those products to be screened very thoroughly as well. So they're complex, detailed evaluations. They're difficult to do, but they do ensure patient safety. And as we know, that is the number one reason to produce these products. Safety, efficacy is good, but safety is really very, very important. But I think knowing more about what these products are meant to do in terms of restoring the bowel flora and doing that in an effective way is critical. And I think we will find that LBPs will not stop at C. diff. I think this is the dawn of a new era for LBPs. I think a recent paper by Eric Paymer that showed that there were about 400 studies going on in the world of microbial restoration. And I've got a feeling a lot of those will become LBPs as well. So there are 2 LBPs that are approved, and I think Paul referred to them. There's ReBiota from Ferring Pharmaceuticals, and there's Voust from Nestle Health Sciences. These will be discussed further by a couple of my colleagues. And for now, thank you for your attention, and any questions, I think the chat line is open. Thank you.
Well, thank you so much, Glenn, for that wonderful overview of microbiota restoration therapy and a real kind of appetizer to live biotherapeutic products and FDA-approved microbiota forms of restoration. It's really kind of my distinct honor now to introduce Dr. Sahil Khanna. He is one of the pivotal people involved in both fecal microbiota Live-jslm's development as well as fecal microbiota Spores Live-brpk's development. He is a professor of medicine at the Mayo Clinic in Rochester, Minnesota, and he is going to be talking to us today about fecal microbiota Live-jslm. Sahil, take us away.
Thank you, Paul. Thank you to the Peggy Lillis Foundation for organizing this and inviting me. I'm going to talk about the story of fecal microbiota Live-jslm. What have we learned over the last decade of clinical development? I do get research support from Ferring, which is irrelevant to this talk. So this is the first approved microbiome therapeutic. Everything you need to know is on this slide, but I'll go over the details of all of this. The generic name is called fecal microbiota Live-jslm, trade name RePreve, and I'll refer it to as RBL as the preferred name for the rest of my talk. This was FDA approved for recurrent C. difficile in November 2022. It is a one-time rectal administration of this product, which is about 150 cc's of live microbe suspension with a defined number of bacteria, colony-forming units, and bacteroides. Does not require a colonoscopy, sedation of any sort, or bowel preparation. Can be done conveniently in an office-based outpatient setting, or there is a home administration program that's available. This is indicated to prevent the next episode of C. difficile infection from happening and is typically administered between 24 and 72 hours after finishing antibiotics for recurrent C. diff infection. With that, why are we doing this? As Glenn mentioned, there's a lot of challenges with FMT. We need to get to good manufacturing processes where the product manufacturing and its administration is standardized. Standardization in terms of donor screening, recruitment, preparation, and retention, donor and stool testing, how do you handle stool, what are the bacterial counts, what's the viability, and how many colony-forming units you get, and then cataloging the inventory and tracing recipients back to donors, and standardizing patient preparation in terms of antibiotic duration, washout period after antibiotic, bowel preparation or no, and how do you administer. And that's where these live biotherapeutics are in play. How about this product itself? This is manufactured from human donor stool under guidance from the FDA. Each dose is from a single donor. Donors are not pooled together. They undergo the rigorous training that Glenn talked about, screening that Glenn talked about for infections, health history, and the likes. Donations are on site, and every batch, every dose is tested for pathogens and bacterial composition, and each dose contains anywhere between 15 billion and 7.5 trillion colony-forming units with more than 15 million CFUs of bacteroides, which are very essential for health in general, but also for C. difficile is in every particular dose. It's in a single dose, ready-to-use enema bag, and it's being studied in clinical trials. These were the 5 clinical trials that led to its approval. I won't go into the details of all of these individual trials, although I would say is that what you can notice here is that the patient population of recurrent C. difficile was consistent along the trials. The endpoint was reducing recurrent C. difficile. People with 2 or more episodes were allowed to be included in the phase 3 trial and the open label trials, as you can see, or when I say 2 or more episodes, 1 or more recurrent C. difficile episodes. We had both open label and randomized control trials, and several hundred patients were included in every clinical trial, making totality of evidence more than 1,000 patients. One of the trials did have 24 months. 2 of the trials had 24 months follow-up, or people were followed for about 2 years to look for sustained improvement. The pivotal phase 3 trial, let's talk about the design of this one. This was a randomized, double-blinded, placebo-controlled trial of RBL compared to placebo at a 2:1 ratio. 2 people got RBL, 1 person got placebo. This was given after finishing antibiotics. Now, typically you would say, the FDA says you got to have 2 randomized control trials for approval. But with the availability of FMT and the fact that recurrent C. difficile infection is an orphan disease, and the fact that several people with immunosuppression were excluded, A lot of patients could not be enrolled in these trials, and that's where a single trial is the Bayesian framework where dynamic borrowing was done from a phase 2 trial. And instead of getting a p-value, you get a confidence of how confident are you that your results are statistically significant, and that's what the Bayesian analysis gives you. This is the study design. Patients with recurrent C. difficile infection diagnosed by any modality, could be PCR, could be toxin, were then included in this particular trial. They were given antibiotics. After they finished antibiotics, there was a washout period of 24 to 72 hours. And then they were given RBL or placebo. Initial follow-up was 8 weeks. There were stool samples at 7 days and 30 days. And then there's long-term follow-up for 3 and 6 months. And treatment success was absence of C. difficile diarrhea at 8 weeks. This is the patient population. Average age was in the 60s. Majority were females. People had received vancomycin before getting RBL or placebo. Some had received fidaxomicin. Some patients had less than 3 episodes. Some had 3 or more episodes. And there was a smattering of testing that was used. Majority were PCR, and some were EIA positive. These are the results. On the left side, you see the results from the Bayesian analysis. Overall success rate with standard of care antibiotics followed by RBL was 70.6% compared to 57.5% in the placebo arm, 13.1% absolute risk reduction, statistically significant and clinically meaningful difference. When we looked at patients who just got for first recurrence, because you can say, you know what, these are a different patient population. In that situation, RBL had 79.2% success rate compared to 60% with placebo. And that these are the pivotal data that led to its approval, in addition to the other studies that were done. Now, what happens after that? You see that there is a difference between placebo and RBX2660 or RBL, and that's the primary endpoint that's in this slide at 2 months. And these patients were followed up longer, and you can see this delta between placebo and RBX2660 is maintained. The higher you are on this graph, the higher is your recurrence rates, and RBL or RBX2660 had a lower recurrence rate. But the important part was once you respond at 8 weeks, that tends to be sustained. Looking at safety, and we've been talking a lot about safety today. These patients had no safety signal. There were no differences in RBL or RBX2660 and placebo in terms of adverse events. There were 2 deaths reported in the RBL arm, and none were related to RBL itself. One person had many comorbidities and one had a cardiac event. What about microbiome changes? Yes, we improve C. difficile infection, but also there are active microbiome changes that happen in these patients. Very interestingly, the lines here on the graph in gray demonstrate placebo responders, and the blue lines demonstrate RBL responders. And then the further right you go into every column, you see the time. Patients were followed up to about 6 months in this particular analysis. At baseline, you're saying patients with C. difficile have high gamma proteobacteria and high bacilli. Those are tags that you do not want to have. And after treatment with RBL or people who responded to placebo, the Clostridia went up. But in RBL responders, you're seeing a higher proportion of Bacteroides that went up compared to placebo responders, suggesting that you are replenishing the Bacteroides with this particular product. And overall, when people get rid of C. difficile, the Bacteroides and Clostridia go up, the gamma proteobacteria and bacilli go down, simulating a healthy state. Not just that, it improved quality of life. That's exactly what our patients are looking for. When we compared RBL to placebo, the graph here on the left demonstrates overall quality of life using CDIP-32, and the graph on the right demonstrates quality of life improvement with mental scores, physical scores, and social scores. And you can see RBL has higher quality of life scores compared to placebo. We talked about earlier today that several patients tend to be excluded in these clinical trials, and that's where an open label study was done where immunocompromised individuals, except the severely immunocompromised like neutropenic patients, those were excluded, but people with moderate immunosuppression were included. IBD patients, IBS patients, reflux disease, diverticulitis, those comorbidities that were excluded in the clinical trials, those patients were included in this particular open label study. And you can see at week 8, 74.6% responded. And of those who responded and completed 6-month follow-up, the overall success rate was 84%. In a vulnerable patient population, people who have multiple causes of diarrhea, we're seeing that RBL is effective in this situation. So how do you use this in clinical practice? It is indicated for prevention of recurrent C. difficile in patients 18 years and older. It is indicated for use in patients with at least one recurrence of C. difficile. And in that situation, you can risk stratify patients if you would like to. It is not used to treat active infection, and it's administered after standard of care antibiotics. And in the open label study, safety has been demonstrated in some immunosuppressed patients. However, it may not be used in patients who are undergoing active chemotherapy, have neutropenia, but you can use it in less severely immunosuppressed people on a case-by-case basis after having a risk-benefit discussion with those patients. Let's say you decide to do this for a patient population. How do you do this in your clinical practice? First step is to start an antibiotic to control active symptoms. Diarrhea improves in 3 to 5 days, and you got to continue them on antibiotics for at least 10 days or until they are able to get RBL. Discuss with your patients at home or in-office administration, and then initiate the process for RBL. There's a prior authorization that's required. You set up an administration date, and if you're doing at-home process, there is a separate process for that, which is a form that can be filled, and prior authorization is done centrally through that. As you're doing this, make sure you prescribe enough antibiotic until follow-up, vancomycin or fidaxomicin, and one can taper the antibiotic to the lowest effective dose, so it's stopped 24 to 72 hours before somebody gets RBL. How do you administer this? It is shipped frozen and administered directly after you thaw it in a refrigerator. In a refrigerator, you can thaw it for, you can store it for about 5 days. Otherwise, at -8, it can be stored for long term. The administration kit, and I'm going to show you some pictures of that. It has RBL and has single use administration equipment, and it's administered through over gravity. No additional IV pole or other equipment is needed. And we recommend patients remain on their side for about 15 minutes for attention and observation, and recommend them to avoid antibiotics for 8 weeks. Very importantly, make sure they don't go back and start taking vancomycin again. How does this look like? This is what the product looks like. There is a spike port. This is the tube set. In your office, you would have lubricant and disposable underpads that you can use. First step is you close the tubing. You put the administration tube into the spike port. Have the patient lie down on their left side. That's what we use most often, although somebody can be on their knee chest position if they prefer that. Insert the tube directly after you lubricate for about 12 centimeters, and then let gravity do its trick. No IV pole is required. So in summary, microbiome restoration alleviates recurrent C. difficile infection. Fecal microbiota Live-jslm or RBL is an FDA-approved option for recurrent CDI prevention. It's been studied in multiple clinical trials across a broad range of patient populations, different kinds of C. diff testing strategies, and in some immunosuppressed patients in open label fashion. It alleviates recurrent C. difficile infection. It restores microbiome, improves quality of life amongst patients with recurrent CDI, and can be administered in office or at home with no bowel prep or sedation needs. I thank you for your attention.
Thank you so much for that wonderful overview of fecal microbiota Live-jslm. I think we obviously, understand it much deeper now. We understand the impacts that it can have, and that is the first of the 2 FDA-approved forms of microbiota restoration. More a little bit later from Dr. Allegretti on fecal microbiota spores, Live-brpk. Now, I want to shift gears, and we're going to be hearing from a representative from Lumen Bioscience. Lumen Bioscience is a pharmaceutical company whose goal is to unlock the full potential of biologic drugs whose potential has historically been held back by the lack of scalable technology. Their goal is to decrease the cost of drugs, how they are developed, and who can access them. They have a pipeline that includes a cocktail of biologics to treat C. difficile infection. Today, we have Dr. Carl Mason, a vice president of clinical operations at Lumen, who actually traveled from Seattle to Hampton, Connecticut just earlier this week and was in my office to discuss some research interests. So here he is. He's going to be talking to us about his company and his product. Carl, the podium is yours.
Thank you for that very kind introduction. I want to thank the Peggy Lillis Foundation for inviting us to participate in this symposium. Today, I'm going to introduce the RePreve clinical trial of our anti-C. diff product, LMN201. Lumen, as Dr. Piersat mentioned, is a biopharmaceutical company located in Seattle, Washington. Using the cyanobacterium spirulina as a platform, we develop and manufacture therapeutic proteins for oral, respiratory, and topical applications. VHHs, or single-chain antibodies engineered from the heavy-chain antibodies found in camelids or llamas, are readily manufactured using this platform. Our anti-C. diff therapeutic, LMN201, is comprised of a cocktail of 3 of these antibodies that target the CTCB toxin of C. difficile. The antibodies can all bind to different regions of the toxin and can be bound to the toxin simultaneously. They also bind at epitopes different than bezotoximab, Merck's anti-TCDB approved biologic. LMN201 has efficacy against the toxin of common ribotype 27 and the standard ribotype 87. Of significance is that each of the independently active antibodies in LMN201 act synergistically when combined. Recombinant phage-derived lysins targeting specific organisms can also be manufactured in spirulina. LMN201 contains a lysin derived from a phage, PLI-CD, that specifically targets C. difficile. PLI-CD and the associated catalytic domain specifically target C. difficile, sparing other bacteria that are important for the microbiome. In preclinical studies, LMN decreases weight loss, improves survival, and reduces colonization in the mouse model shown on top, and improves survival in the hamster model shown on bottom. Each of the 4 components, the 3 antibodies and the lysin of LMN201, have been engineered for digestive protease resistance. Trypsin and common trypsin results following exposure to protease for 1 hour is shown here. All the components have good stability. In a subsequent small exploratory study, oral administration of LMN201 components to ileostomy patients confirmed the presence of active antibodies and lysins over time in ileal fluid. The bioactive antibody levels were consistently greater than the estimated minimum therapeutic concentrations required for activity. The RePreve trial is currently underway. RePreve is short for recurrent prevention. It was chosen in a contest. The initial Part A sentinel cohort addresses safety and tolerability. This was mandated by the FDA. The Part B main cohort addresses recurrence prevention and, of course, continues to address safety and tolerability. The global cure endpoint is a combination of initial antibiotic response and recurrence prevention, similar to that used in Merck Modify 1 and Modify 2 trials of bezotoximab. Enrollment of 24 participants into the Part A sentinel cohort is ongoing now. Enrollment in the Part B main cohort is planned for early 2025. Participants will be stratified by age, 65 years above or below, and standard of care antibiotic, metronidazole, vancomycin, or fidaxomicin. Participants will receive LMN201 or a placebo during the treatment and prevention phases. This schematic for Part B main cohort shows the flow of participants through the treatment, prevention, observation, and follow-up phases. The prevention phase has 2 weeks of twice daily and 6 weeks of once daily LMN201 or placebo. Through the end of the observation phase, there are 5 clinic visits and 3 telephonic visits, attempting to minimize the requirements for participants to attend in clinic. The inclusion and exclusion criteria are the same for both Part A sentinel cohort and Part B main cohort. Both primary and recurrent C. diff infections are eligible. Additional details are currently available on the clinicaltrials.gov and also the study website at https://www.reprevestudy.org. In summary, Element 201 is a cocktail of 3 different anti-C diff toxin B antibodies and 1 anti-C diff lytic enzyme. Element 201 is orally delivered and appears to be safe, similar to other oral protein therapeutics. Element 201 has an active IND and was granted fast track status by the FDA. The Part A sentinel cohort is now currently actively enrolling. We are looking for additional U.S. sites for the RePreve trial Part B main cohort. And that concludes my presentation.
Carl, thank you so much for that overview of the RePreve study. I'm super excited to hopefully eventually see the end results and see how we can move science forward. So as we now shift, we're going to look back at antimicrobials. And we have another wonderful expert here today to tell us about a novel antimicrobial, Ibezapolstat. Kevin's been following Ibezapolstat really since its inception and conceptualization for a number of years, and he's been sharing that with me along the way, and I'm super excited to see it move forward. So he's here on behalf of Acurx Pharmaceuticals. Kevin is a professor of pharmacy practice and the Robert L. Boblet Endowed Professor of Drug Discovery, along with the department chair at the University of Houston College of Pharmacy. Kevin, we're so excited to hear you talk.
Hello, everybody. Welcome. Hi from Houston, Texas. Thanks to the Peggy Lillis Foundation for letting me be here today, and it's been a wonderful symposium so far. I'm looking forward to the rest of it as well. Okay, so I was teed up very nicely by Bruce and Vince earlier on today with the pathophysiology and risk factor slides, including Vince's recreation of his own figure. So what I want to focus in on is C. diff is a microbiome disease, and your normal microbiota is generally, you're resistant to C. diff, and it's only through the use of antibiotics or other things that you have a susceptible microbiota, which then allows the vegetative C. diff cells to grow, and then you get disease. So what I want to focus in on here is, and then that's when we give an antibiotic. And so the ideal antibiotic that we give will not further disrupt the microbiome, and even better, it would help restore the normal microbiome and colonization resistance. So I want to blow up that top part of his figure and add on this. So what is it that these spores are ubiquitous in the environment? And so how come for the normal microbiota, you can eat spores and essentially just poop it out the other side without ever getting symptomatic infection? So what's the importance of the normal microbiota compared to this susceptible microbiota or dysbiosis? And so that gets us back to the bile acid story that we've heard a few times today. So bile acids are made in the liver. Primary bile acids are secreted in a small amount into the colon. And generally, certain very specific gut microbiota metabolize those primary bile acids into secondary bile acids. And that's good because secondary bile acids inhibit C. diff growth, and primary bile acids promote C. diff germination. So it's a really a better understanding of C. diff pathophysiology that helps us rationalize drug design to optimize the use of our drugs. And so then the specific bugs that are responsible for bile acid conversion is still work in progress, but we know that the group called Clostridiales are very important for this. So now we can go back to that slide and update it to say, so we want to have low primary bile acids because we don't kill or help preserve these Clostridiales, and that should prevent C. diff in the first place. And more important for antibiotic drug discovery, it should prevent C. diff recurrence. Okay, so then this is the star of the show for the next 14 minutes, Ibezapolstat, a new antibiotic currently entering phase 3 trials. It's a small molecule inhibitor of the DNA pol-3C. Now, the pol-3C is only present in certain gram-positive bacteria. So it's going to be a narrow spectrum of agent just because it's its mechanism of action. And these Firmicutes is a large component of our healthy microbiome. They also contain many of the pathogens, Staph aureus, anthrax, for example. So it's a targeted therapy for certain pathogens that we do want to get rid of, including C. diff. I've been working with Acurx for a number of years now, including in their healthy phase 1 studies. And there we were able to confirm that it was more narrow spectrum than oral vancomycin. That's the graph on the left. And you can essentially see by these changes, the red is reduced constant proportions of something over time, and the green is increased proportions. And so you see much more red and greens in the vancomycin arm than in the Ibezapolstat arm, proving that it was a more narrow spectrum agent. Now, in a phase 2A, so non-comparator study, open label, not only was it selective for Firmicutes, but it was selective of certain Firmicutes such that you saw increased proportion of Clostridiales. And if you remember that Clostridiales from the bile acid story, you're getting very excited that this compound, Ibezapolstat, could have an anti-recurrence effect. So that was more than enough data to go into a phase 2B study. This is Ibezapolstat 450 milligrams given for 10 days, twice a day, compared to vancomycin, normal doses for 10 days, initial clinical cure, many of the regular clinical trial endpoints. And then we also added on a large component of microbiome, including bile acid changes. 16 patients enrolled in the Ibezapolstat arm, 14 in the vancomycin arm, generally elderly, primarily female, white, and Hispanic, sort of the regular circulating ribotypes of the United States, and both treatments were well tolerated. One patient failed a clinical cure for Ibezapolstat, 94% clinical cure rate. 2 patients had a recurrence in the vancomycin arm, and I'll just re-emphasize 2 patients had recurrence in the vancomycin arm. I'll show you some interesting microbiome data, giving you a sustained clinical cure rate of 94% for Ibezapolstat, 86% for vancomycin. Time to resolution of diarrhea was similar, about 7 days for Ibezapolstat and about 10 days for vancomycin. So just pay attention to the y-axis here. So it's a non-absorbable agent. So the plasma micrograms per ml less than 1, while achieving very high fecal concentrations, over 500 micrograms per gram of stool by day 3, which is what you want in a C. diff antibiotic. You want high colonic concentrations because that's the site of infection. This is a proportional changes. And so a few things catches your eye right away. You can see a big expansion of those purples in the Ibezapolstat treated patient population, not vancomycin. That's actinobacteria. Actinobacteria is responsible for a lot of things, including fermentation of fibers to short-chain fatty acids, another health beneficial effect of the microbiome. And then if you go over to the class, you can see not the super dark green, but the one right underneath it. That's maintaining on Ibezapolstat and shrinking in vancomycin, and that's the Clostridiales class again. Now, in microbiome world, the figure I just showed you is proportional changes, and this is quantitative changes. So Bacteroides, Bacteroidetes, gram negatives. So Ibezapolstat should have no effect. And so you see that blue line of Ibezapolstat really having no effect at all. In other words, it's not having an effect on the gram negative species and the anaerobic gram negatives. And you see a big decrease with vancomycin, which is well established. And then go over to the middle, Clostridium leptum and Clostridium cacoides. These are 2 taxa responsible for bile acid metabolism. And you can see the blue line is above the red line. Ibezapolstat preserves those key taxa better than vancomycin. And then if you just kind of look and see how things are changing over time, You'll notice I put a third plot in here. So if you go to the alpha diversity plots, the green is Ibezapolstat, the dark red is vancomycin, and the pink, that's the 2 patients on vancomycin who had recurrence. So recurrence is often thought that you have less diversity of organisms, and it hasn't really been shown in clinical trials before. So small number of patients, but you're seeing a trend that as these vancomycin patients become more and more less diverse, I should say, that's the groups that have recurrence. 2 different methods of showing that, so all that is. Beta diversity, green again is Ibezapolstat, and go down to the bottom, because you see at the top, they're all sitting on top of each other. And so the green is Ibezapolstat, that very wide ellipse, it is kind of close to Ibezapolstat, but going down from there. That's the vancomycin patients that did not have a recurrence. And you see that really individual little circle. Those are the 2, once again, patients that had recurrence. Then you say, well, what happened to that crowd? So now you see no Clostridiales with those vancomycin recurrence patients. You see an increase in proteobacteria and an elimination of Actinobacteriota. So it's really helping to prove the mechanistic understanding of Ibezapolstat, and also providing further clues on the pathophysiology of C. diff. Now, the same thing happened again. In this case, blue is Ibezapolstat. The more red one again is vancomycin, and those pinky ones are the patients with van recurrence. So this is the quantitative changes, and you see vancomycin is causing a decreased concentration of these healthy beneficial taxa, and especially those that went on to recurrence, you're seeing dramatic differences. Now, the big bang finish is obviously you're all at your edge of your seats wondering, was that taxa changes enough to influence bile acid changes? The answer is yes. So once again, Ibezapolstat in green, vanco in red. The left graph is primary bile acids. You don't want a lot of them. And you see them going up dramatically while on therapy, which is sort of that shaded gray bar, and continue to be persistently high through day 38. And if you remember, recurrence with vancomycin is highest within the first 30 to 38 days of therapy. A nice way to illustrate this is the rightmost graph, where it's the primary to secondary bile acid ratio. And anything below that line, you'd have more primary bile acids than secondary. So you can see for the duration of the dosing period with vancomycin through day 20, their primary bile acids outnumber their secondary bile acids, providing them some physiological proof that this narrow spectrum of Ibezapolstat that has led to no recurrences yet, there's an underlying mechanism for that as well. So conclusions for now, it's Ibezapolstat was clinically comparable to vancomycin in this phase 2b study. Favorable PK and microbiome results compared to vancomycin, high colonic concentrations, increased beneficial taxas in the microbiome, and then favorable effects on bile acid homeostasis. So looking forward to the phase 3 trials and continuing these great microbiome results. And thanks again for the opportunity to present here today. I'll show the gang and thank Acurx Pharmaceuticals, the makers of Ibezapolstat, for funding the microbiome work in my lab.
Kevin, thank you so much for an excellent edge of your seat discussion on Ibezapolstat. I'm super excited to see that product also coming through clinical trials and seeing some end results. So now we're going to shift gears, and we've spoken about antimicrobials briefly, and we're going to go back to FDA-approved forms of oral microbiota restoration therapy. The product is Fecal Microbiota Spores Live-brpk. I want to introduce Dr. Jessica Allegretti. Jessica is an associated professor of medicine at the Harvard Medical School, medical director of the Crohn's and Colitis Center at the Brigham and Women's Hospital in Boston, and another true C. difficile expert. Jessica, thank you so much. Super excited to hear your discussion.
Thank you so much for having me, Paul. It's really a delight to be here to give you kind of a nice, succinct overview of this newly FDA-approved therapy. And we'll talk through the data, how we got here, and really sort of, I think, a very practical primer on how we use it and some of the challenges we're still facing with this therapy. So with regards to some overview here, VOWST, or Fecal Microbiota Spores Live-brpk, formerly known as SCR-109 from the clinical trials, has notable differences compared to what we are calling traditional or unapproved FMT and also other LBPs. We know that dysbiosis associated with C. diff infection includes significant reductions in both Bacteroidetes and Firmicutes. And we know that this therapy approaches its treatment by targeting one of the known deficient phylums in patients with C. diff, specifically the Firmicutes. And so while this product is donor-derived, it does undergo an ethanol-based purification process in which viruses, vegetative bacteria, parasites, fungal organisms are removed from the sample, except spore-forming Firmicutes. And so the final product contains anywhere from 1 to 10 to the 6 to 3 times 10 to the 7 Firmicute spore colony-forming units per capsule. So if we just look back to the EcoSpore phase 3 trial, and this was published by Paul Feuerstadt and co. in the New England Journal back in 2022, it was one of the pivotal trials that got us to approval with this therapy. But again, this looked at oral administration over 3 days compared to placebo after standard of care antibiotics. In this trial, there was Live-brpk administered before capsule administration, and patients were randomized in a 1-to-1 fashion. Notably, with regards to the key inclusion criteria in this trial, patients needed 3 or more confirmed episodes of C. diff within a 12-month period, and the diagnosis of the confirmatory episode needed to be with a toxin EIA test, so PCR only was not allowed for entry. Key exclusion was no patients with IBD were allowed in this trial, no immunocompromised patients, and the primary endpoint was lack of C. diff recurrence at 8 weeks. So with regards to the results, with the primary endpoint, we see here that almost 90% of patients had complete resolution at week 8 compared to almost 60% in the placebo arm, which was, of course, statistically significant. With regards to some secondary outcomes, sustained response for VOWST at 24 weeks was found to be 78.7% in the treatment arm compared to 52.7% in the placebo arm, also statistically significant. I will just point out there has been some real world data published, although I think there definitely is more coming. And so this was a trial that a study I should say, that I actually participated in with several other studies, several other centers, excuse me. So a multi-center retrospective real world study in which we looked at patients who were requiring a microbiome therapeutic, and that could have been either sort of unapproved fecal microbiota transplantation, fecal microbiota spores, Live-brpk, which we're discussing now, or fecal microbiota Live-jslm, which I know you've already heard about today. And you can see here that in this cohort, again, this was sort of early days into FDA approval, 90 patients had received unapproved FMT, 7 had received fecal microbiota spores Live-brpk, and 15 fecal microbiota Live-jslm. And as you can see here, again, I think taking into consideration the ends in each of these cohorts, we actually see that both of the 2 FDA-approved products performed quite well with regards to resolution of C. diff at week 8, even compared to unapproved FMT, although there were certainly many more patients treated with unapproved FMT at the time. And I think we are continuing to collect data, and there will be sort of larger real-world cohorts coming down the pipeline. I will also just mention the EcoSpore 4 study, which was sort of the follow-on to EcoSpore 3, and we're starting to get some, I think, more similar real-world type data through this study because patients were allowed to have a first recurrence in this. We do see some immunocompromised patients in this study. This is an open label study design, and this was really aimed at just gearing towards getting more safety data, but we do see some important efficacy numbers here as well. So with regards to results from EcoSpore 4, we do see very similar results to EcoSpore 3, which I think is very reassuring. Only 8.7% of patients experienced a recurrence up to week 8 in the treatment arm, those getting treatment, and 13.7% with recurrence up to 24 weeks. So again, really good sustained response in this patient group. With regards to safety, in the label, there are really no contraindications to this therapy. There is potential to cause adverse reactions due to food allergies. That is unknown, the potential. So it is noted in the label. But if you look overall at the clinical trial programs as well as real world evidence, we see that this therapy is safe and well tolerated, with adverse events really being very mild GI side effects, as we see with unapproved FMT. And if you look again in the clinical trial data, rates of adverse events were similar in the treatment compared to placebo arms. With regards to indication for use, so that's a lot of the data on how we got here, but now that it is FDA approved, how are we actually using this therapy? So just again, to remind everyone, the labeled indication is prevention of recurrent C. diff in individuals who are 18 years or older following antibiotic treatment for recurrent C. diff. And so VOWST should be considered in adults experiencing a second recurrence and beyond, so 3 or more confirmed episodes, in keeping in line with our clinical guideline recommendations for unapproved FMT. However, there is really no mandate in the label as to when in the patient's treatment course or disease course you can or should use this. So you should consider using this therapy earlier for a high-risk population. And here we've listed some in some patient populations where you may want to consider using this as early as the first recurrence. And so that may be older patients, those who are immunocompromised or live in skilled nursing facilities, those with severe underlying illness, those with inflammatory bowel disease. And so certainly, I think there is utility in using this earlier in subsets of patients. Otherwise, continue to consider using this in patients where you may have considered unapproved FMT. As I mentioned previously in the ECOSPOR 4 trial, there was included a cohort of patients with first recurrence showing a 93.5% sustained clinical response rate at 8 weeks following administration in this cohort. So again, showing good data that this does work even when used earlier. So how do you actually use this if you're not familiar? This is dosed as 4 capsules taken once daily for 3 consecutive days. Antibiotic treatment for recurrent C. diff should be completed 2 to 4 days before initiating therapy with VOWST. This is, again, an outpatient therapy that is essentially prescribed and sent to the patient's home. So this does not need to be done in facility. Patients should have completed a standard course of antibiotics, typically 10 to 14 days, but this can still be used when appropriate after a pulsed or tapered course of vancomycin. However, if the patient is appropriate for this therapy and you feel that they are in need, there is no need to complete a full tapered course. You can stop the antibiotic therapy after that 10 or 14-day course as appropriate. So even if this often happens where the patient comes to us on a very prolonged course of vancomycin, and we determine that they actually, of course, do need this preventative strategy, we don't have to wait the full 60 days of vancomycin that they were originally prescribed. We can stop after we are sure that the patient has completed a therapeutic course. The recommended washout for vancomycin is 2 to 4 days prior to your first dose of therapy. The evening prior to the planned intake, also the patient should take 10 ounces of magnesium citrate or equivalent. The patient should remain NPO or nothing by mouth for at least 8 hours prior to administration and for 30 minutes after taking the 4 capsules. VOWST can remain in the patient's home refrigerator or at room temperature at arrival for the subsequent 2 days of administration. And the patient should take all doses on an empty stomach prior to the first meal of the day. And one should not freeze these capsules or thaw them out. So just leave them either in the fridge or at room temperature and complete the course. I will just mention this is from their website. This is what comes when you actually prescribe the therapy. So you do get, sort of the blister packs with the 3 days of dosing. And you also do get the laxative that gets mailed to the patient's house directly, so they don't need to worry about going out to get it. So I know we've been hearing about a lot of exciting and great options today. How do you choose what may be appropriate for your patient? So often when I have a patient in front of me, I'm thinking about upper versus lower administration. Is the patient able to swallow pills? Not everyone can, or some patients have, severe esophageal or gastric motility disorder. So capsules may not be the best option for that patient. On the flip side, there may be a contraindication for a colonoscopy or rectal administration, in which case capsules would certainly be preferred. And then the other sort of side to that is there any need for a mucosal assessment? Is there any thought that there may be something else going on? So you really do want to administer this via the colon, or a microbiome therapeutic via the colon to get a mucosal assessment. If that's not necessary, then I think capsules certainly are a great option. Also, I find that where the patient actually lives and the location of patients often does play a role in which therapy you may consider. Because VOWST is able to be prescribed and mailed to the patient's house, this works great for many of my patients who live far away, because I can see them even virtually. We can get an assessment done, and then I can have this mailed to their house, and it doesn't require them to come into the city to have to take this therapy in the office. And so I think it really does make this convenient and very patient-friendly. What about the challenges? Of course, as newer products come to market, I think we're often learning where the challenges lie, and hopefully they will continue to get worked out the longer we have experience with these therapies. But as this is still a new product, there are still insurance coverage issues, and cost certainly is variable. And I find something new every day, a new challenge, a new denial for a different reason every day. Just to give you some examples, these are all things that I have seen recently. I had VOWST denied because the patient had recently used bezlotoxumab. And then right after that, I had VOWST denied because there was no attempted bezlotoxumab. Go figure. And we have occasionally seen mandatory pass-throughs of other treatments. So we have seen payers say, must use ReBiota before VOWST and the other way around. And so again, we just don't know as plans are updating. I think we'll probably see a whole host of new things after the new year when plans update. So I think this is really a moving target. And so we're just always ready with data, with the patient's test results, with letters of medical necessity. And usually on appeal, you're able to get this approved, but it is certainly, it is work for the office and the provider. That being said, patients' assistance programs do exist, which is great. So if the patient does have very high copays, there is the VOWST Voyager program. So it is a piece of paper that you fill out, and then the company actually can help offload costs with copay assistance for those with commercial insurance. I would say the one downside to this program is, as of right now, this is a paper form. There is no online portal. So as I mentioned, I do see a lot of patients virtually. And so I often have to mail this piece of paper to the patient's house and have them fill it back and mail it back to me. As you can imagine, that is not ideal and can delay care. So hopefully there will be an online portal in the very near future. So in conclusion, the FDA approval of Fecal Microbiota Spores Live-brpk, or VOWST, in addition to other novel microbiome therapeutics, which have been approved and are also under investigation, has really ushered in a new era of management of C. diff. And I think we're really in an incredible time right now with more options and more to come. These landmark products have really paved the way for future investigation of other products that might manipulate the microbiome for the benefit of other diseases beyond C. diff. And VOWST really does represent the first oral microbiome therapeutic approved for the prevention of C. diff. And so I think this has really been a wonderful addition to our treatment armamentarium, again, with certainly more streamlined processes and more things to come down the line. So thank you so much for your attention.
Well, Jessica, thank you so much for that wonderful overview. I appreciate it. So, we've learned now about Fecal Microbiota Spores Live-brpk, Fecal Microbiota Live-jslm. The company that actually produces Fecal Microbiota Spores Live-brpk, or VOWST, is Nestle Health Sciences. And many of us know the name Nestle for, let's just be honest, their chocolate. But they have a huge nutrition portion of their company producing things like Boost and Optifast. They also distribute common over-the-counter irritable bowel syndrome treatments such as IBGuard and FDGuard. They're also integral, as I mentioned, in the development of VOWST. So we are delighted today to have Dr. Jason Goldsmith, who is a Senior Director of Medical Translational and Data Sciences from Nestle Health, to give us a broader overview. Jason, thank you so much for being here.
Hey there. All right. Let me see how I can make the presentation show up. There it is. All right. There we go. So thank you for all being here. I was formerly part of Series before the product moved over to Nestle, so I've been with this for a while. And I'm going to talk to you today about the manufacturing, what goes into making this. So to start with, it's a 5-step process, right? So you're going to start with your donors, like all the donor-derived products do, and that involves a lot of screening. And then there is important testing after that. And, you can say, isn't testing part of screening? Yes, but we try to divide that up because they're different controls. And then the unique step for us is this inactivation process that I'll talk about, and then the subsequent purification and encapsulation, which gets that oral formulation. So what is donor screening, right? So donor screening is a really important part of the process. And apparently the pictures didn't pop up, but that's fine. We'll make this work. So donor screening, right? When you do donor screening, you have to think about the person coming in as no different than a patient, right? You're going to do a history, a physical exam. You're going to then think about conditions that you would not want a donor to have that could influence product safety from the perspective of, is it a transmissible condition? So you're going to ask them if they have a fever. You're going to measure their temperature. You're going to ask them if they're feeling sick, all of those types of things. That's an important first step in the screening process. But then you're also going to consider other conditions that could maybe transmit by the microbiome as we're still understanding things. So, history of inflammatory bowel disease would be a concern. History of depression is a concern for us, and so on and so forth. And so you're going to undergo an initial significant screening, medical history. It'll probably be the most robust history most of these people have ever provided, along with a physical exam. And then after that, you're going to continue on and have repeat screening. So every time you come in, we're going to ask you, hey, are you feeling well? Has any of your medications changed since last time you were here? And just make sure there's no changes. And then every month, we're going to do that full history and physical again, just to ensure that we're keeping an eye on the donors. The next thing we do, and again, I am missing my pictures, but that's fine. We'll make this work, is that we're going to do donor testing, right? So we do a variety of testing at different cadences. So you have some tests that only come in right when you enter the program. And then every month you have blood tests thereafter for infectious diseases that transmit by the blood, which the list is in the bottom left of this slide. And then you also add on weekly stool and COVID testing. And so for GI pathogen testing is weekly, and then COVID is also weekly. And so every donor in the program has this repeat cadence of testing that goes alongside those histories and physical exams. And so from this, we get the starting material, and that is then all reviewed and made sure it is all what we align on, that it's per our standards, there's nothing missed. That goes through a formal batch release process like you'd see in any pharmaceutical for starting raw material or intermediates. And then from there, we go into the manufacturing process. And so our manufacturing process involves ethanolic inactivation. So we mix the stool formulation that we have with alcohol, and that inactivates numerous potential pathogens per some of the papers you can see cited in the bottom left. But in the process, it preserves Firmicutes bacterial spores, which is our active ingredient, because bacterial spores are resistant to alcohol. And so we're able to kill things like E. coli or COVID, SARS-CoV-2 significantly through this alcohol process. You're essentially doing an alcoholic form of cleansing. And then from there, you still have to purify it down, right? And so that's where we have a centrifugation process and filtration steps. And what that does is removes debris and the inactivated pathogens to produce a highly refined spore fraction, which is approximately, we have 1% residual material left over after this. So of what's in your final formulation, it's only 1% residual material outside of the bacterial spores. And then from there, we take it, and the final product is then put into capsules. And we have a double encapsulated pill. So you have a pill with the liquid spore formulation in it, and that goes inside a second pill. And what's nice about this is that between the fact that it's bacterial spores, which are hardy, and it's in a capsule, inside a capsule, we have room temperature stability that can be on the shelf for up to 36 months. And so that is how we essentially make VOWST from start to finish, right? It is a, it is a process involves donor screening, testing, ethanolic inactivation, and then downstream filtration, and then filling up capsules. And that's it. And I think I can take questions relative to the manufacturing process, but that's about it. And anything else we would direct to the medical information line.
Okay. Well, thank you so much for that nice overview. I think what was good about this is that we kind of had some clinical data, and then you walked us through and practical usage of fecal microbiota spores, Live-brpk, and then we shifted over and you gave us kind of an overview of the process and the production associated with it. And I think Glenn in his section also kind of mentioned the good manufacturing procedures and that kind of piece of what this looks like. So, question for you. Yeah. With regards to, the production process, how many donors are there for the mass production? Is it a small number, like 5, or is it a larger number?
Yeah, so just as a reminder, one donor makes a lot of drug, right? Yes. So we don't pool our donors, and one donor makes a lot of drug. We kind of keep the number ratio secret, and it's variable from donor to donor, but you do not need a huge number of donors. You're looking at, handfuls, not an army of donors. And we like to keep our donors for a long time because we do need a lot of donations from one person. So our program is really focused on having small numbers of high quality donors for long periods of time, as opposed to like 100 or 200 different donors coming through. So it's a small number of people that make it through the gauntlet that then have that right combination of all the health criteria, the spores we want, that can commit to being in the program a long time.
Got it. And I think you had mentioned it's 1% or less than 1% of what's originally donated ends up in the encapsulated form. So, the next question I have is, okay, so now we have this indication of prevention of recurrence in people at highest risk for recurrence. Is there any kind of active research that you can share with us, obviously, for this publicly, available, that we should look into or look for in the coming couple of years, trials associated with VOWST that you think that we should keep our eye out for?
I think that's when I would get in trouble for sharing on this one, but definitely researchers who are interested should reach out on that medical communication line that we have, or can reach out to me and I can put that in touch with you all, because we are interested in learning more and moving further, but we have those conversations one-on-one at this point.
Excellent. So, what we're going to do next is we're going to shift here. So first of all, thank you so much, Jason, for your time and your insights. I think we've all learned a lot from you today. Next, what we're going to do is we're going to shift over, and Christian is going to introduce a patient advocate, and we're going to kind of reground just like we did earlier this morning, hearing a patient experience. So we're going to have a couple minute delay here. So in the meantime, why don't I kind of noodle through what we've experienced today and what we have discussed. I mean, we've gone through a whirlwind of information already today. We had Alice who spoke to us about epidemiology. And during that epidemiology section, she essentially told us, look, community-associated infections are re-increasing after the pandemic. Healthcare-associated infections we're doing well on. We heard from Eric, who walked us through diagnostics. In addition, we had a number of other individuals who walked us through. We went through the standard of care guideline treatments, IDSA, SHEA, as well as ACG. And we've really kind of covered a little bit more detail microbiota restoration therapy and the 2 FDA-approved forms of microbiota restoration therapy under the context of the pathophysiology that we covered earlier. So now, what we're going to do is we are going to shift over. We're going to have Christian introduce the patient advocate.
Hey, it's good to see you, Paul. You've been a great MC so far. It's actually usually something I have to do, so it's been nice to be relieved of that duty today. But yeah, I think it has been a fantastic day so far. I have learned a ton, and I think Minnie and Spencer were really fantastic in terms of sharing their experience as a patient and a caregiver. So I think this has really been excellent, and we are just getting ready to introduce our next patient. He's in the green room, so we're going to welcome him over in a second. But I do want to thank everybody again for sponsoring today's event. I want to thank all the speakers who've been so generous with their time and their expertise. We truly couldn't do this without you guys. It's really, really appreciated. So now I have the pleasure of introducing our next patient speaker. And so our next presenter is Michael O'Kane. And he is a C. diff survivor who joined PLF as a volunteer this past spring. Having survived a C. diff infection thanks to one of the FDA-approved live biotherapeutics that Paul was just mentioning, Michael wanted to help others. Michael has a history of service from enlisting in the Navy in 1966 and serving in the Vietnam War. And then after he retired from service, Michael had a long, distinguished career at New York Telephone, for those of us who remember when there were telephone companies. And he has really been an amazing volunteer with our peer support network. And after primarily having had a virtual relationship with Michael over the summer and fall, I finally got to meet him and his lovely wife, Kathy, at our gala last week. And I'm so grateful that Michael is joining us to share his story. So take it away, Michael.
Good afternoon. I'm Michael O'Kane. I'm 76 years old. I feel like I'm 18. I was diagnosed with C. diff in 2021, right after the pandemic, when the pandemic started to slow down. And I initially thought it was just an ordinary case of diarrhea, and it didn't. It turned out not. It just was persistent. It was with me all the time, 24 hours a day. I wasn't sleeping, and when I was sleeping, accidents would happen. And initially I thought it was something that I did, something I did wrong, and it wasn't. It was my cardiologist who diagnosed me. I told him what was going on. I was in for a regular visit with him. I told him what was going on, how long I'd been having these episodes, and he said, a dentist gave you a drug called clindamycin. And I said, yeah. He said, that's a very wide spectrum. It kills everything, even the good stuff. So he's right. He's right. He was absolutely right. About 3 weeks after I gave myself the clindamycin, I came down with the diarrhea almost constantly. Food goes in and came right out. It's a dirty, filthy, disgusting disease. I relapsed 7 times, and I've tried various therapies, Microbiota, phytomoxicin, all the standard drugs. And I kept thinking in the back of my mind was always, it's something I did, something I ate, something I'm doing. And that wasn't the case at all. It was nothing I did. It was something that a dentist did. And I'm sure that he uses clindamycin all the time, probably still does. I stopped seeing him. I'm sure 1 million patients have used it. It was just my turn. And the final drug I used was Vowst, and so far that was in April, and I've been clear so far. Had a scare a couple of days ago, and it turned out we're waiting for the lab results, but I'm pretty certain it's not C. diff. The doctors, my primary care physician is a gastroenterologist, and he's a smart guy. He knows what he's doing, and he knows what he's talking about. But he kept prescribing phytomoxicin, which I think is difficile, and he just kept prescribing it. And the cardiologist, he said, I think it was Einstein described insanity as doing the same thing over and over again and expecting a different result, and that just wasn't happening. So I took my cardiologist's advice. I looked for the one guy that does nothing but C. diff, and I found him. And he looked at me, we did a sample, and he looked at me and he said, you got C. diff, and here's what we're going to do. And he prescribed Voust, and away we go. And that was in April, and I was good every time since, ever since. All the therapies I tried, Rebiota, they never lasted more than 2 or 3 weeks. I was never well for more than 2 or 3 weeks, and it was, I wasn't aware of Peggy Lillis Foundation, and they've made all the difference. I got to meet other people who had it at the gala, and I'm one of those guys who talking about a problem makes it easier for me to bear and to deal with, and I needed to do that. If I met you on the street and you asked me how I was going to buttonhole you and say, "Oh man, I got C. diff, and this is what's going on." And the more I talk about it, the easier it gets to understand. It's really a horrible disease, but what I want to get across to people is you didn't do anything to get this. It just happens. There's a common saying, it happens. And it did happen to me. And it may happen again. I don't know. Right now I'm clear, and that's what I'm dealing with. Am I supposed to take questions or anything, Christian?
No. I mean, if people do have questions, they can let us know. I have that chat open. But thank you for sharing your story, Michael. Something I wanted to touch base on, because we have a little bit of time before the next speaker, is you've been volunteering with us for a while now, and you've been doing peer support. And I'm just curious as to how you found that.
Oh, I love doing it. I asked Lauren the other night, send me more people. I get more out of it than they do. I really do. It's, again, talking about it and telling them it's not the end of the world. There are treatments out there, and you got to find one that works. Yeah.
So, you have a very kind of powerful story, and I think it's important to realize, sometimes timing matters also. So, you said that you had responded to Voust, but perhaps not to Rebiota. Maybe if it was vice versa, you might have had different results. The bottom line is you're better now. And I think that's probably the most important thing for us as clinicians to know and understand, which is sometimes it requires multiple types of treatments, multiple approaches. If I were to ask you, as a patient who has experienced multiply recurrent C. difficile, if there is one thing or a couple of things that you could say to somebody that doesn't know that the Peggy Lillis Foundation exists, besides saying, "Hey, you got to find this organization," what would be your advice for them?
Oh, find the organization. It's a bunch of good people. They know what they're talking about. Most of them have experienced C. diff. And another thing I forgot to mention, because of my service in Vietnam, I suffer from PTSD. And there is a PTSD associated. I recognize it for what it is. That's because I'm lucky I have it. It's associated with C. diff. There's a crash when you realize that therapy didn't work. And this guilt that says, again, you fall into that pit. Something I did, something I ate, something I'm doing. And the PTSD is real.
And I think you're bringing up a really important topic here. And this is something that I have viewed from the other side. So I'm in no way, shape, or form ever going to say that I understand what you went through. And thank you so much for your service to our country, especially in the week that we're in right now with Veterans Day and everything else. But that PTSD, and I'm sure it's different, right? The PTSD from being in battle or being in the armed forces is one piece. The PTSD from C. diff is something that I can say I've tried to kind of optimize and understand over the years. And it's multiple different factors. It's physical, which we've discussed. It's mental, which I think we've alluded to a little bit. And then there's sort of the social element of it. Oh my gosh, what am I going to do if? Can you speak to a little bit on if you're comfortable? I don't want to put you in an uncomfortable spot.
No.
So please, the mental and the social elements.
With the mental is the guilt that's associated with it until you get past that. The social, my wife and I we had no social life. I was unable to travel, and I have an app on my phone right now. It tells me when I plan a route where the safe toilets are on my route. And that every McDonald's, every Burger King, every public library, they're all okay, and they're all public, and you don't have to buy anything to use them. But as far as the PTSD goes, the Vietnam half of it, I get flashbacks. Fireworks are triggers, fireworks, gunshots, crowded situations. We were never together for more than 3 people at a time. Because if we 3 were talking and somebody walked up, I would turn around and walk away. It just without saying a word. And it's the same with C. diff in that I'm not comfortable unless there's some place to go. I'm really not. First thing I did when we went to the Gaelic Christian was I found the toilet. I knew where it was as soon as I walked in. When we go to a theater, even though I'm clear right now, I got to know where the toilet is and where the exit is. It's just one of those things. We went to a Japanese presentation years ago, and it was a tiny little theater on, I forget the street, in Lower Manhattan. And the first thing I did was I said, there's only 2 ways out of here. One is behind the stage and one is behind us. And if it comes to it, we're going where everybody else is not going. And she said, why do you do that? She knows why I do it. It's just something I do. And it's PTSD. I'm not comfortable in crowds. And with C. diff, I'm not comfortable in crowds. I'm always thinking about what if.
Well, and I think that's really powerful. And I think what you're saying is unfortunately something that so many patients with C. diff, just with one recurrence, go through, let alone multiple recurrences. And we've had really exemplary and well-spoken individuals who've shared their insights, yourself and earlier today, just the full experience of this and the stress that goes into this is something that I think as practitioners gets a little bit lost in the fray of a patient calls, they're having recurrent diarrhea. Oh, shucks, we have to deal with this again.
Yep.
Right. But the reality is what you said, which is when you go on a drive, you know where every McDonald's is, you know where every clean bathroom is, and that's a tether for your life. I mean, certain patients, they'll bring changes of clothes with them. They will wear diapers when they didn't previously. There's a lot to that, and a lot that I think, like I said, it doesn't get, fully translated in a clinical office visit. And I think one of the really fascinating things that we've been able to do is take a look at it from the science side and look at the impact of some of the microbiota restoration therapies. There's something called the gut-brain axis, which is what we believe to be changes in the colon, the metabolic changes, the chemical changes in the colon can get somewhat translated to the brain. And it's logical to think, well, wait a second, if we prevent a recurrence of C. difficile, then of course somebody's going to feel better. So they're physical, mental, and social beings, what we call the health-related quality of life. We had Kevin Gary on earlier, and he's the person who created the C. diff 32 questionnaire that we leveraged for this data. So the clinical trials that looked at both VOWST and ReBiota looked at health-related quality of life. And as I mentioned, it was a logical extension. The logical extension was people who didn't recur had an improvement in their quality of life. But what was most interesting from that turned out to be that the individuals who received VOWST and ReBiota compared with placebo actually had changes in their microbiota. So even though they recurred, so I'm talking about the group that recurred, even though they recurred, the group that received those active treatments actually had trends for increased quality of life, whereas the group that received placebo did not. And what's most fascinating, exactly, and I saw your response, that's exactly what the response is, was just, wait a second, They recurred, but they still had an improvement in their quality of life. And I think what we're really unearthing with that is that there's other microbiota changes that come with this. And perhaps with the C. diff comes psychological change as a result of changes in the microbiota. And that when we rescue the microbiota, we might be rescuing some of those dysbiosis or some of those changes that actually helps us from a psychological standpoint, independent of somebody getting the PTSD or getting a recurrence in the future. And we've drilled it down to a granular level and actually looked at the specific microbiota changes in those patients that recurred despite receiving these FDA-approved products. And you'll probably see that in publication in the next year. Maybe at next year's conference we'll be able to discuss that. But it's really focused on all these really fascinating things. And to me, it's putting the pieces of the puzzle together from what we've been talking about all day, which is the pathophysiology, the microbiota, antimicrobial effects, and then finally, microbiota restoration therapy. I don't want to leave bezotoximab out from that because that certainly deserves a mention, but all of this together hopefully builds towards what the vision of the Peggy Lillis Foundation is, which is helping patients, gaining access to resources, but also moving the science forward.
While I was in Vietnam, I was there for a year and a half. I contracted amoebic. Well, they say it was amoebic dysentery. I don't think it was. And this is, I've been sicker with this than I was with dysentery. And we were expected to function. I mean, we were expected to go out and do our jobs. And yeah, I was on tiny little boats in Vietnam. They were called PBRs. And if you had an episode while you had dysentery, you just hung it out over the stern. And it sounds disgusting, but that's the reality of it. And I'm having a flashback. But anyway.
All right. And these are real thoughts and feelings that you have, and I'm sorry that you went through that. But it's important that all of us as providers ground in the realities of what patients experience. And I really appreciate that you've provided all this information today.
Yeah, I apologize for my awkwardness. I'm not comfortable in this situation with a camera and talking about this.
I don't think there's any reason to apologize. I think you've been fabulous and you've been real, and you have provided us with insights that we wouldn't otherwise have. So I say thank you.
Usually at the end of these things, when we're all done and everybody's packed up and gone away, I say, oh, damn, why didn't I say this? Why did I forget this? And I don't work well from notes because I'd rather look at the camera than look off at a bunch of notes. So I try to wing it. I hope it's been successful.
Well, it's been very successful. And what I'll say to you now is you have that opportunity. So is there something else that you feel that we should know as it relates to C. difficile and your patient experience that you haven't been able to share already?
Educate the doctors. Educate the doctors. Everybody, like I said, my guy he's a gastroenterologist and he's a smart guy, but I believe he literally had to go to the book and look up C. diff. It's educate the doctors, educate the patients. I'm trying to do that with taking care of patient advocacy. I hate the disease, but I love the people that are involved with it.
Yeah, and I think that, go ahead, Christian.
I was going to say, Michael, I think, I sometimes do talk about this, but the whole time that I was in college, I had terrible irritable bowel syndrome, and I knew where every bathroom was between my university and my home, and I felt like, pardon the pun, but the party pooper for not being able to go out or being concerned about going out. So, I somewhat understand what folks are going through with the C. diff infection. It's somewhat different. But, I want to thank you. And I think Minnie and Spencer also brought this up, treating the whole person. And, you talked about feeling a little bit awkward in this situation and feeling guilty about things. And, I think I think what it points to is that we need sort of a more caring country in general. Like people should, like there should be public restrooms that are easily accessible.
Yep.
You know, we should give each other a break and treat each other well when we're not feeling well. And I think, you know, certainly the three of us all came of age in a go, you know, work hard, you know, thing.
Yep.
And I think we're starting to maybe realize that that's not for everyone. But I mean, if you're comfortable leaving it there, Michael, I would thank you so much for joining us and sharing your story again. And you're definitely like a huge blessing to the people that you work with. And you can't see all the comments probably, but people are very, you know, very thankful for sharing your story.
I need my glasses and I need to lean in like
Well, I can tell you that they are all very appreciative for what you shared and the insights that you shared.
Well, thank you so much. It's nice to hear. When I'm talking to a patient or to someone who's suffering with it, I judge the person I'm speaking with, and just to see how colorful I can get as far as language goes and situations go. And you know, we need to get out there about this. There's a guy I'm working with he's up in the middle of nowhere and up in New York State, and he can't find a doctor that knows anything about his nearest doctor is in Syracuse, which is a 2-hour drive for him, and he can't make that. You know, he can't do it. So I spoke to my guy, and he said, I can't find anybody up there anywhere near, and I would love to. If I have to, I'll go up there and take him. But it's we need a celebrity. We need somebody famous to come out and say, I've had this or I have it and I couldn't work because of it. And it's nothing to be ashamed of. It's nothing you did. It's everything you can correct, but nothing you did. That's pretty much it. I'm sorry if, once again, awkwardness, it's an awkward situation for me. And this is worse than speaking to a group of 100 veterans, which I've done, and I used to do regularly. This is worse because I can't see anybody but you three. I know they're out there because I see the comments coming up, but I apologize for my awkwardness.
Oh, you were fabulous.
You have nothing to apologize for. You know, as much as things like Zoom or technology like this does help us connect with people all over the country at once for an event like this, it is a little weird to speak into it, especially when you're used to talking to people one-on-one. So, Michael, thank you so much. We really appreciate your time and your support of so many people, and I'm so glad that I got to meet you last Friday, and I look forward to seeing you and Kathy again soon, since we only live in different boroughs.
That's another thing, Christian. You've seen me in the wild, and you know I'm not like this. You know I'm a garrulous, likable, affable guy, and I haven't murdered anybody in years.
Better than I've done. All right, well, the next speaker is getting ready. So what a nice guy. And
yes,
I would just like to say, because, you know, we've been very focused on HCPs most of the day today, all of whom, as we know, are very important. I think a point that Michael made that we keep running into is, you know, certainly all gastroenterologists are great. Well, let's say most of them. No offense, Paul. And you know, most patients are great. I'm sure you get some wackos in there too, right?
That's what keeps
I
us
wouldn't
interested.
want me as a patient. But I do think that, you know, when people are in Michael's situation or Minnie's situation where they have not just C. diff, almost not just recurrent C. diff, but things that are really treatment resistant in a way, you know, what we try to do here is find them somebody like you, like many of the people who've spoken today, who are, you know, physician scientists who are on that cutting edge, because that's what we need. And I think we see a lot of that mentality in chronic disease and cancer. We don't, I think, have that same mentality around infectious disease, and we need to get there. You know, we're like, if you have a serious infection, you might need somebody who is a true expert in that infection, you know?
No, I agree. And I would have expected with the pandemic a few years ago now that more light would have been shed on infectious disease and the risks associated with it. But despite all of our efforts trying to focus on these processes, I think we're heading back, or we are back to where we were before. You know, COVID has become basically, oh, that's just another thing. And I agree with you. And it's fascinating, especially C. diff, which is the most common healthcare associated infection. We really are, as a society, I guess, not acknowledging it as much, but organizations like PLF are doing what they can and getting the word out there and touching many people and hopefully opening people's eyes.
Yeah, and I think one of the sort of key things is that, you know, I think sometimes patients and doctors are put in an almost adversarial position, especially, you know, if things are tricky or the first treatment doesn't work, people can kind of get upset with that. But when it comes to actually, you know, I can't speak to how anybody interacts with any specific person, but I think when it comes to the bigger picture, what we really need is for us to all work together around these diseases so that, you know, whether it's a regulator like the FDA or Congress or, you know, even some of the big companies, you know, where we're speaking to them in one voice and saying, you know, either we need you, we need your help, or we support you, we're going to push for this, you know, just a much more kind of, you know, solidaristic mindset. Because I mean, at the end of the day, people don't go to medical school to hurt anybody. You know, you all go to medical school because you want to help people. And I think, you know, obviously that's, you know, why I do this. Otherwise I would be a stand-up comedian. But
no, and I think a day like today symbolizes what that is, which is an intermingling of basic scientists, clinicians, patients, industry, advocacy groups, all coming together for a common cause, and that's what makes this so fabulous.
Yeah, I agree. So I believe our next speaker is here.
Okay, we will.
So we might need another minute or two for them to get set up. Thanks, Paul, for being chatty.
No problem. No problem.
They have the right two people to kill time. Next time we'll have more of a routine where like maybe there'll be a little song and dance. You know, you can play you know, rock paper scissors, something that everyone.
We gave everybody a short break, so we're just waiting for the next speaker to come into the pre-room, and then we will get his talk off the ground. You know, Christian, I wanted to take a moment now just to thank you for today and giving us, I'm just being representative of clinicians, but people interested in C. difficile in general, a platform, an opportunity to share and exchange ideas and to really kind of grow the field and grow knowledge around the field. I think it's really fabulous, and I want to say thank you for that.
Well, you're all very welcome. And I want to thank, you know, I mean, going back to almost 15 years ago when this first happened to my mom, you know, there were a few doctors that I reached out to, and early on I ended up getting connected to one of our favorite people, Cliff McDonald at the CDC. And I just wanted to understand what happened, you know, and he walked me through everything. And, you know, I didn't go to medical school. I'm not a microbiologist. And so, you know, not just as a patient, but as somebody who I think many people consider a patient leader, I'm not always comfortable with that. Like I'm reliant on people like you to explain to me why bile acids matter.
In an interesting way that doesn't get you to sleep, right?
Exactly. And that also that I can then explain to other people, you know, I mean, that's, you know, but, you know, I'm very glad, you know, obviously the C. diff community, you know, we had our friends at the C. diff Foundation, and very sadly we lost Nancy Caralla to COVID. They had been doing an event like this for years, and you had been one of the people organizing that every year. And so, when you first brought it up to me, I was like, oh, we already have so many events. I don't know if we can do another one. But you convinced me of the importance, and then the experience of today of having 450 people sign up for this. Clearly there's a desire and a need, and I'm very glad we did it. And I'm very glad that sponsors who, had already committed for the year decided to, commit a little more to help us pull this off. It really, it really has been just a great day. I mean, I've really enjoyed hearing so many different perspectives. And I'm actually excited to think how we can make it better next year.
Well, I'm me too, and I think that this was a fantastic opportunity to really kind of showcase what this is and can be, and I'm super excited about getting things off the ground for next year. And of course, thank you to our sponsors. Now we are ready to shift over to our next talk, and please, we have a bunch of talks still to go. We've got about, I think, 3 or 4 more people to speak. I am going to shift over now and speak. Going to have Tech Lab. Dr. Stuart Cohen is here. Tech Lab is a company that has C. diff Quick Check, which is a complete test combining the GDH assay and the toxin A and B assay. So a little bit of pulled from Eric DeBerke's presentation, toxins A and B, which is detection of the toxins, and GDH, which is detection of the organism. Stuart will be speaking on behalf of the company. Thank you so much for being here.
Thank you. So there are my slides. I appreciate being added to the agenda late, and I'm apologizing because I thought I was supposed to start at 12:15 my time. I just got finished with a medical student session. So I will move it as quickly as I can. I was asked to talk about EIAs and CDI diagnostic testing, and I know Dr. DeBerke went through everything early. I wanted to put maybe a little bit more of a local perspective onto things. I always say that the key to all of this is having a clinical diagnosis. So the patient's meeting clinical criteria for having CDI as important to even do testing in the first place. I only show this picture of the CT scan because a lot of times that's one of the things that we hear, because patients get scans done really quickly in their hospital stay, and people bring up the idea that they saw colitis on a CT scan, and that often impacts how they address patients and work things up. So I've always been a proponent of EIA testing, or at least toxin testing, as the way to make the diagnosis of CDI, because it's the toxins that cause the disease. Actually, it's toxin B primarily that causes the disease. So identifying the organism doesn't necessarily tell you that the toxin is being produced and that the organism is actually causing the problem rather than just colonizing the patient. And so when my colleague, Dr. Chris Polage, was here at UC Davis as the director of the clinical microbiology lab, we did this clinical trial where we were reporting only toxin assay results. So we were doing quick check, but we weren't reporting the components. We were only reporting if the toxin was positive, that's what we reported, positive test. But in the background, we were doing PCRs. And so we were able to find people who were PCR positive and negative by the toxin assay. And we know that the PCR is a more sensitive mechanism of identifying the organism. But the clinicians did not know that the patients had a positive PCR test. And so they were treated based on the toxin result. And what we saw in this cohort of patients was that, at least looking at time to resolution of diarrhea, the patients who had a positive toxin test, which is the solid dark line at the top, took significantly longer to clear their diarrhea on therapy than the patients who had a negative test, which is the blue dotted line, or the patients that were toxin minus but PCR positive by the orange or gold line. And those patients weren't being treated by and large. There were some that did get treatment because the clinician was convinced that the patient had C. diff, even though the testing was negative. So it looked to us as if, even if we may be debating whether the diagnosis is really not C. diff or really mild C. diff that doesn't need treatment, the argument was the toxin assay was the one that told us whether the patients needed treatment. Subsequently, and this study was published in 2015, subsequently, the IDSA SHEA C. diff guidelines were modified from the 2010 guidelines, and they included a variety of different testing methodologies that were alternatives to this for people who were more concerned that we would be missing patients every once in a while by doing toxin assays alone. I saw another paper that was just published a couple years ago that looked at the same thing. They did everything by PCR. They used what's called cycle thresholds to determine whether the patients had toxin or not. They used that as a surrogate for a toxin assay. And they, again, compared the patients that had only a PCR test reported, and this was what's called a quasi-experimental design, meaning there was a time before and a time after the intervention. And then they looked at whether the C. diff toxin went away or the organism went away as their primary outcome. But the secondary outcomes were the clinical ones: 7 days of diarrhea to diarrhea resolution, hospital length of stay, and 30-day mortality. And the test, basically, the pre-intervention period, the clinicians were seeing only the PCR results. And the post-intervention period, or the intervention period, was when the patients were seeing functionally a toxin assay. And you can see these groups. I just wanted to show that the groups were pretty well matched. Actually, the patients in the intervention group were a little bit older and also were more likely to have a hematologic malignancy. But there were bone marrow patients in both groups, solid organ transplants in both groups. And then the percentage of people who had had antimicrobials within the prior 30 days were not different, and whether they were on a ward in the emergency department or an outpatient wasn't any different. So, and what they also showed were some of the other variables that were a little bit different. So the patients may have been a little bit more chronically ill with a lower albumin in the pre-intervention group, but severe C. diff was more common, even though not statistically differently, in the intervention group. And then the patients were more likely to not be treated in the intervention group. So you can see that in the intervention group, only 15% of the patients got C. diff therapy, whereas in the pre-intervention group, 91.5% did. And what turns out is very similar to what we found, which was that the time to resolution of diarrhea was not inferior. The 30-day mortality was not inferior. The length of stay was not inferior in the pre or post groups. And then so you can see Unresolved diarrhea at 7 days was 20% in the pre-intervention group and 13.7 in the intervention group. The length of stay was the same, and all-cause mortality was pretty much the same. Clearing the test was maybe more in favor of treating than not treating. And so that, to me, sort of re-emphasized this. But then we had a sentinel event where we had a young kid who we knew was PCR positive because we screen everybody coming into the hospital to determine whether they need to be isolated or not. But he had multiple tests that were negative, but he had a megacolon. And so it seemed that this was severe C. diff infection, and he was ultimately treated. He didn't have a great outcome. And so we re-looked at this and we thought, well, maybe we should be adjudicating the discordant results when the organism was present and the toxin was negative. And our numbers, of course, went way up, and our rating in all these ranking systems went way down, and it made all the administrators a little bit unhappy, or maybe a lot unhappy. And so we started looking at this. And so this is just 1 month, and I know this is just our facility, but we performed 262 tests. 12 of them were positive by standard methodology. 35 were discordants. 6 of those were PCR negative, so it was a non-toxigenic C. diff. And then 29 of them were PCR positive. Of those, 4 had tube feeds, 1 was on laxatives, and 1 was receiving lactulose. And so those 6 shouldn't have even been tested based on our diagnostic algorithms. And then 8 didn't meet the clinical definition of C. diff. And so there were some that were being picked up, but we were probably reporting a lot of colonized patients. And this is what our reports looked like. You can look at the slides later, but that's the positives and negatives. And then we decided to do what they do at WashU, what Dr. DeBerke does, which is require an antimicrobial stewardship faculty member to place an add-on order for the discordant results. And so now it's going to be reported starting on the 19th as an indeterminate test with the following interpretation. Discordant toxin versus antigen. Do not treat. If suspect C. diff infection, consult with stewardship immediately for guidance. And then they can put in an add-on order, an EPIC, that will get the PCR result. And then the result will come back, and it's a little hard to read this. I made it a little bit too small, but the negatives will say this is not C. diff, and the positives will say sort of what we've said before, that this may be colonization, and you really have to think about whether you want to treat these patients or not. So this is my final slide and my interpretation of what I've showed you, and more than that. Active disease versus colonization is a challenge when you've got these discordant results. Interpretation of the clinician is important if the report is totally transparent. And that's what we've tried to make it now, so that they can see exactly which components are positive and which are negative. Make sure that the patients who are being tested actually meet clinical criteria. Don't test if they're getting tube feeds or laxatives, which is an alternative cause for diarrhea. PCR can be used for adjudication of these results, but it's not necessary in all cases, and it still needs to be looked at with clinical judgment. And so this is an important area for diagnostic stewardship, to try to make sure that people are ordering testing appropriately and we're identifying all patients that need to be treated with a minimum of treating colonized people. And I will thank you for your attention, and thanking you for being a late add-on, and thanking you for your patience for me showing up when I was supposed to already be finished. So I don't know whether you're taking questions or not. Either way, thank you so much.
Well, Stuart, thank you so much for that riveting talk on diagnostics, and thank you to Tech Lab for sponsoring your portion there. We greatly appreciate it and appreciate your time. We're going to go back from diagnostics. We're going to go back to treatment now, and the next few discussions are going to be on really the future. What's on the horizon? What's next? And the next company that we're going to have is a company called Vedanta. Vedanta is a bioscience company based in Massachusetts that is pioneering rational design of drugs for the treatment of serious gastrointestinal diseases using defined consortia of bacteria. They have a product that's called VE303 that many believe is going to be the next generation form of microbiota-based treatment that only includes 8 bacterial strains. From Vedanta, we have Dr. Stephen Schiff. Dr. Schiff is a Senior Vice President, Head of Clinical Research at Vedanta Biosciences, and he's going to be talking to us about VE303. Steve, thank you so much for being here.
Thank you. Good day to everyone. Good afternoon or evening, wherever you are, or perhaps morning. I really want to thank the Peggy Lillis Foundation for inviting us to talk about VE303. It's really an honor to speak at this symposium and to represent my dedicated colleagues at Vedanta Biosciences. I'm Steve Schiff. I lead the clinical research function at Vedanta and oversee all of our clinical trials. On the next slide is our disclosure slide, presented because I'm going to be speaking about our investigational product, VE303. So this is what Vedanta is really all about. Defined bacterial consortia, also known as live bacterial products or LBPs. We believe that these will transform medical therapeutics for many purposes, not just preventing recurrent C. diff, and for many reasons. And among them are the conveniently administered oral route, that they're well tolerated, and they have pleiotropic modes of action to restore gut homeostasis. Our vision is to transform medicine by applying these microbiome restorative therapies to control infections, many of which are currently very serious public health problems, not just in the United States, but worldwide. Here you see the focus of the presentation today, VE303, which we're developing as a potential first LBP to restore the gut microbiome after disruption by antibiotics to prevent recurrent C. diff infection. As you can see, VE303 is comprised of a defined collection of 8 commensal bacteria from Clostridium clusters 4, 14A, and 1 from cluster 17. Here you see the proposed mechanism of action of how beneficial commensal bacteria are thought to restore gut homeostasis. There is restoration of luminal homeostasis in terms of the ecological community of organisms, in terms of the biochemical makeup of the lumen. In addition, restoration of mucosal homeostasis. As you see on this slide are the steps taken to rationally design VE303, the VE303 consortium. On the left, you see how we went from FMT studies and data identifying organisms that were suspected to drive the beneficial effect of FMT onto in vitro experiments assessing the ability of candidates that were identified to suppress C. diff, and subsequently to in vivo animal experiments that permitted evaluation and optimization of the consortium. And this was the strategy used to identify the consortium VE303 that was taken into human studies. Here you see the results from a published phase 1 study where various dosing levels and schedules of VE303, and that's represented at the bottom of the slide in the enclosed box, were administered to healthy participants, mostly after a short course of antibiotics. In this study, we showed that VE303 colonization was dependent on antibiotic pretreatment, which is shown in the bottom right-hand corner, and that it was durable, shown in the upper left-hand corner, abundant in the upper right-hand corner, and dose-dependent. These results allowed us to choose a dose to carry forward into a phase 2 study. Here you see the design of that phase 2 study, which was conducted, which is also called the consortium study. This is where safety and efficacy of VE303 was tested in participants with recurrent C. diff infections. These were either subjects who had either recurrent C. diff infections, or in a smaller group who had a primary C. diff infection but were at high risk for recurrence. Participants were treated for the qualifying infection with antibiotics, as you can see on the very left-hand side of the slide. And those with successful treatment were randomized to placebo or 2 doses of VE303, 1 high dose and 1 low dose. Active to placebo randomization was 2-to-1 to 2-to-1. And the reason for that was in order to achieve the high dose and low dose, different numbers of capsules needed to be administered during the trial. Participants were followed for recurrence for the next 24 weeks, and the primary endpoint was recurrence at 8 weeks, which you can see in the dots. Here are the results of the study. For the primary outcome, all the way on the right side of the slide, 13.8% of participants treated with high-dose VE303 had a recurrence at week 8. This is compared to 45.5% of placebo-treated participants. This is tantamount to an adjusted absolute risk reduction of 30.5%, and the adjustment was made for stratification factors. The recurrence in the low-dose group was not different from placebo statistically. Here you see survival curves for the recurrences over the course of the study. Apart from seeing the marked difference between high-dose VE303 treatment in the orange line and placebo in the blue line, it is also noteworthy on the very bottom corner of the slide. It's noteworthy that after day 10 of treatment, of the 14-day treatment, there were absolutely no recurrences in the high-dose VE303 group for the rest of the observation period. Here I show colonization data from the phase 2 study. The left panel shows colonization of VE303 in the 3 treatment groups in terms of relative abundance detected in stool samples after the 14-day dose period. The higher dose led to a 6-fold higher median colonization than the low dose. The right panel shows the correlation between quote unquote cure and the relative levels of colonization. You can see that if a subject showed colonization above the median in the blue line, there was an extremely high probability that a recurrence would not occur in the rest of the observation period. Here is the safety data from the trial. VE303 high dose and low dose was well tolerated. The vast majority of treatment emergent adverse events, or TEAEs, which are adverse events that occur after administration of the first dose of study drug, were mild or moderate in the vast majority. Few TEAEs led to discontinuation of study drug. There were no treatment-related serious adverse events. TEAEs that were deemed related to study drug were mild to moderate and mostly falling into the GI system organ class of MEDRA. This brings me to where we are today, which is our phase 3 pivotal restorative VE303 trial. This is a global study being conducted in 23 countries across 5 continents. We started it last spring, and it is ongoing. Here you see the study design. It's very similar to the phase 2 study. As Dr. Nicholson noted in her talk, we are currently recruiting participants as young as 12 years of age. The study is being done in 2 stages. The first stage, which I noted was up and running now and enrolling subjects, is for recurrent C. diff patients. After successful treatment of the qualifying recurrent infection, participants are randomized in a 2-to-1 ratio to either VE303 or placebo for 14 days of treatment. And then they are followed for recurrences for an additional 24 weeks. The primary endpoint is recurrences at 8 weeks. Of note, in the blue bubble, participants who have an on-study recurrence during the observation period are eligible to receive open-label VE303 for 14 days and are followed for the same additional 24 weeks to observe for any recurrences of C. diff. Just a word about the qualifying C. diff infection. You just heard Dr. Cohen talk about the importance of identifying a true C. diff infection, and we're following the recommendations of the US and EU societies to identify our C. diff infections in the for qualification into the trial and also for on-study recurrences. We're very hopeful that our phase 3 program will replicate the encouraging phase 2 results that I showed you, and that we can bring VE303 LBP to market with all of the advantages shown here that an LBP can have to offer, such as pure derivation from pure clonal cell banks, fully consistent products across the production lifetime of the product, and oral route of dosing with a very, very good effect on efficacy on the recurrence rate. And on this slide is a QR code that you can scan to look at our trial as it's displayed in clinicaltrials.gov. And I've also provided some contact information in case you have further questions about the trial for us, both me and my colleague, quinned in. And with that, I'd like to thank you all for your attention. And again, thank you for allowing us to present this at this scientific symposium.
Steve, thank you so much. Good to see you. And it was good seeing you at the gala last week also. So, really, really exciting information with regards to VE303 and potentially that next generation type of microbiota restoration therapy or a true live biotherapeutic product. I want to shift gears now to another really exciting product coming from AstraZeneca. And now we have Dr. Anne-Marie Stanley. She's going to be here to talk to us about AZD5148. All of us are familiar with the vast number of offerings from AstraZeneca. Dr. Stanley is a director of translational medicine, early vaccines, and immune therapies. Dr. Stanley, looking forward to hearing your discussion on AZD5148.
Yes. Thank you, Paul, for the introduction. I also want to thank Stephen for switching slots with me while we sorted out some technical issues on our side, since we don't have any hardwired Ethernet options left here anymore here at AstraZeneca. But I also want to thank Christian and the Peggy Lillis Foundation for organizing such an engaging symposium and for the opportunity to present today. As Paul mentioned, I'm Anne-Marie Stanley. I'm a director of translational medicine at AstraZeneca. And if we can go to the next slide, these are the disclosures for myself and my co-authors for the presentation today. We can go to the next slide. I'm part of AstraZeneca's Vaccines and Immune Therapies team. And for those of you who may not be familiar with the VNI unit, our therapeutic area takes a complementary approach to developing therapies for infectious disease, both working to develop differentiated vaccines as well as developing highly targeted antibodies for indications where vaccines may not be available or for populations who may not respond to vaccination, and are doing this for both viral and bacterial pathogens. And so today I will introduce to you the monoclonal antibody that we are developing to combat C. diff infection. So if we can go to the next slide, please. The information on this slide on burden of disease will be very familiar to many members of this audience, and you've heard much more about this from Alice and others on the call today. But I want to emphasize that although there have been a number of developments and new products in this area, many of which you've also heard about today, there's still a significant unmet need. Once people experience an initial infection, it's still anticipated that 1 in 6 individuals will experience recurrence following antibiotic treatment. There's also still an unmet need for early prevention, with recent late-stage vaccine trials failing to meet their primary endpoint. And although some of the epidemic strains like RT027 appear to be decreasing in prevalence, other hypervirulent strains like RT078 continue to be prevalent, and new ribotypes such as RT955 continue to emerge. So to address this need, AZ is developing AZD5148, which is a monoclonal antibody targeted against toxin B. So if we can go to the next slide, please. As you've heard today, toxin B will normally bind at a receptor at the epithelial surface. And then following endocytosis and acidification of the lysosomes, the toxin undergoes a conformational change, and that GTD domain is cleaved and released into the cytosol, where it can inactivate the Rho family of GTPases. This leads to epithelial damage, subsequent inflammation, and the diarrheal symptoms characteristic of the disease. However, AZD5148 can bind a conserved epitope in this GTD domain. This prevents the cleavage and delivery of the GTD domain into the cytosol, preventing damage to the intestinal barrier and the associated symptoms of the disease. So if we go to the next slide, you can see that this is an overview of some of our key preclinical data for AZD5148. So in the panel on the left, we're looking at the epitope conservation. The box at the top of the left panel is a heat map that shows the alignment of AZD5148 epitope in over 9,000 sequences of human isolates. So where the plot is black, the amino acids are the same as our reference sequence. And as I hope you can see, there are very few changes across the board here, except in the small cluster of sequences at the top of the plot for strains belonging to clade 4. Overall, the conservation is greater than 95%, And if you look specifically at the 7 binding residues, the touch point residues that make the contact between the antibody and the toxin, the only change that is observed, which you can probably barely see on the slide, is a substitution at Y323H to a histidine residue, which is seen only in about 3% of sequences in this very large database of sequences. So in the middle panel, now moving to the middle panel, we've also tested the ability of the monoclonal antibody to prevent the toxin-induced cytotoxicity. We use toxin from a number of different ribotypes, different C. difficile strains, including both prevalent ribotypes and others of clinical concern. With the exception of the one toxin, the one ribotype that has the Y323H substitution, AZD5148 demonstrated very potent neutralizing activity with IC50s in the nanomolar range. Now, if you look at the final panel, this is data from a mouse model of C. diff. It's a prophylaxis model, so mice are, after antibiotic treatment, given AZD5148 before they're challenged with C. diff spores. The top panel on the right-hand side is looking at weight loss from diarrhea following the C. diff challenge, and the bottom panel is in survival. And in this case, we could dose as low as 0.1 mg per kg and still see protection from the C. diff challenge, both in terms, both in terms of the weight loss and also in the bottom panel, a statistically significant increase in survival as well. So we think we have a very potent and potentially best-in-class antibody. If we can go to the next slide. We have also tested AZD5148 in a germ-free piglet model. The pathophysiology of this model more closely resembles the human disease from C. diff than some of the other models that are used, but it's a very challenging model to work with. But in this case, it's also a prophylaxis model. So you have piglets that are delivered by C-section. They're then placed into a sterile chamber where they're fed Similac formula. After about 3 or 4 days, again, they're administered our monoclonal antibody, and then the following day challenged with C. difficile spores by oral gavage. And then they're monitored for a variety of clinical observations, as well as other measures, including body weight, colony-forming units from rectal swabs, observed for rectal prolapse. Their diarrhea is scored 3 times daily, and blood samples are taken over the course of the study as well. And what you can see on the right-hand side of this slide is the diarrhea scores, both on day 3 and day 7 following infection. And in the top panel at day 3, in the left-hand side in the black dots, this is a control animal that's been challenged with C. diff, but given a monoclonal antibody that does not interact with C. diff or the toxin. And on the right-hand side, the black dots are an uninfected control group. And what you can see by day 3 is that the piglets are starting to develop diarrhea. And then by day 7, you can see that this is much more severe, but that in all cases, in all concentrations of AZD5148 that were tested, there's a statistically significant improvement and reduction in the severity of diarrhea that is seen, both compared to the control group as well as to the Beslow comparator shown in blue. So if we can go to the next slide, please. In addition to looking at the severity of the diarrheal symptoms in the piglet model, at day 7, the colons are also harvested to look at both gross pathology of the colon as well as the histopathology following H&E staining. And so again, here on the left-hand side are control groups where the animals have been challenged but given a control IgG. And the gross pathology score is actually a composite score of 6 different metrics. So 0 to 6 is considered mild, signs of mild disease, 6 to 12 is considered moderate, and anything above 12 is considered symptoms or signs of severe disease. And what you can see here is that many of the control animals actually are up in that severe disease group, whereas pretty much all of the animals treated with AZD5148 show only mild symptoms of disease by gross pathology, and some show none at all. And again, this is statistically significant between the control IgG and even the lowest dose of AZD5148. And there's also a significant difference between AZD5148 and the Beslow comparator. So on the right-hand side of this is the histopathology and some representative images. So if you were to look at the images on the right-hand side, you'll see both in the control IgG and in the Beslow group, significant expansion of the lamina propria and infiltration of inflammatory cells. If you look on the left-hand side of those 4 images there, you will see that there's it's very mild, the expansion or any changes in the lamina propria and the AZD5148 group, and that the barrier is still largely intact. And then this is represented by the histopathology scores in the graph in the middle of the slide, where again, you see statistical differences at all doses that were tried for AZD5148, both compared to the control IgG as well as to the comparator, to the Beslow group. All right, if we go to the next slide. So with this promising preclinical data, AZD5148 has now entered into clinical development. There are 3 studies that are currently ongoing. The first is a standard dose escalation phase 1 study in healthy volunteers. This is to look at the safety, tolerability, and pharmacokinetics of AZD5148. We also have a phase 1 study that is now currently running in Japan that's just started enrolling. It is also a safety, tolerability, and PK study. And then the last study is a little bit different. This is a non-interventional observational study that we are running. Clinical trials in C. diff are very challenging. These patients are, acutely ill during their episodes, and we want to ensure that we have the best sort of clinical designs possible when we enter our pivotal studies, with a focus on patient centricity and making that, hopefully minimizing the burden on the patients as much as possible. So the observational study is geared at evaluating various aspects of the logistics and study design to prepare for these future pivotal studies. And this also includes evaluation of the methods of collection, transport, and testing of the stool, which can be quite a challenge when you have a bioreactive and variable matrix like stool in the context of a clinical trial where you would often prefer to do central lab testing. But we're very excited to have this molecule in the clinic. And if we can go to the next slide, just in summary, just to highlight that AZD5148 is a monoclonal antibody that's targeted against the GTD domain of the C. diff toxin and binds a very highly conserved epitope. The AZD5148 prevents cytotoxicity in vitro and also protects in a mouse model of C. diff. AZD5148 also prevents development of severe disease in the germ-free piglet model of C. diff infection as well. And again, we're very excited that AZD5148 is in clinical development for the reduction of, we're headed to an indication for reduction of C. difficile recurrence. And if we can go to the next slide, I just want to thank the many, many people who have been involved in getting this molecule into the clinic, including our global product team, as well as all of the individual clinical study teams. It takes a lot of work to do the clinical development, as well as my colleagues in early vaccines and immune therapies, as well as many of our external collaborators as well. And with that, if there's time, I'm happy to take any questions. Oh, Paul,
Thank you so much, Dr. Stanley, for your insights. That was tremendous, and I think I'm also just equally excited to see the practicalities behind your initial study here, and then ultimately what the data looks like with regards to how the product works compared to placebo. The future is incredibly bright, and I want to thank AstraZeneca also for their pushing forward new products for our patients with C. difficile infection.
Yep. Thank you, Paul.
Awesome. So now we're going to shift gears. We're going to go to a company called Crestone. Crestone is a clinical stage company focused on developing small molecule drugs for serious bacterial infections. One area of focus of theirs is C. difficile, and they have a product called CRS3123. This is a small molecule protein synthesis inhibitor. Today, we have Dr. John Bruss. He's the Chief Medical Officer from Crestone to provide us with an overview. Welcome, and thank you so much for being here.
Thank you very much. Thanks for having me. And many thanks to Peggy Lillis Foundation for holding this symposium. It's been fascinating today, and I've really enjoyed all the lectures. I'm going to present some information about CRS3123 from Crestone. I'm an infectious disease physician. I've been in clinical development of antibiotics for over 25 years and have worked for Upjohn and Pharmacia and Pfizer and Achaogen and Theravance and Spiro Therapeutics, and probably consulted to many more than that. So I've been consulting for Crestone over the last few years and helping them get this product into clinical development. So why don't we go to the next slide. And as mentioned previously, CRS-3123 is a narrow spectrum agent for the treatment of CDI, and it is in clinical stage now. And so I'll go through some of the background information and then some of our recent clinical findings. Next. And as you know, there's been many lectures today, and I won't go into detail, but CDI is really, truly still an unmet medical need. There's been a lot of development activity over the years, but clearly we need more therapeutics. I'm very excited about some of the new therapies around fecal transplants and microbiome replacement therapy, but we still need small molecule drugs. Next slide. And antibiotics still remain the frontline treatment. And then, you know, obviously we are starting to embark on replacement or restoring the microbiome. But I think killing Clostridium difficile remains a very important part of the therapeutic regimen. Next slide. So CRS-3123 is a small molecule. It's fully synthetic. It's non-systemically absorbed, so it is an oral compound, but it stays in the gut. So it's ideal for treating GI tract and specifically GI tract infections. It has excellent potency against Clostridium difficile with an MIC of 1 microgram per mil. Its activity against hypervirulent strains is the same as non-virulent strains. So, and it's specific, has activity against ribotypes 027 and 078. It's very narrow in its spectrum and high specificity for C. diff. So it is a novel mechanism of action. It's an potent inhibitor of methionine tRNA synthase. And because of its target here, it inhibits growth of the pathogen, it inhibits the toxin production, it inhibits spore formulation. There is no pre-existing resistance and no induction of resistance to other antibiotic classes. So it's uniquely positioned for the treatment of C. diff. Next slide. This is a diagram that shows methionine tRNA synthase. There are two main types for this enzyme, type 1 and type 2. I'll go through the type 2 first, which are not susceptible to this agent. And so most of the anaerobes in the gut and also key regulatory bacteria like bifidobacteria and Bacteroides and Lactobacillus, and also the gram-negatives. It doesn't target any of those gram-negatives. If you look at type 1 on the top, it is very specific in the pathogens that it does target, and C. diff is prominent among those. It is interesting that it also has activity against Enterococcus, both Fecalis and Faecium. And so, you know, this may be kind of an important collateral in certain patient populations that may have CDI. Next slide. These are some structural images of the enzyme itself. And if you look at the top, you can see type 2, and you can see that the molecule does not fit very nicely into the pocket of the enzyme. If you look at the bottom right image, you can see that CRS-3123 fits very nicely in a MET-RS pocket there, and you get nice conformational change. Next slide. This is just a comparison of some of the mean inhibitory concentrations for various agents. metronidazole, vancomycin, fidaxomicin, and ridinilazole. You can see that, and CRS-3123 is on the far right. So for all of these bacterial groups that you have off on the left-hand side, you can see that, well, all of these agents, first of all, are fairly active against C. diff. But if you look at the CRS-3123, all of those bacterial groupings, there's either no effect or very high MICs. So it is not active against those, and therefore there's a good foundation for the preservation of the microbiome. If you look, metronidazole obviously has a huge impact on the microbiome, but so does vancomycin. Fidaxomicin is a little narrower in spectrum, but not nearly as narrow as CRS-3123. And then ridinilazole is improved over fidaxomicin, but still there's some pockets there, or some holes where it has activity against some of these key bacterial groupings. But you can see that CRS-3123 is very narrow spectrum. Next slide. This was data that has been done to look at, this is after 10 days of BID dosing in healthy volunteers in our phase 1 MAD study. And this is looking at the gut microbiome in these normal healthy subjects. And the key takeaway here is at both 200 milligrams twice daily and 400 milligrams twice daily, there is very little disturbance of the microbiome. There is some shifts, so we see some minimal changes at 200 milligrams, some minimal to modest changes at 400 milligrams, and then a little bit more change at 600 milligrams twice daily. But there were no loss of any of the major phyla. So yes, we saw some shifts, but there were no losses of any of these major phyla groups. Next slide. CRS-3123 exhibits key attributes for optimal CDI therapy. If you look on the left there, that's an in vivo hamster model of infection that's pretty routine. And this is comparing CRS-3123 to vancomycin. So if you see the untreated controls, there is a very rapid mortality and complete mortality. And then with vancomycin, there is some survival out to 14 or 15 days. However, you eventually get nearly 90% mortality with the vancomycin, whereas with CRS-3123, you have very high survival rates above 80% in this hamster model. If we look at CRS-3123 from the SAD-MAD studies in humans, you can see there that the concentrations, which are in blue dots with a mean concentration there with the line. And then there's a gray area, which is the mutant prevention concentration. And also at the very bottom, it's just above the bottom of the graph, is the mean inhibitory concentration. So you can see that the concentrations in stool for CRS-3123 are very, very high. So, I didn't go through the adverse events in the phase 1, but all of them were mild. There were no serious adverse events. Has low impact on the gut mucosa and has very high intragut concentrations. And these are more than 1,000-fold greater than the MIC and more than 10-fold higher than the mutant prevention concentration. Next slide. So these are some of the attributes of CRS-3123 and really contribute to our decision to advance this further from phase 1 and into phase 2. So it is a novel target. It's extraordinarily potent against C. diff. It is active against hypervirulent ribotypes. There is no pre-existing resistance. It's very selective inhibition of C. diff. It allows gut flora to not only recover, but it doesn't have impact on the gut flora, and it mitigates dangerous spiral of multiple recurrences. And we'll show you a little bit of our early data. And there's a possibility of reduction in disease severity because it is a protein synthesis inhibitor. And if you see a reduction in toxin, you may have the ability to decrease severity of the disease. It halts spore formulation, so which may be both important for transmission, but also spores may have a role to play in recurrences as well. Next slide. So we embarked on a phase 2 study. So it was a small phase 2 study. I can assure you that if you are faint of heart and doing clinical trials, you should not embark on a clinical trial during a global pandemic. It is very challenging. C. diff is a challenging indication as it is, but conducting this during a pandemic was very challenging. We didn't anticipate that, but we did manage to get through it and complete the trial and get enrollment. So the study endpoints, obviously, to assess the safety and efficacy of 3123. So the rate of clinical cure at test of cure, which was 2 days after the end of therapy, as really specified by the FDA in their guidelines. We're looking at an overall assessment of safety and tolerability of CRS 3123. And then we had a number of secondary endpoints. I've listed a couple here, but we're looking at both rate and time. So clinical cures, total relief of symptoms, early and late recurrences, and global cures. Also the time to resolution of diarrhea, early and late recurrence, and global cure. And we also were looking at plasma concentrations. We did do some exploratory analysis as well, and we're looking at biomarkers of inflammation to also look at the effect on the microbiology and specifically the microbiome, as well as metabolomics. So those, we have completed the study, and some of those are off in specialty laboratory. We're awaiting some of those results. Next slide. So eligibility, this was an adult study. We conducted this study in the US and Canada. We allowed patients coming in with a first episode or a first recurrence of CDI. They had to have greater than 3 diarrheal stools with a Bristol stool score of 5, 6, or 7 in the previous 24 hours prior to randomization, and really had to have C. diff in the judgment of the investigator. The stool had to be positive for C. diff toxin A or B. We were not allowing patients to come in on a PCR alone. They had to be toxin positive. And this could have been either through any one of the FDA or Health Canada approved EIA or ELISA tests, but they had to have that before randomization. Patients were randomized 1:1:1 into one of 3 treatment groups. Treatment arm A was CRS 3123, 200 milligrams twice daily. Treatment arm B was CRS 3123, 400 milligrams twice daily. And then, I'm sorry, let me go back. And then vancomycin was 125 milligrams 4 times a day. So we did have, because it was a double-blinded study, we had placebo capsules in there to mimic the 4 times a day that vancomycin was being delivered. This is a study schema, so you can see the screening period there. And this is where we determined that they had CDI and that they were toxin positive, and then they could come in, be randomized. And then the treatment period, you can see the 3 treatment groups there. This was a 10-day therapy, so we didn't really allow for a window of therapy. It was 10 days of therapy. And then our test of cure was 2 days, at least 2 full days after the end of therapy. Then we had follow-ups on day 20, 27. We did have a long-term follow-up on day 40 and a very long-term follow-up on day 70. So I'll give you some very high level. This data is just rolling off, and we are just getting this data. We will be we have a press release out, so some of this data information has already come out in the press release. I won't go into great detail because we will be presenting this at probably at ECCMID in the next few months. But I wanted to give you an idea of what we're looking at here. So we have a clinical cure at the test of cure visit in the primary analysis population, which was the intent to treat. We had a cure rate for when we combine both of those CRS 3123 arms together of 97%. We had a high rate of cure in vancomycin, which is consistent with vancomycin. It's pretty good at treating. It does have a higher recurrence rate. But I think the positive takeaway here is these were all patients with significant clinical disease that were toxin positive, and we were able to get a fairly high cure rate. There were 2 withdrawals and no clinical failures at the test of cure visit. The rate of recurrence by day 40 for the combined CRS 3123 treatment groups was 4% compared to vancomycin at 23%. And this is consistent with the literature of recurrences for vancomycin. CRS 3123 was well tolerated. There were no serious treatment emergent adverse events. We did have a number of mild adverse events, but clearly the drug was very well tolerated. And that's really about all of the clinical data that I can show you on phase 2. We will be presenting a more in-depth presentation at an upcoming meeting, and then hopefully have a full publication on the trial. We were very pleased, even though it was a small trial and conducted during a pandemic, that we were able to finish this trial and really demonstrate that CRS 3123 has some promise and will advance into phase 3 testing. I do want to acknowledge that this trial was funded by NIAID, and we were very grateful to be working with them as partners. We also thank Ron Evans for expressing and purifying the enzyme, and Doug Davis for solving the 3D crystal structures. So with that, I think that's the last slide. I'd be happy to take any questions if people have any.
John, thank you so much. I don't think we have time today for questions, but super exciting results. And I mean, the phase 2 data, I'm really looking forward to seeing the full abstract and then hopefully manuscript to come in 2025. But such an exciting time for you over at Crestone.
Yeah, thank you very much for the opportunity.
Thank you so much for being here. So next, we're going to reintroduce somebody who presented earlier, Dr. Sahil Khanna. Sahil is a professor of medicine at the Mayo Clinic in Rochester, Minnesota. He is here now on behalf of Probiotic. Probiotic USA is a company whose strategic goals are focused on bringing combined synergistic live biotherapeutic product and antioxidant microbiome biotherapeutics to a global prescription market. Sahil is going to be discussing the next generation of LBPs. Sahil, thank you for coming back and being here again.
My pleasure. We started the day today mentioning the word metronidazole. We talked about vancomycin, fidaxomicin, fecal transplant, live biotherapeutics, and today I'm very excited to talk about where are we going next with bacteria-based therapies or live biotherapeutics. And the title is The Next Generation of Prescription Live Biotherapeutics, taking beneficial bacteria from what's today considered as foods to in the future would be considered as therapeutics. I've been very fortunate. I've been associated with Probiotic since about 2017. They've had a phenomenal journey from a concept to a prototype to patents and now preclinical data and going on to the clinic. They've been at the forefront of innovation, and I should say we've been at the forefront of innovation with Probiotic. I I'm a consultant for them. I get paid for my time that I spend with them. And we're developing defined microbial consortia where we know functions of each of these bacteria, their metabolites, what their benefits are, and how can we now make sure that they live and survive into the environment in the human body. And products are currently being developed to prevent recurrent C. difficile, treat inflammatory bowel disease. And I'm really hopeful that this is the next frontier where we can lead and change the field going forward and forever. Paul briefly mentioned the strategic goals of probiotic. We've developed them together. They're focused on leveraging the synergy between proven live biotherapeutics, defined bacteria, and antioxidants. And that's the differentiator here, that if you add antioxidants to live bacteria, perhaps we think we can improve how they work, how they grow, and get those live bacteria from foods to prescription. We're working on harnessing the safety and efficacy of what's out there by all of these patient exposures to these bacteria in the food and supplement sector, and then channeling that data into new prescription medications, translating the research and real life evidence of benefits of these therapeutic products into not only oral, but oral, rectal, and vaginal products to help a myriad of diseases. There is scientific evidence that's out there that we can combine live biotherapeutics or defined bacterial compositions with antioxidants, and that increases their potency against infections, against pro-inflammatory states, as we see within inflammatory bowel disease. So what are the products and how do they look like? This is a patent-protected technology that we have at Probiotic, which is innovative, and the delivery mechanism, and I'll talk more about it, leads for us to combine these live biotherapeutics and antioxidants and deliver them at targeted sites within the intestines through oral ingestion, through rectal, or also through vaginal ingestion. And the active ingredients, and I'll share some of those today, have demonstrated some efficacy in GI, urogenital, dermatological disorders, targeting the systemic mediation of inflammation that we see through the gut into the rest of the body. All right, two different kinds of products. There is an oral capsule, and if you follow this is timed local release of ingredients. There is an inner capsule that has live bacterial strains that are cultured from cell banks and then freeze-dried for sterile storage. And they are released after the outer capsule, which has antioxidants. So the way this works is the antioxidants are released first, and they change the local milieu. They work on the mucosal lining. And when the inner capsule is released, they boost the growth of the bacteria, and we hope also will help with colonization of these bacteria into the intestines. There's also a suppository form where the outer suppository layer for rectal administration contains the same antioxidants as the outer capsule for the oral administration, and there is an emollient for self-lubrication. As we've heard today, that when you are developing live biotherapeutics, perhaps both oral and rectal administration are important in different disease states, including in C. difficile infection. Probiotic has had patents that have been granted across the world in the United States, Europe, and Australia, and there are several other patent pending applications. And the patent is for the dual compartment products to deliver sequentially, first the antioxidants and the live biotherapeutic that's within the inner capsule. This dual release mechanism is believed to optimize the mucosal environment for integrating the live bacteria that are delivered into the colon or the upper intestine or the vaginal region. And we think that this enhances the potency of live biotherapeutics and also differentiates it from what has traditionally been called as probiotics in the food industry, where they are just bacteria and can maximize the therapeutic potential that we see for these bacteria. As we do with any new product line, safety is critically important and is important to the company itself, as we are now combining live biotherapeutics within antioxidants. When we did a survey with key opinion leaders, there is evidence and belief out there that lactobacilli bifidobacteria are very safe. They have been in foods, they have been in supplements, they have been in probiotics, and the exposure is a lot. This bacteria-based food products are exposed to millions of people every single day. We did develop these target profiles with surveys from key opinion leaders, and these probiotic strains have been safe in the literature and also have been safe within the survey data that we have and trusted by patients. Now, we just didn't take bacteria and start thinking we were going to put them in humans. We have done some preclinical lab models. The data that I'm going to show today right now are not published and are proprietary at this time. We did some lab models where antioxidants that we have within our capsules, they were synergized with Live-brpk, and there were in vitro models of human colon that we studied. The antioxidants, they boosted the levels of the bacteria and how they grow, and I'm going to show them in the next couple of slides, both lactobacilli and bifidobacteria. And also there was production of short-chain fatty acids, which we now understand that it's very important for overall health. Acetate and propionate were the other ones that we saw went up. And we did some C. difficile models, which is very dear and close to my heart, and saw some C. difficile counts and toxin production were decreased in vitro. So these are some data. Follow the left graph with me. The y-axis is toxins, and the different colors are the different time points that we have. 3 bars here are control, bacteria alone, and bacterial and antioxidants. And when you co-culture C. difficile with just by itself, you see high toxin production in the in vitro colonic model. You add the bacterial species from the blend that we have that tones the toxin down. But then when you add the bacteria and the antioxidant put together, we hardly saw any toxin being produced. Follow the graph on the right side here. Again, the 3 sets of columns are control, the bacteria, and the bacteria plus the antioxidants. And you can see with control, with time from 0 hours to 24 to 48 hours, C. difficile tends to grow within the colonic model. You add just the bacteria, it still grows, perhaps doesn't produce as much as toxin, but when you add the bacteria and the antioxidant, you don't see growth of C. difficile from where we started. And that's where we think that putting the bacteria and the antioxidants together not only attenuates toxin production, but also attenuates the growth of the C. difficile bacterium. With this, we've also completed a preclinical, I should say a clinical phase 1 pilot study of rectal products in healthy individuals, looking at tolerability and safety. I'm not showing the data here, but all I can say is we saw lots of positive results from that tolerability and safety studies. There's an orphan drug application submitted for C. difficile for this particular product to the FDA, and including an IND that's been submitted to start a clinical trial for recurrent C. difficile prevention. Again, remember, this is different from traditional live biotherapeutics, where this is not donor-derived. These are all bacteria that are cultured within the lab and put together with antioxidants, so it can be produced at scale, and the safety concerns are much lesser than donor-derived products. This is the team that I'm blessed to work with on a day-to-day basis. Deborah is our fearless president and CEO. Brenda is our chief scientific officer. And then we've got Emilia, who's the vice president of the regulatory affairs. Paul Feuerstat, who you all have known all of day today, has been a consultant to the group. And then we've got Rob Britton, who helps with some of the lab experiments that we do. Jonah is our consultant for pharma. And then we've got other regulatory consultants. Bill remains also a consultant to us, and James is the legal counsel. So with that, in a nutshell, there are now being developed innovative products for time release, antioxidants, bacteria put together. We have the ability to manufacture and learn from oral, rectal, and vaginal administration. There can be many therapeutic targets, and always happy to collaborate with others who are interested in further co-developing this and understanding the science. And hopefully we take the clinical impact of these to GI and other inflammatory disorders also. I'm going to leave this message from Deborah, who's our CEO, out there, and take any questions going forward.
That's great. We can give it a second, see if we get any questions, and let people read this lovely message from Deborah, who I'm looking forward to meeting at some point. Any questions, folks?
Kristen, when I talk about something like this to people, one question that comes out is, how is this different from a traditional probiotic that I can just get off the shelf? And I think the big difference is, one, the manufacturing process of the bacteria itself, how we preserve the viability, make sure they don't have endotoxin in them. The second difference is the dual delivery mechanism, where you've got the antioxidants within the capsule itself that help preserve not only the viability, but also the function of those bacteria, and then allow them to grow in a completely different hostile environment, which is the colon, the large intestine. More to come on that, and see how this can then influence a disease that's close to your heart and my heart, which is C. difficile, get this to more patients, more people, but then also try to see how we can get live biotherapeutic products to people for other disease entities, which I'm sure you get a question every single day of your life. I want an antibody for X, Y, or Z condition. We're not there quite as yet, but can we define bacteria that have these functions, put them with antioxidants, which are, in lay terms, the food for the bacteria that they need to grow and survive, put them together and help modulate disease?
Yeah, I totally agree. And I think the microbiome is such an exciting, I think, we've just scratched the surface of what the possibilities are going to be here. And obviously, like, you and I both know how important it is to have anti-infectives, antibiotics, antifungals, but, to the extent that we can rebalance things and bring things back into order, I think is very exciting for the future of our health overall. So I want to thank you so much, Dr. Khanna, Sahil, my friend. You did double duty today. And thanks for ending with that great, fascinating presentation from Probiotic USA. So I will let you go. So much appreciate Dr. Khanna. And we're kind of done. So I just want to thank again all of our speakers who provided fascinating information about the present and future of C. diff treatments, prevention, infection control. We really ran the gamut. I want to thank the Hatches and Michael for giving such crucial insight into the patient experience. An outstanding 440 people registered for today's symposium. Our goal was 250, so we almost doubled that. I want to thank again our platinum sponsor, AccuRx Pharmaceuticals. Thanks to our gold sponsors, Nestle Health Science and Recursion. Thank you to our silver sponsors, Probiotic USA, Tech Lab, and Vedanta. And also thanks to our bronze sponsors, AstraZeneca, Back to Life, Crestone, and Luma Bioscience. So much exciting stuff, so many new things on the way. I said it earlier, I'll say it again, have never in 15 years seen this much being developed around C. diff at the same time. It gives me enormous optimism. I think this was a great start, and we look forward to growing this event and hopefully having all of you join us again in 2025. So have a great rest of your day.